All right. Good morning. Hi, everybody. We're really going to get started this time, which is not too bad. First, I want to say thank you so much for joining us. Welcome to the 2025 National GVHD Symposium. It is genuinely an honor to convene here today, both virtually and in person. We are united by our shared commitment to progress GVHD research and care and advocacy. And the hosting of this symposium by the James at the Ohio State University is, we could not have done this without them. And so thank you, we greatly appreciate it. At the heart of today's event is the mission of the Meredith A. Cowden Foundation. We want to increase the number of blood and marrow transplant survivors, raise awareness of transplant complications and late effects, and reduce their impact. The foundation is dedicated to empowering survivors and families by connecting and educating healthcare professionals and the public, as well as supporting programs to improve post-transplant quality of life. And this day exemplifies our commitment, bringing together clinicians and researchers, patients, and advocates to share all of our knowledge, develop hope, and move forward with innovation. Deep gratitude goes to our organizing committee, our presenting experts, our generous sponsors, and especially our attendees. The Cowden Foundation Committee has shaped a program that I think is going to be so insightful and provide us with a lot of really good information and ways to move forward. And your participation is crucial so that we can collectively advance awareness, prevention, and treatment of GVHD. I'm going to quickly go over the schedule of the day. So in the morning, we're going to have parallel tracks. And so if you're interested, I can't see any of you. Okay, so if you're interested in the scientific tracks, they will be in this room. If you are interested in the patient and caregiver tracks, they will be across the way in the Scioto room. If you get lost, I'm really sorry. Like, I don't know how. I feel like you'll figure it out. So this morning, what we have are some fantastic presentations. Over here, we're going to have a case presentation. And then across the way, there's lifestyle medicine, there are nutrition interventions, neurocognitive care, late effects, with leadership from experts from UPMC and UC Health, The Ohio State University, and Memorial Sloan Kettering. And then during midday, we're going to have, it's sort of like a group of things together. So we're gonna, the people in the patient sessions are gonna come back over here, and we're going to have our keynote presentation by Dr. Andrew Harris, as well as a panel for Q&A. You have very large pieces of paper with a lot of space for questions. So please think of questions as they come, write them down. And if you could have those to us by 11:30-ish, please turn those into that table over there. Keen is waving. Yeah. And so that's going to happen during the middle of the day, and then we're going to end the day with lung and oral GVHD, rehab strategies, and a sound bath. So the lung and oral GVHD will be in here, the rehab and sound bath will be across the way, and then what we're going to do is finish things up, and then we're going to drink and eat, because why not? So I want to say to our virtual attendees, please make sure that you follow the instructions that you received for participation in the Q&A sessions. We're going to have somebody manning the chat, and so if you type in your question, it will be, we'll make sure that we get to it. If we don't get to it live, then we'll make sure that we're able to answer it later with follow-up. And we really appreciate the fact, I know that there are two different links, and so we appreciate the ability to bounce back and forth and have flexibility with that. As we move through today's sessions, I feel like this is an Irish toast, because I wrote it out like, may our conversations and collaborations honor, it just feels like an Irish toast. Like, as you slide down the banister of life, may the splinters never point the wrong way, But so in this case, that is true, please. And also, like, hopefully our collaborations and our conversations will honor what it is that the Cowden Foundation and my father specifically have worked so hard to develop, which is building a future in which survivors thrive, knowledge grows, and the impact of GVHD is diminished. Thank you again. Marcos, do you want to say anything? Or you want to wave? Just wave. Okay, cool. Okay, so, okay, I know. Okay, so with that, I'm going to turn things over to Marcos, and then we're going to get started. Thank you so much.
So good morning. My name is Marcos de Lima, and I work here at the James. But I'll tell you, those who know me love that I love to tell a story. So before I do that, though, this meeting is not quite the same without Jerry and Marty here, right? I mean, are they online? They should be. Hey, Jerry. So 2012, I moved from Houston to Cleveland. And I got to Cleveland, and they told me, you know what, there is this foundation. It's a couple here whose daughter has been involved with this and for a variety of reasons. And she met Kalaisho at the Cleveland Clinic, treated her. Why don't you go talk to them? And so I did, and found out that this was and still is the only such enterprise in the United States. A foundation dedicated to this, from the outside, a rare complication of transplant. For us here, not rare, right? But if you look at, 300 million Americans, this is like an alien planet, right? And has been through advocacy like this that industry, academic centers, out there, clinics start paying attention to this. So this is vital, right? Vital, because we know that if we don't make noise, you are ignored, right? This is how society works. And so I came to admire this couple, and I admire Meredith very much so. So this was 2012 for me. For you, when was founded, when the foundation was created? I forgot. 2007, so I came late to the game. But since then, this is why we're doing this here, right? Because of this connection and, obviously for the topic, it's very dear to us and obviously, so anyways, so that's the story. And finally, I want to welcome all to Columbus and all those who are already here. And thanks for coming, because we have several of our patients here, and this is the reason why we do what we do, right? So thank you all for coming. So let the games begin.
So now what we're going to do is, I wanted to make a note really fast because I thought it was funny, and also I was like, that's so wrong. So we're going to start off this first session with how I treat chronic GVHD in the scientific space, and then across the way, Dr. Golubic is going to be speaking about lifestyle medicine. And I will say for the how I treat GVHD session, it is not my specific medical advisory group. Foundation, it just says the Meredith A. Cowden Medical Advisory Group. And so I just wanted to clarify, it's not my personal team. Yeah. So with that, have a great day, and thank you so much.
Oh, perfect. I was like, what's the answer for you guys? We have the podium mic and we have two additional mics. Cool. They're currently muted. To unmute them, you just click the button. Okay. Just so they don't make noise when people come in. So you guys are free to pass those and just make sure you click them first. Yeah. Thank you. And you can take this off if you need a third mic. Okay. Totally up to you. Do you want the podium to the side? Do you want me to just move it over for this? So that you're not blocking, right?
Sure, and then we can just have these.
Yeah, feel free to take that. I can get it for you. Sorry,
And then,
it's tricky.
Sorry, this one's the advancer?
Yep. Oh, you'll want to go, the big green button is forward. There you go.
Okay,
Cool. I'm cheering to the virtual as well. I'm controlling that all in the back.
cool. Hello. Here, grab one. Marcos. Dr. DeLima. All right, well, welcome everyone. I will tell you, I'm Annie M. I'm one of the transplant physicians at UPMC. I'm joined by this esteemed panel. Andy Harris is going to get, is our keynote speaker and is going to get a long introduction later. But two of our other members of several, but two of our other esteemed members are Betty Hamilton, who's at the Cleveland Clinic, and then you just heard from Dr. DeLima, Marcos DeLima. Did I say senior? Esteemed and senior. So Dr. Harris, Dr. Hamilton, Dr. DeLima. And I will tell you that this originally was going to be a talk on infection complications in transplant from a speaker from the NIH. And unfortunately, due to governmental restrictions, we had to pivot last minute. So we thought this would be fun, and we are going to do a case discussion and discuss among this panel some of the complicated topics in chronic GVHD for which we don't have great data, and just hear from our panel about kind of different practices. So I'm going to keep us on time. I'm going to make sure we end on time. So I might rush through some of these things to get to some of the meatier questions. I should also, yes. Okay, so just real quick, this is a 57-year-old male. He was diagnosed with AML. It was FLT3 ITD mutated, NPM1 mutated. He had CNS involvement at the time of diagnosis. He underwent induction and had some complications during induction. He underwent HiDAC consolidation, also some complications, as you can see. But ultimately, he underwent a matched unrelated donor, peripheral blood stem cell transplant. Patient donor CMV was mismatched, ABO was matched. His conditioning regimen was with Flu-Bu-4, and his GVHD prophylaxis was with post-transplant Cy, Tacro, and MMF. His transplant course was complicated by one seizure episode. He did have that prior history of seizures. PRES was ruled out. His Keppra dose was increased. So, wanted to start, and we won't spend too much time on this question because there's other kind of good topics to talk about, but, kind of in this era of the evolution of GVHD prophylaxis, we'd love to hear from the panel about what prophylactic strategies you guys are using at your various institutions. And perhaps in addition to that, with that change and with this evolution recently and the changes of the standard of care, how has that impacted either rates of GVHD, characteristics, et cetera? Did I mention all the institutions you guys are from? I didn't. Sloan Kettering and Cleveland Clinic, and then obviously The Ohio State. Anyone can jump in, or we can go down the line, up to you.
I can start as the pediatrician in the room. So I know on the adult side, most centers have, for their unrelated donors, really across the board gone to post-transplant cyclophosphamide for all patients. That really hasn't happened yet in pediatrics. There are some centers that are adopting that. There are others that are not. And there are things we think about in pediatrics that we don't necessarily in our older adults that are getting transplant, like the extra alkylator exposure and potential impact on fertility and growth and development for our patients. So we're still primarily in these settings using calcineurin inhibitors and short course methotrexate as our GVHD prophylaxis. However, in our unrelated donor setting, and then also in our patients that are getting transplants for non-malignant conditions, we're adding in ATG, and we're using population-based PK dosing of ATG that's been shown to really not only reduce the incidence of graft versus host disease, but also increase, based on how we do the dosing of it, the immune reconstitution post-transplant to minimize the risk for infection. So that's really what we tend to do with most of our patients. Now in the cord blood setting, we still tend to use tacrolimus and mycophenolate as our GVHD prophylaxis. And then for our mismatched donors or haplo donors, that's where we tend to use either PT-side or alpha beta T cell depleted, T cell B cell depleted grafts. And that's obviously still a very hot topic of which one of those is going to end up being the best approach going forward in that setting.
Yeah, can I actually ask a quick question before we go on? I actually don't know this answer. Is there data in the pediatric setting for PT-side for matched unrelated donors?
There is some.
Not as robust as adults.
Not as robust as adults, but in the mismatched setting, the two approaches that tend to be used most are the PT-Cy or abatacept. The problem with abatacept was that we saw that while it reduced the incidence of acute GVHD, chronic GVHD rates were not decreased in the slightest. We're seeing very high rates with that. Now, that's trying to be addressed by extending the course of abatacept to see if that can reduce the chronic GVHD incidence, or if that's just going to kick the can down the road and we're going to see the chronic GVHD later. But we're not participating on that study, so we're using PT-Cy preferentially in our patients.
No. So you just reminded me that kids are not just a small adult, yes, right? Yeah. Because the field for adults has changed a little faster than that, right? I mean, in post-transplant cyclophosphamide has taken the field by storm, right? Which brings, for those here who are not exactly in the clinical side of things, or are patients or caregivers, it gives us options, right? I mean, we evolved, if you will, from one size fits all to a variety of settings, which reflects also the fact that we have so many donor options now, which is great, but also adds another layer, right, of complexity, because immune reconstitution becomes more complicated intrinsically because there's so many HLA mismatches, or the combination between these HLA mismatches and then the changes in GVHD prophylaxis. So you don't know even at the end who is who. but the reality is that we live in an era where, when I started doing this, I would see a person of color coming for transplant. And in the vast majority of the times, I would say, no deal. I have no donors. I have no ways to do this. It would simply be impossible because the registry would not find a donor. If not lucky enough to have a donor in the family who was fully matched, you are out of luck. So this has changed dramatically because of these mismatched transplants, and in the United States because of post-transplant cyclophosphamide, so which is great, but it then brings another layer of different stories, which is how to learn to recover this immune system and protect people during that transition and so on. So anyways, but remember, kids are not just small adults. See, I'm well-trained.
I agree with all and just make the couple points that, just like Marco said, PTSI, although it has drastically reduced the incidence of GVHD, particularly severe acute GVHD, it's not perfect. And our field is really is very interested in improving upon that, reducing the doses of Cy, adding other novel agents to it. And chronic GVHD has not been fully eliminated. I mean, we see through our chronic GVHD consortium that, the incidence of chronic GVHD, we're still trying to understand if the characteristics are the same as with traditional calcineurin inhibitor methotrexate, so.
Yeah, well, thank you all. Yeah, I would agree. I would say that for us at our institution, we take pause with myeloablative conditioning in PT-Cy because some patients, it's really tough to tolerate. And so, I'm looking forward to the data that comes out about what's different about chronic GVHD in the PT-Cy era as well, because that'll be very interesting. I think all of us have kind of anecdotal experiences about that, but I mean, I'm interested to see the data. So we'll go on with the case. So this patient ended up having biopsy-proven GI GVHD. He responded to steroids, did fine with that. He was able to taper off that. He did have bone marrow biopsy that was positive for MRD, so he started gilteritinib maintenance. And then during the tacrolimus taper, developed a new skin rash. So again, we started on steroids and was taper off by some reasonable amount of time. That is blank. But responded to steroids and did fine with that. So this is then later on post-transplant. I will say that this case, some of the details have been adjusted for the purposes of discussion. So if you think about it, we weren't using PT-Cy a year and a half ago, right? But just pretend. So a year and a half, 1.5 years post-transplant, he had about 15-pound weight loss over 6 months. He had dry eyes and discomfort in his eyes. So he was referred to ophthalmology as well as our GVHD clinic. You can see his pulmonary function tests pre-transplant, day 100. He had 1 year PFTs, and then you can see at the time of referral what his PFTs looked like. So at time of referral to us in the GVHD clinic, you can see the significant decline in FEV1, and then we did repeat this just to confirm, that this was, just to confirm that this was, a true decline. So, of course, most of us would start him on FAM. What would you do now? Do you start steroids alone up front for all patients? Do you ever consider non-steroids up front? Or is it let's just give him steroids, because that's easy.
Okay, all right. So we typically sort of just making sure that acknowledging a full pulmonary workup, doing a high-resolution non-contrast CAT scan. We oftentimes work with our pulmonologist colleagues to just make sure we rule out infection and other causes. Given, obviously, the constellation of symptoms, as patient seems like they have a diagnosis of chronic graft-versus-host disease, and FAM therapy is, well tolerated and has been shown to reduce the progression of BOS, or bronchiolitis obliterans. I think when available, I think enrolling on a clinical trial is something that we always consider in chronic graft-versus-host disease. There is actually sort of ongoing trials because about not using steroids up front. I think as a field, we all recognize how toxic corticosteroids can be. And in chronic GVHD, the response rates are less than 50% to first line, even though steroids do remain the first line therapy for chronic GVHD. Response rates and durable response rates are less than 50%. So there's a lot of interest in our field to use non-steroid approaches. So I would hopefully offer this patient a clinical trial to study non-steroid approaches. A lot of times in real clinical practice, it'll depend on, this patient has been on steroids before. If this patient had developed diabetes and irritability and all these terrible side effects of steroids, it is a real consideration to minimize the steroid use.
Let me ask you this. Do you, I remember you and Navneet Majhel were doing this proteomics of breath. Where does that stand? I mean, I haven't seen a follow-up on that. I always thought that was so neat. You may want to
Thanks, Marcos.
Have you published this yet,
Making
Betty?
me feel bad about not publishing that paper yet. So what Marcos is referring to is that we did a study where we evaluated breath analysis. I think many people are aware of breath analysis and like a breathalyzer test. So there is some data in being able to detect changes in breath metabolomics in different diseases, like liver disease, inflammatory bowel diseases, and things like that. And so this was a collaboration with our pulmonologists in which we evaluated breath and the changes in a breath signature, more as it related to GI graft-versus-host disease, with the hypothesis that the microbiome changes and bacterial changes lead to changes in the breath signature. We have done a follow-up study where we actually are correlating longitudinal breath samples and stool samples, and the manuscript is currently being written. But in theory, yes, this potentially could be used in sort of the lung setting as well, but has to, obviously be studied.
So I think this is what this sounds like is an isolated pulmonary chronic GVHD case, which is a great opportunity for me, putting my pediatrician hat on, to show some of the limitations and challenges that we have. So if this was a 7-year-old patient, we would be able to get these PFTs and make this diagnosis. But we are very limited in what we have approved in the pediatric setting below 12 years of age or below 40 kilograms, depending on, we talk about as far as additional agents for graft-versus-host disease. So we use a lot of things off-label, but some of the newer agents, there's a lot of challenge in trying to get access to those for these younger children. Thankfully, now we have clinical trials that are getting ready to get underway with some of these newer agents like belumosudil and axatilimab in pediatrics, but they're not enrolling yet. If you back this up from a 7-year-old down to a 3-year-old who we can't get PFTs in, we really don't have any really well-established testing to try to monitor lung function. There's papers coming out looking at, parametric response mapping with CT scans. We have, hyperpolarized 129 xenon gas stuff that's being done out of Cincinnati. And then we have the multiple breath washout testing, which in the most recent pediatric ATS guidelines is being recommended for baseline screening and then at diagnosis, but not a surveillance in between. So there's a big gap there as well. So a lot of centers, unfortunately, are waiting till these patients are symptomatic. And by the time the patients are symptomatic, they've had a severe decline in their lung function. So even identifying lung GVHD, particularly in our young patients, is really, really challenging and a really big unmet need that I hope that we're going to hear a lot about later on. Because I know that we have a talk about that this afternoon that specifically addresses this challenge. But then we look at our treatments right now in pediatrics. The only agents that we have approved below 40 kilograms or 12 years of age are steroids, which really isn't technically approved, but it's widely accepted, and ibrutinib, which we talk to all the pediatric chronic GVHD people, none of us use because we don't think it's all that effective. And our
Adults
patients
don't use it that much either.
And patients tend to feel miserable on it. So unless you can get something off label and you have to get insurance approval for that, we're really limited in our treatment. So up front, it's still steroids for us because we really don't have access to anything else. And we have to really advocate for our patients when we have to move beyond steroids, given the limited options to actually have approval. And this is something that I think that we need to try to figure out how to address on a federal level, getting these younger patients included up front in studies so that way we can learn how to use these drugs safely and then get indications so I have tools in my tool bag that I can use to treat these kids when they present.
Yes. So for all of our industry partners, pediatrics up front. And I'm looking around. I see one pediatrician, but I don't know if there are others. But anyway, so it's really nice to have that perspective because we don't think about these things on the adult side for sure. Okay, so just going on with the case, I want to be respectful of time for our next speaker. This patient ultimately was started on FAM, autologous serum eye drops. He actually had a lot of difficulty with steroids previously for acute GVHD, so really pushed hard against steroids. He did decline participation in a clinical trial looking at upfront AXA-Rux versus steroids because of the 1/3 chance of receiving steroids. Ultimately, he worsened. He was admitted with MAC pneumonia infection, and even after resolution of his infection, he really had declined again in his PFTs and symptomatically as well.
Right, so he did not receive systemic therapy at that time. He didn't want steroids, but when did he get started on nothing? Just FAM?
No, so this case is a little bit, like I said, fabricated. So in real life, yes, like he wasn't quite. Yes, he was not started on any systemic therapy. Okay. Yes, and symptomatically it was just mild at the time. So ultimately, after this episode, he was started on steroids and belumosudil, with the idea that to try to get him off steroids more quickly, and because, and I think we can talk about this, but the idea that belumosudil being antifibrotic would be good in this setting for him in particular. So he did have symptomatic improvement on this therapy, but what I wanted to get to, hopefully, is, I think a really interesting question, which is, especially in the setting of things like lung and some of these other difficult to treat organs, how long do you wait before switching or adding treatments? And that also gets to the question of what determines clinical response in some of these organs that where stability might be a victory. I think this is always a really tricky clinical question, so curious to hear people's input on that.
So where is Steve when we need him? He's with the patients now. But this is where this becomes a little art, right? Yeah, I mean, it is a lot on the eyes of the beholder. I hate to say that. Especially because, as you alluded to with the lung GVHD, a lot of what we do is not exactly based on direct measurements, right? I mean, it's just the nature of the beast. Dry eyes, subtle symptoms everywhere. So we can, obviously our field has tried to quantify this very elegantly. We have all the scores, all the GVHD took a decade or more. Steve is Dr. Pavlevich, who just left here, who left the NIH as well recently, but he spearheaded a variety of initiatives. He was the heart and soul of a lot of what we do in terms of grading and defining response and all that. So he's here. Somebody wants to talk to him. He just left to go to the patient track. But I hate to say Steve is not here. I can say something silly. There is a lot on the eyes of the beholder, right? I'll leave at that because I think we all give 2 months, 3 months or something, but if we don't see that, nothing happening. The magic word here is fibrosis, which is a nightmare we may have now a tool to address that. But the reality of the matter is, for example, right, I mean, if you have a given angle to, failing to extend your arm, you're going to measure that angle a little bit. So there are ways to measure that a little bit, but especially when it's very fibrotic, we all know here, those who are in this field, know that that's a very subtle thing sometimes, and then obviously you rely on how the patient feels, which adds another degree of subtlety on this, but ultimately that's what matters, right? It's not how I feel, but how he or she feels. So anyway, so I'm not answering at all.
So for me, yeah. So, when I talk to my patients who are starting treatment, I acknowledge that if they have a lot of fibrotic disease, we may not see a lot of overt improvement for months, if at all. And so, I think that this has been shown in some of the more recent, clinical trials as well, is that these patient-reported subjective improvements are very, very meaningful. And what I'm hopeful for in these patients is because they're feeling better, what's happening is we're getting better control, even though we can't really reproduce this on physical exams or testing or things like that. And so I'm hopeful that with time we will start to see more objective improvement, but that subjective improvement in symptoms, improvement in ability to do activities they enjoy and go to work or to school, to me are very meaningful outcomes. So if I'm seeing that, that tells me that we're on the right track, and I will continue with what I'm doing at that point in time if I'm getting that report, but not seeing anything that's showing me very clear and overt progression of disease at the same time.
Needless to say, I'm sorry, Beth, I probably interrupted you, but not to mention that, to add complexity to this, again, I know most of you folks are familiar with this, but there is mixed responses, right? I mean, sometimes, hey, I have a little liver function test abnormality, and then it's a little bit better, but you talk to the patient, he doesn't care because, he's still feeling miserable. Hey, but your liver looks great, but he doesn't feel that. And so there is sometimes a huge discrepancy between you and I and who's there and tells us, okay, dude, your labs look great, but I feel horrible. So how do you measure that, right? I mean, so this is where the patient scores and such come in.
I agree with everything that's been said. I'll just add in terms of adding treatment. So I was going to say the same thing about oftentimes seeing mixed responses. So if something is not completely resolved or the patient doesn't completely feel better, although there's really no data, acknowledging no data for it, many of our now treatments or FDA-approved agents do have different mechanisms of action, different toxicity profiles, and has been shown at least in theories that's safe to do. And so I will often consider adding additional treatment. In general, I do, in the absence of toxicity or clear progression, I do wait 3 months before considering additional or changing of therapy.
Yeah. No, I mean, I agree with you guys because, but in BOS, sometimes, patients end up being on multiple therapies because, I'm not seeing response, but we're like, well, but this is a new mechanism and you're tolerating all this all so well. So it's really tricky. I will also say to Marcus's point about like the discrepancy, Joseph Padal and I looked at this in the chronic GVHD consortium data and also looking at it in some of the clinical trials, the larger clinical trials in chronic GVHD that there's poor correlation between patient-reported response of how they're responding, clinician response, and NIH response. And so it's like you need all three to sort of like, they're all three contribute something, right, in deeming response or determining response. So anyway, I think it's really tricky. Because we started late, we're short on time, and I want to make sure to give Dr. Shaw her time. So I will just end the case there, but I think these are all topics for ongoing discussion. I'm sure we could have spent a lot more time talking about these topics, but I want to thank the panelists for doing this, especially so last minute, and for answering these difficult questions. Thank you. Or not. take questions or like topics that people would want to hear about maybe next time about from a panel discussion. Anything while we wait for our speaker who's across the hall of the other talk. I feel like that discussion could have gone on forever, and we again tried to cut it short just to get back on time. But any other topics, hot topics people would want to hear about? Hey, how are you? Good. Yeah, oh, that's a good one. Yeah.
I was thinking when people choose how to make that.
Yeah. And that like often comes from that case discussion, but we just didn't have time to get to it. Like why you choose one. Are people using like organ involvement, presentation to choose? Yeah. That's a great question. Both of those are great questions. Other one? Yeah. Yeah, right. And that's like a no data. So like we all combine, but like they're like, so we have to do this like retrospective, like, analyses of like, oh, look, it's like well tolerated and safe, but like there's like little data on like, is this effective? Should we be doing this? When? Yeah.
Can you repeat some of the questions for our virtual attendees? Can you repeat some of the questions? The virtual can't hear unless it's in a microphone.
So the three things that came up as like potential topics for next time and next panel discussion, like the difference between primary and like secondary resistance of the GVHD therapies, when people are choosing belumosudil versus AXA or any of the newly approved drugs and why, and then I guess like data or like when people are using combinations versus switching. Yeah, so all great topics. Okay, I'll hand it over to Dr. Pavletic to introduce our next speaker.
Hello, thank you, Dr. Im. So it's just my delight to introduce the next speaker. It's Dr. Irvi Shah of the Memorial Sloan Kettering Hospital in New York Cancer Center. And Dr. Shah is the attending physician. She's a myeloma physician, so she is a member of a multidisciplinary team that treats myeloma, multiple myeloma, and related diseases in that group of diseases. And she is at the same time a pioneer in an area of a connection of nutrition and cancer. And we know we are being faced as practitioners and as family members constantly with questions, how can we modify nutrition? What is the connection between nutrition and cancer? We are not trained really to deal with this. There's a lack of evidence and hard data just to connect and even to counsel patients to that account. And that's what Dr. Shah is doing. She's generating unique evidence to make that connection, so help us all moving forward, using a myeloma as a model for cancer in general. So please, Dr. Shah. Yeah. Thank you.
Good morning, everyone, and thank you, Dr. Pavletic, for this invitation. Really excited to talk to you all about this topic that I feel is so important, but not really, you don't hear too much about. These are my disclosures. So just bringing you patient perspective, and a patient who I don't take care of just messaged me on social media and said, my oncologist team said, just keep eating a balanced diet. And I ultimately realized that this is on me to decide and figure out what does that mean. And the oncologists around the same time were telling me we shouldn't tell our patients to do anything more than just eat a healthy, well-balanced diet. And so it got me thinking, what is a balanced diet and who really follows this? So do patients even know what that means? And even do oncologists know what it means? And when we look at the US population, and this is a study in cancer survivors, you can see that only 12% get enough fruit and vegetable intake, and less than 5% get their dietary fiber in the US. So it is a very small number that are actually meeting even the USDA guidelines. So I find that what food or supplements can I take is a most likely question asked by patients and also the least likely answered by oncologists. So I feel like this is really an unmet need and something that we need to develop the research evidence for, but also the infrastructure to help patients with. And then one of the first things we did is survey patients with cancer or pre-cancer states and ask them, do you have questions around nutrition? Did your oncologist address it? And you see majority did have questions. And we find also that when the oncologist tries to give some guidance, the patients do say that they would like to follow them or attempt to follow them. And what was most surprising to me is that patients actually make changes whether we like it or not. And so we saw that patients actually on their own started eating more of the healthier foods and reducing less healthy foods on their own. So it would be nice if we can actually guide them towards what's important. And I think we're all realizing as we move through different eras of oncology, and we went through the cytotoxic chemotherapy and then genetic or targeted therapy and then immune therapy. I think the next area that's up and coming is the microbiome and microbiome-directed therapies. But knowing and understanding, we're just scratching the surface of this, but we are actually more microbiome cells than human cells, 38 trillion versus 30 trillion. So we should be thinking about what does the microbiome need to survive and thrive, and what do we need to feed it? And you can see here in this figure that the microbiome is really central to health and disease in many aspects, and we're learning that over time, and cancer is no different. I just want to bring your attention to one concept of microbiome diversity, because I'll talk about this more, and this is something you probably have read in papers or heard about as well. So more diversity, think about a rainforest or a plant with many different varieties of species of animals and plants and birds and all of that. That's a diverse environment. And then you think about a plantation where there's only one kind of species of a plant, like trees, then that is a less diverse environment. So in the microbiome too, that same concept, when you think about applied, higher diversity is usually associated with better outcomes. And we can see some data around this next. So when we look at autologous transplants and we look at microbiome diversity, you can see here very clearly that high diversity has better progression-free survival and better overall survival too, compared to lower diversity. When you look at allogenic transplants, so is that any different? You can see again higher diversity, better survival compared to lower diversity. And then not just thinking about diversity, but thinking about the composition of the microbiome. So what kind of bugs are there? Butyrate producers have got a lot of attention. These are bacteria that make the short-chain fatty acid butyrate. And butyrate has anti-cancer, anti-inflammatory effects. So we see that more butyrate producers are actually associated with better survival too. And then bacteria that are associated with worse outcomes would be things like enterococcus, which is pathogenic, as we would know as well. And then I remember I said butyrate producers. So butyrate is a short-chain fatty acid. So what if we just look at the short-chain fatty acid levels, and can we see differences in outcomes? And this study shows that patients who have chronic graft versus host disease actually have lower butyrate levels than patients who do not have chronic graft versus host disease, and compared to control healthy individuals as well. So same thing with propionate, which is another short-chain fatty acid. And having higher levels of butyrate and propionate being made by the microbiome in the gut can move into the bloodstream and maybe impacting GVHD or other inflammatory situations as well. And then what leads to an increase in these bacteria, or how do we change this? So if we want to improve gut microbiome diversity and composition, what's the low-hanging fruit, no pun intended? But dietary patterns are a major modifiable factor that affect gut microbiome health. So if we want to think about, is it even possible to change diversity, change composition? Can we do it just with dietary changes? And still thinking about in the transplant space, this is work from Dr. Marcel Vandenbrink's lab and Jenny Sanchez, who works and is a junior faculty in his lab. But they presented this at ASH, and I wanted to show you that what they showed is that higher fiber intake associated with better overall survival, but also less acute graft versus host disease. And when you look at the higher than median compared to the lower than median, you see that difference. You also see for acute graft versus host disease, higher than median fiber intake has lower levels of acute graft versus host disease. And then they looked at this in preclinical mouse models as well. And you can see that where they looked at cellulose, so that's one type of dietary fiber, and they gave the mice different levels. So the low fiber diet had 0% cellulose, the standard diet was 6% cellulose, and then the high fiber was 12% cellulose. And you can see that there's a difference in survival with 12% cellulose in a GVHD model preclinically as well. So based on their evidence and suggestions, they showed in this study that dietary fiber is associated with better survival, less acute graft versus host disease, and also in mice we're seeing very consistent findings too. So we've now talked about associations of the microbiome with outcomes and associations of dietary fiber with outcomes through the microbiome. But is it possible to do dietary intervention trials and actually change the microbiome and improve diversity, butyrate producers, and composition, and maybe through that improve outcomes? So we just recently published this paper looking at key considerations in designing interventional dietary trials in heme malignancy specifically, and I think there's lots to think about, as you can see in this busy slide, but we have to think about a lot of different aspects as we think about trial design, including the disease setting, type of therapy we're going to do this with, the intervention, biomarker endpoints, and the study duration. I'm going to show you some evidence around the trials we have done, and this may not be directly in the GVHD or transplant setting, but it is in heme malignancies. And thinking about in the prevention setting, how do we think about this as a backbone to prevent future cancers, or in a pre-cancer state to cancer development? In the treatment setting, if it's synergistic with immune therapies, and in the survivorship setting, so once a patient's finished treatment, how do we prevent relapse or reduce risk going forward? So starting out with the prevention setting, that was where we started our work and the first study. So I'm going to just take you through that study and what we found. And the reason we decided to do this in the precursor or prevention setting, these are patients with MGUS or smoldering myeloma. These are precursor states to the blood cancer multiple myeloma. And patients with that disorder are told there's nothing to do, just watch and wait. When you do develop myeloma, we'll treat, but other than that, we just watch. What we do know is in observational studies like this one, elevated BMI is associated with twice the risk of progression compared to a normal BMI. And it's not just one study. I'm showing you two here, but there are 3, I think, published in this space. So I think as hematologists and oncologists, we have an opportunity for cancer prevention and improving outcomes. And these are the pre-cancer states that I'm going to talk to you about and show you our data from. And then some of them may develop multiple myeloma over time. As the disease progresses, there's more genomic complexity and there's more immune dysfunction too. We know that modifiable factors affect the immune system. So is it possible that we can delay the development of myeloma or tilt the scale through reducing some of these modifiable risk factors? So that was what led to the Nutrivention trial. So the first study that I designed in this space or wanted to think about. And in this study, it's basically a single-arm, single-center study. We had 20 participants with a BMI over 25, with these precursor states of MGUS or smoldering myeloma, and we provided them high-fiber plant-based meals to see if we could improve biomarkers and feasibility too. And what you can see is that we provided 12 meals per week, so that's not all their food, and we didn't calorie restrict them. We said you can eat as much as you want, but just focusing on unprocessed plant foods. And we provided nutrition coaching for 24 weeks and then followed them for a year on the study. These are just pictures of some of the food we sent them. The intervention, one of the things we looked at is how did their diet quality change? So were they able to be adherent to it? And you can see that at baseline, their diet was about, the percentage is basically the percentage of calories that are unprocessed plant foods. And you can see it's really low. It's only 20% of their calories. That's also, I think, a little higher than what the US average would be, because these are patients who are willingly coming on to study. And you can see that it improved to 92% on intervention while we provided the meals and the coaching and all of that. And even 1 year later, it was high at 60%. So patients actually found that they benefited and continued to do this even after we stopped providing the food, much better than where they started. You can see about a 7% reduction in weight, which was maintained also a year out, and quality of life improved as well. When we asked patients how difficult was it, surprisingly, the majority of patients who responded said it was easy and nobody said it was difficult. And we also asked them, were there things that you found improved, like personally, or how did you feel after the study? And you can see the green bars on things that patients found improved for them. So energy, sleep, pain, GI symptoms, metabolic disorders, even diabetes, prediabetes, self-confidence, anxiety, all of these things. And more importantly, 4 patients were able to actually stop prescription medications like insulin, bupropion, potassium supplement, and hydroxychloroquine, saving money per month as well. Now, this is a really exploratory analysis because this is a small study, and we had all kinds of patients who are newly diagnosed where we didn't have the M spike or the protein before diagnosis, and we also had some patients who had really tiny levels of disease that is not able to look at trajectories over time. But you can see that there were 2 patients who for 5 years had this disease, and their disease was slowly progressing before going on intervention. And it appears like when we calculate a rate of change that there may have been some slowing in their disease trajectory, and the p-value was significant. For 20 months before intervention to 20 months after intervention, the comparison, suggesting that maybe there is some slowing of disease trajectory. We also looked at insulin resistance. So despite eating the same number of carbohydrates, we're not reducing carbohydrates, but we're reducing refined carbohydrates because they're eating more complex fiber-rich carbohydrates. You can see insulin levels dropped. The gut microbiome diversity that we just talked about and how it's important significantly improved, and it didn't just improve at 12 weeks, even at 1 year it was improved and maintained because of the dietary changes that they've made and maintained over time. You also see butyrate producers improved and increased, and we also looked at the enzymes or genes around butyrate genes, and that also increased and improved. I've just not shown it here. Then we looked at inflammation. So inflammation is an important aspect too, and C-reactive protein levels actually dropped significantly by the end of year 1. In the patients that it was elevated, it dropped by about 50%. And neutrophil count in the blood also went down at week 12, suggesting less inflammation in the blood. When we looked at immune subsets and how that changed, you can see that monocytes, classical, which are considered anti-inflammatory, actually shifted to an increase in the blood, and non-classical monocytes, which are considered inflammatory, reduced, suggesting again a shift in the immune system as well. Now this is exploratory, but we did single-cell RNA sequencing on the bone marrow at baseline and 1 year apart. So looking at how the bone marrow microenvironment changes in after a dietary intervention. And what you can see here is the granulocyte monocyte progenitors. So the green bar is after intervention and gray is before. You can see that they actually increased. But I just showed you in the blood the neutrophils reduced. And what that means is that there is enhanced innate immune potential in the bone marrow, but they're just not circulating due to less inflammation peripherally or need to be circulating. But there is availability if necessary. You also see the CD14 monocytes increase, which is very consistent with what you're seeing in the blood with the classical monocytes too. And then if you look at the figure on the right, this is just an exploratory interaction, what we call the cell chat function, where we are looking at how do these cells talk with each other and what's their interaction. And you can see in the blue circle is basically the myeloid cells, and they are mainly interacting the gray lines tell you how they were interacting before the intervention at baseline. And you can see that the gray lines mainly converge on CD8 exhausted T cells. The green lines tell you the conversion, where they converge after the intervention 1 year later, and you can see mainly it's with the cytotoxic T cells and natural killer cells, suggesting maybe there is a shift in immune function too. This was one patient, and not the only one, but who had significant improvement, was able to stop insulin and come off that for their diabetes after 30 years and have other benefits too. And then we collaborated with Dr. Matteo Bellone's lab in Italy to actually do mouse modeling of this and see if we can actually delay progression in mice who have smoldering myeloma to multiple myeloma with a high fiber diet. And what you can see here is that the standard diet, so this is not like a high fat diet or anything, this is a standard mouse chow compared to high fiber chow. And you can see that the mice in the standard diet, all of them progressed by the end of the experiment at 30 weeks, but in the high fiber group, half the mice had not progressed to myeloma. So with that study completed, we're also enrolling on 2 other studies in the same precursor space. This is a decentralized study that's enrolling nationally, and it's just looking at small interventions and the effects on the microbiome. And then we have the Nutrivention 3 study, which is very similar to Nutrivention, the pilot study, but it's 150 patients, so much larger, and we've enrolled almost 70%, so we should be done with enrolling by next year, I think, at the rate we're enrolling. We've also shifted and looked a little bit in the myeloid disorder space and thinking about clonal hematopoiesis, which is associated with increased inflammation, cardiovascular disease. And happy to say that a review that we wrote around modifiable risk factors has just been accepted and should be out in the next week or 2, I think. And we also have a study in clonal hematopoiesis that's going to open early next year that has been funded. And we're going to look at the effects of diet on epigenetic aging, inflammation, quality of life. So that study I'm looking forward to as well. Now, moving on to the synergy with treatment. So we talked about in the prevention setting, thinking about in treatment setting. In myeloma, it's the same way as I showed you short-chain fatty acids being associated with GVHD. You can also see that these short-chain fatty acids are associated with the disease state. So more advanced disease has lower levels of them, but also with response. So CRMM is like myeloma incomplete response, and newly diagnosed myeloma is NDMM. And you can see again that the myeloma patients in response are actually having higher short-chain fatty acid levels than those not. And so we are opening this study. It's actually IRB approved and should be ready to enroll in the next couple of weeks. But this is a study of newly diagnosed myeloma patients. They're going to get their standard induction therapy with 4 cycles of Dara-RVD or isatuximab-RVD. But half of the patients we will be providing coaching and nutrition support and actually sending meals to. This will be a national study and enroll in a decentralized fashion. So patients can be at any academic myeloma center in the country as long as it's an EPIC site as well, so we can look at records as well. If you have patients and interested in being a partner in enrolling, you can email us and we would be happy to discuss further. And then I'm thinking in the treatment setting, we often think about only how does it enhance response and survival, but we should also be thinking about quality of life. We should be thinking about infections, weight, all of those things too. And this NutriDiet trial, I think, answered a very important question. And it looked at patients both with allo and auto transplant and looked at doing a protective diet versus a non-restrictive diet. And when they talk about the protective diet, it means that you can only eat cooked foods with thick peel fruits. And non-restrictive diet is you have the basic hygiene standards, but you're not restricting them beyond that in terms of what you eat. What you can see is that the patients in the non-restrictive diet were, of course, allowed to eat fresh fruit and vegetables too, whereas in the protective diet, they were not. There was no difference in infection rates. There was a difference in weight, where the protective diet had lower weight compared to the non-restrictive diet, and quality of life was also lower in the protective diet, suggesting that there is no difference in infection, and we are maybe, like when we talk about these protective diets, we are restricting them from healthy foods and foods that might be good for their microbiome health as well, so something to think about. And then lastly, I just wanted to talk about dietary interventions in the survivorship space. So how do we think about diet and lifestyle improving outcomes or the time before the relapse or survival as well? So one study we did in myeloma, this is not an interventional study, but has led to us doing an interventional study, was looking at patients on lenalidomide maintenance. So this is myeloma patients who've finished their induction therapy, had a transplant or not, and then gone to maintenance lenalidomide after. What we looked at is their microbiome and outcomes. And sustained MRD negativity is the best kind of response in myeloma, so long-term. And you can see that patients who had higher microbiome diversity, higher butyrate producers, and higher butyrate concentrations were more likely to be sustained MRD negative. And additionally, when we looked at dietary patterns, we didn't change diet, we just surveyed patients, and we do see associations with healthier proteins and dietary flavonoids, which are found in plant foods mainly. So because of this, our hypothesis, and this is just a correlation study, but thinking how dietary patterns affect the microbiome, the immune system, and so myeloma control or MRD negativity. We've just completed this study, and we'll be starting to analyze the microbiome data on it, but we finished the quality of life part, and that has been reported already. But we looked at newly diagnosed patients getting 2 types of maintenance therapy and looking at quality of life with these 2. But all of the patients also had detailed microbiome and dietary data collected, and a sub-study of like 24 patients out of the 89 also got the dietary intervention of a high-fiber diet. So we can see the interaction with the immune therapies and how this may affect outcomes too. So hopefully in the next year, we'll have some data to share. And so with that, I'd just like to say that dietary patterns are all-encompassing in the ways that they affect our metabolism, our microbiome, immunity, and maybe even cancer. And just thinking about sources of dietary fiber, and I added this because after I've given talks to medical students, residents, and asked them about sources of dietary fiber, I've got answers like fish and dairy, and people don't always know where it comes from. So just to bring it up, that it's basically unprocessed plant foods that have dietary fiber. And thinking about how do we shed light on dietary mechanisms to empower patients through all of these different ones to improve outcomes. And maybe just dietary fiber is the original immunotherapy, and maybe I've convinced you of that. And so with that, I'd really like to thank my team, colleagues, mentors. It takes a village to do this research, and it wouldn't be possible to do it alone, and also the patients who've taken part and the funding sources. Thank you. Are we doing questions now? Or we
can take questions.
Okay. Okay. Go ahead.
Oh, I thought there was somebody behind.
We can go next.
No, please. Here.
That was a really fantastic talk. And I want to ask you, so I can understand the interest in the microbiome correlation with the diet, but I really would urge you and hope that are you trying to look at post-translational modifications of proteins that might happen, that might change because of the diet, because that has a really, really prominent effect on immune response. And And are you hoping, the second question follow-up is, will you expand to autoimmune diseases also, where this might be really important?
That's a great question. So for the autoimmune disease, like actually on the study, we've had patients who've had autoimmune or other things and seen benefits, but that's not our main focus in the study. But we had a patient with really bad eczema, and her face would get red and swollen, and she didn't know like what was causing it, tried seeing so many immunologists and doctors and couldn't figure it out, but also had MGUS. So I said, you can try the study, we will reduce inflammation through it and see what happens. And her eczema improved significantly. So for her, this has been life-changing, and now her whole family eats better, and she's like, this has really changed what we do as a family. And another patient who had cat allergies, that improved as well. So we are seeing some like immune changes where patients are actually noticing those things. And there are studies around how diet can affect infection risk. And in the interest of time, I didn't show you, but like with COVID infections, there were 3 studies showing that people who eat more plant foods actually have less COVID and less severe COVID. So suggesting again that what we eat can affect our infection risk. In terms of post-translational modifications, I am not sure which one specifically you're thinking about, but would be happy to chat more and see how we could look at those things, because we've collected all kinds of samples, so it would be possible.
So I have a semi-random question. You know, a significant fraction of U.S. population now is on Ozempic-like agents. And one thing that fascinates me with these agents is anti-inflammatory effects.
Yes.
Are you computing, I mean, is there data in the midst of your cohorts here of that?
So I can give you an anecdotal case. That was actually the case of the patient that I showed where the M-spike trajectory changed. So this patient was on insulin for 30 years. The patient also was on a GLP-1 drug for diabetes, not for myeloma, like not for obesity. During that period, the patient had lost, before going on our study, about 15% of their body weight over many years because I think of the GLP drug that they were on for diabetes. However, the M-spike trajectory continued to rise during that period because I think they were also on insulin. Then they went on our study. They were able to stop insulin in a month, continued on the GLP because that was something they were on anyways. And that's when we saw the plateauing of the disease, which we had not seen, and they lost 15% more weight on the study. So I think that weight loss alone with these drugs I definitely think they're going to be helpful in a population way and improve inflammation, reduce cancer risk, and all of those things. But they are working through one mechanism of weight loss. When we do dietary changes, we're working through many mechanisms of the improvement in the microbiome, improvement in the foods that have anti-cancer, anti-inflammatory effects, the flavonoids, all of those things, insulin resistance, and as well as weight. So I think that while those drugs can be valuable and help people and aid them, I think if we can do it with diet quality change, we're going to see much more benefits.
Hi, Uvi.
Yes.
This was a fascinating talk. For my patients who ask about diet, I share your work.
Thank you.
So it's very, very impactful.
Thank you.
I just think there's a lot of potential in the chronic GVHD space.
Yes.
Because even when there is objective response in GVH, the number one complaint patients say is fatigue. Their hemoglobin could be 12.9 and they're still fatigued.
Yeah.
So I was very impressed by your patient-reported outcomes for quality of life. I think there's a lot of opportunity and hope we can collaborate in this space.
Yes, I think we saw an improvement in fatigue as well, and shortness of breath too, which I didn't show here, but yeah.
Thank you. So that was really exciting and interesting, and I know a lot of our patients would be fascinated to sort of hear more and maybe try to model their diet after what has succeeded for the patients in the studies. For those who may not be able to enroll on a study or the study may not be accessible, is there, I know the coaching would be difficult to reproduce, but is there some sort of printed guideline or patient-friendly information that we could share to better describe what that high-fiber diet looks like?
Yes. So I think the American College of Lifestyle Medicine does a really good job of a lot of handouts and data. The American Institute of Cancer Research has some as well. I have put a Linktree link on the slide. It's not like it's more of like when I give talks to patient foundations or other talks that are on YouTube, I've linked them all in one place. So sometimes I find it's helpful for patients where we don't have time in clinic to talk about everything, but I can just send them the link and say, you can look at these videos and come back to me and we can discuss it if you have more questions. And that way it's also not stressing the patient out with like, okay, you have to do all these things, but like hear it out, see what they would like to do, and then we can talk more about it. So I think those would be a few starting places. We also, sometimes I'll send a bunch of links in a PDF to patients too, which I have, and I'm happy to email you.
Thank you.
Okay, any more questions? Okay, just quick last question. Obviously, it's a fascinating chain of events, the nutrition, microbiome, cancer control, or GVHD. Going back to GVHD more, there is this aspect in this chain of events, the role of gut-blood barrier. So is any evidence that some cytoprotective strategies may be important or kind of preventing GVHD because of the microbiome?
That's
influence?
a great question. So the gut lining, to be healthy, there is a mucus barrier that keeps the integrity of the gut lining. When that mucus barrier is disintegrated, that's when you have what we call maybe leaky gut or inflammation, because things are moving more permeably between the two. And what keeps this barrier integrity is the mucus lining, and that mucus lining is protected by the microbiome. And the microbiome, when we give it fiber-rich foods, that's what it eats. But if there is no fiber-rich foods, it is thought that the microbiome ends up eating more of the mucus lining, so then that leads to more leaky gut. So having enough fiber in the diet can actually protect that lining, and maybe that is part of why there is improvement in inflammation and the immune system through keeping that barrier integrity.
Thank you. Okay, we have a break now, I think. Thanks. How long is the break?
Renewal event certificate is predicated on the fact that there are some individuals with pre-existing conditions. Those are the ones that get predisposed to organ failure and may apply.
No, just because I'm there'll be the one crop here and several people. You know, we're having it here. So yesterday was the birthday of your so people are setting out as a little. Really, it's a more heterogeneous group. But the thing is that anyway, so a few jokes about going somewhere. So TMA.
So, no. I was saying that the rank around that there's definitely pre-existing information. We have eliminated pre-existing information. So In hospitalization, that's one area. But then in acute GVHD, they're all chronic.
That's the easiest studies ever. We did flooded. It's 30% is considered, but guess what? We are 5 minutes in. No, stop. So you put those, think of something. Anyways, yes. I asked one so they we give the patient
Samples from vitamin A should be like that.
I'm saying,
But I'm saying
move
create
forward.
new studies
Everyone that comes in, hi. Good to see you. Oh, God. It's like,
It's overwhelming. It's a lot of work.
it's like a lot of work in like bursts. It's like, this is due now.
This is due tomorrow.
Yes, exactly.
I'm obsessed.
And it's like, review these abstracts. They should be in a different category. Is that cool?
Say hi, Wang Xing Ken.
Oh, hi.
Yes.
Yeah.
Those are great
It is. Yes.
Cool. Don't you do like that?
Yeah, but I don't
You don't have
I don't have a whole But anyway, yeah. Which is maybe I'm just
Yeah. So, good, yeah. You know, I'm very trained with
And like all the genes. And so I don't know, we
those friends
Stephen's great. I don't know. Chat buddies. It's just every other week now. I want to go for it, but I shouldn't be so.
it's always nice to go. I don't, so I take care.
Yeah. That's actually the difference in this patient. I mean, about all the, sorry,
yeah, the lady with the
whether or not they get this better, then we get the classified. I'm trying to organize. I have a organized.
One of the issues that I didn't anticipate.
We actually had to, so glad it was RTP got to make and I told everybody, nobody starts anything systemic. I can handle this. You can give this kid. So now his tuberculosis. Right now, it's not right. But yeah, I think, you know, I'm embedded in the so and like physically, my clinic is next to, you know, and then I owe them a review for January. Yeah, and then we also have easy access to the IT. Yeah, a lot of it is there's the implementation here. Like the spring
That's where little Mary and her. Whatever it is, but it's very much, yeah. This is very hard.
I mean, I don't know what the
part mindset and part people have to do it. But the other aspect of this is coming.
Yeah.
That is like
right, because you have to relearn it, you know, it's a rare thing.
And I identify that in the group
Oh, that's my goal, you know, this is
so that's amazing. That's right you know, that's a loss of what you do. The SPE is something else. But I'll introduce you to recreating our program. What is your thought? Okay, over there. Yeah, I'm gonna yeah, no, well, I'll definitely be here. What? No.
Actually, I'll copy you when I send it to Maria. It'll be so much fun.
Hi, everyone. We're going to give you a few minutes, if you can, to get seated again. We're going to start with our next session here soon. Well, it is my absolute pleasure to be able to introduce our next speaker. Our next speaker is Dr. Katana. She is an assistant professor of oncology at Johns Hopkins University School of Medicine in the Division of Pediatric Oncology. She divides her time between research and clinical care, focusing on the treatment of pediatric, adolescent, and young adult patients undergoing transplant for malignant and non-malignant conditions. Dr. Katana earned her medical degree from the National and Kapodistrian University of Athens, Greece. She conducted postdoctoral research at the National Human Genome Research Institute and completed her residency in pediatrics at Children's National Medical Center in Washington, D.C., followed by a fellowship training in pediatric hematology oncology through the combined Johns Hopkins University and National Cancer Institute program. Her research centers on the epigenetic regulation of immune responses following allogeneic transplant, with a particular emphasis on DNA methylation. Dr. Katana's laboratory employs mouse models of transplant to elucidate how these mechanisms shape the donor immune response and influence graft versus host disease and graft versus tumor effects, with the ultimate goal of informing therapeutic strategies that harness the allogeneic immune response to improve transplant outcomes. So we're very fortunate and honored to have you with us today. Thank you.
Thank you so much for the introduction, and thank you for having me here today. This really looks like a lovely group of people, and I'm so glad to be with you. Let me see, how do the green button maybe moves us forward? Oh, there we go, okay. So I have no disclosures for you guys today. There, I can see my slides there, okay. And so, the audience here knows very well that allogeneic BMT remains the only curative option for many malignant and non-malignant disorders, but graft versus host disease is a major limitation. And just a couple of seconds to remind us all of the general paradigm of GVHD pathophysiology is that the conditioning regimen causes diffuse damage and inflammation, which causes the release of pro-inflammatory cytokines, which then activate host antigen-presenting cells, and those activate the donor T cells. And at the same time, there is the release of soluble inflammatory agents that further amplify that local tissue injury and inflammation. And all of that together culminates in this vicious cascade of graft versus host disease. But when the targets of that process happen to be malignant cells in the patient, we know that as graft versus leukemia or graft versus tumor activity. So since donor T cells are central participants to both of these processes, how are their responses to alloantigen versus tumor antigen regulated? Because that is really the holy grail of what we do in the lab, right? Trying to figure out what sets apart harmful GVHD from beneficial graft versus tumor effects. And that's where epigenetic modifications come in. So epigenetic modifications consist mainly of DNA methylation and histone modifications and chromatin remodeling. And they make good therapeutic targets because they determine transcriptional activity, so they can turn genes on and off without altering the DNA sequence itself. But at the same time, they're somatically inheritable from cell to cell as they divide, and they can be reversible. And a lot of what we're going to talk about today focuses on DNMT3A, which is the main de novo methyltransferase, in which by now we know well regulates T cell function and polarization. So it is an enzyme that is crucial in embryogenesis and hematopoiesis, and as we age, acquired mutations in this enzyme, in this gene, are very, very common in hematopoietic stem cells. It is in fact the most common mutation in what we now know as CHIP, or clonal hematopoiesis of indeterminate potential, which is basically clonal populations of non-leukemic white blood cells. It can affect about 30% of individuals over the age of 60, and it results in increased risk of hematologic malignancy and cardiovascular disease and mortality all around. So if CHIP is such a common thing, what happens if your donor happens to have CHIP? So this study came out in 2019, and they examined about 500 donors over the age of 55, and they found that 16% of them had CHIP at the time of donation, and the leading mutation, as one might expect, was DNMT3A. And what they saw was that donor CHIP increases the risk of chronic GVHD, decreases the risk of relapse, and all of that was mainly driven by the DNMT3A mutated grafts. Now, I will share with you guys that when this study came out, I was already in the lab studying the phenotype I'm about to show you. So it was very exciting to me that clinical data came out showing in humans what we were seeing in mice. This next study, even larger, came out a few years later. They examined 1,700 donors over the age of 40. And over 20% of them had CHIP. This study showed that the vast majority of these donor clones engraft in the patients, and they had 8 cases of donor-derived leukemia, but none of these were from grafts with DNMT3A mutations alone. And what they saw again was increased risk of chronic GVHD, decreased risk of relapse, and overall improved survival associated with that. But all of that went away in the patients that received post-transplant cyclophosphamide or PT-Cy, suggesting that this is perhaps a T-cell-mediated phenomenon, because as we all know, PT-Cy is a very effective method of GVHD prophylaxis. So our hypothesis here is that donor T-cell DNMT3A somehow regulates alloreactivity, and to test this, we use T-cell conditional DNMT3A knockout mice as donors in mouse models of BMT. And how these models work is that you take your donor, in this case it would be a DNMT3A T-cell knockout or wild type, and you isolate bone marrow, and that goes on to provide immune reconstitution. And you isolate splenic T-cells as well, because in the mice, the bone marrow does not contain enough T-cells to cause GVHD the same way it does in humans. And then the recipient mouse gets a conditioning, usually that's irradiation, and then you infuse the cells and monitor the mice for GVHD and other endpoints. And in this case, we also looked at their CD4 and CD8 T cells specifically. So I'm going to walk you through one of the first models that we use, which is a haploidentical model. So they were relevant to how we also transplant patients. So here you have the survival curve, and we have the syngeneic control group. So, identical donor and recipient. We don't expect to see any GVHD, perfect survival. And then we have an allogeneic wild type control group. So these mice are expected to get some GVHD, and we see that. And then the mice that receive the knockout T cells have accelerated GVHD, accompanied by worse GVHD scores and increased weight loss. This was also accompanied by worse histopathological scores in target organs such as the intestine and the liver. And this is established histopathological scoring by a blinded pathologist who does not know which mouse is which. And we wanted to make sure that these mice are not dying from, graft failure, for example. So we looked at their bone marrow, and we looked at peripheral blood counts, and we saw robust donor-derived hematopoiesis. So then we, started thinking, is it the CD4, is it the CD8 T cells, what's causing this? So here we're looking at a MHC1 mismatched model. So with an only MHC1 mismatch, you only expect to have CD8 activation, and your graft only contains purified CD8 T cells. And what we saw, again, syngeneic, wild type, and knockout recipients, and the phenotype here is even more exacerbated than before. And then in an MHC2 mismatch model, where you only have CD4 activation and only CD4 T cells in your graft, we saw, again, the mice do just fine. They all survive, but by the end of this experiment, the mice have a more sclerodermatous phenotype and have increased histopathological scores in target organs. We also did mixing experiments where we kind of isolated the CD4 and the CD8 wild type and knockout T cells separately and co-injected them. And what we saw is in orange there, the CD8 knockout T cells are sufficient to replicate the phenotype, but the CD4 knockout T cells in purple also contribute. So then we started thinking about, okay, well, what are the mechanisms behind this? And we looked at T cell expansion first. Is it just that the sick animals just have more T cell expansion? And that was not the case. If anything, the animals, as they got sicker, had decreased T cell expansion in CD3 and CD4 and CD8 T cells, and that's in blue there. And then we looked at cytotoxicity. So this is, a JAM assay. It's kind of the gold standard of cytotoxicity, and it's radioactive, so people don't do it anymore, but I did it, sacrifice myself for science. And then we also looked at, and there were no differences there. And then we looked at markers of cytotoxicity by flow cytometry, such as granzyme B, and again, not many differences there. So then we decided to compare these cells head to head. So we purified the wild type and the knockout T cells, and we dyed them each with a different proliferation dye, and we co-inject them at a 1-to-1 ratio in lethally irradiated allogeneic animals. So you'll see wild type on the red axis and knockout on the blue, and what you see 24 hours later in the spleen, there are 3 times as many knockout T cells as there are wild type. Imagine my excitement when I saw that in the lab one day. And then 48 and 72 hours later, what you see are these, the subsequent populations that you see in the knockout gate, those are division peaks. So these cells divide much faster. And by day 4, these cells kind of lose the proliferation dye because as they divide, with each division, they lose the proliferation dye. But we can follow them because they have differences in CD45.1 and CD45.2 and CD90.1 and CD90.2 on their surface, so we can still follow them. And what we saw as they migrated out of their spleen, there's a higher percentage of knockout T cells migrating to the lymph nodes and to the Peyer's patches and the intraepithelial lymphocytes and the lamina propria of the intestine. A very interesting finding that we came across as we were doing these experiments was that we saw a very distinct population in the knockout T cells. So here you see in the spleen at day 7 after transplant, CD4 and CD8 T cells, as one might expect. But the knockout recipients have this very dramatic, distinct double positive population. And, double positive T cells can be seen in some lymphomas, they can be seen in some autoimmune conditions and HIV, but they're not very well characterized. But we see them in the spleen and in the lymph nodes. And just the morphology of the plot there suggests that they're originating from the CD8 T cells. And indeed, if I take you back to that MHC1 mismatched model, the CD8-driven one, they are present there, but absent in the MHC2 mismatched model. And then interestingly, a couple years ago, this paper came out where this group identified double positive T cells in patients with GVHD, and these were predictive of grade 2 or higher GVHD. They were not present in the grafts to begin with, and then when they used them in a xenogeneic model of GVHD, what they saw is that indeed they emerge from mature T cells. They are sufficient to induce GVHD, but they appear to have no additional graft versus leukemia benefits. And speaking of graft versus leukemia benefits, of course, we went on to test this in our model. And the way we do these models is we transplant the mice, just as I told you before. We cut down the T cell dose by 50% because we don't want the mice dying from graft versus host disease before they have a chance to develop GVL effects. And then at the time of transplant, we inject a tumor cell line that is luciferase transfected so we can monitor tumor burden by bioluminescence. And what you see there in the syngeneic group, the immune system is identical to the host and to the tumor. So there's uncontrolled tumor growth. And as my lovely mentor likes to say, they light up like a Christmas tree and they die very early. In the allogeneic wild type mice, there is some allogeneic effect because you see the tumor growth is delayed, but the knockouts are much better, are controlling or eradicating tumor, and that is associated with improved tumor-free survival. So then to take a deeper dive, we wanted to do some more sort of, sophisticated analyses. At day 10 post-transplant, we isolated all these different subsets by flow cytometry at very high purity, and we went on to do whole genome bisulfite sequencing, which is kind of the gold standard in DNA methylation, and RNA sequencing in parallel, with the aim of kind of intersecting the regions that have differential methylation and differential gene expression to identify the signaling pathways that may be dysregulated in GVHD. And I'll tell you just a little bit on the methylation metrics that we use in these experiments. So we look at the mean methylation level across each genomic unit, and then we look at what we call entropy, because from read to read in a normal cell, you're really, the methylation is supposed to be quite orderly. And then we look at what we call the Jensen-Shannon distance, which is a metric that incorporates those two and other factors. And basically, when you're comparing two samples, 0 means they are totally similar, and 1 means they are as different as can be. So if you knock out a major DNA methyltransferase, one would expect you would see hypomethylation, but that was in fact not the case. Global hypomethylation was very similar in these wild type and knockout T cells after transplant. But what we saw were these distinct peaks in hypomethylation in areas that made sense, such as the EGR3 gene locus, for example, which is a transcription factor and negative regulator of T cell activation. And these changes were involved in critical T cell pathways such as TCR signaling and T cell differentiation. And indeed, just seen very broadly here, they affect gene expression. And I'll draw your eyes here to the CD4 locus, which is unmethylated and overexpressed in those double positive T cells I showed you. And if we do a PCA analysis, you can kind of see that the double positive knockout cells there in blue cluster very closely with their CD8 counterparts. And then we did gene set enrichment analyses where you kind of compare your data to other published data out in the community. And what we saw was that the knockout CD4 T cells are enriched for genes expressed in activated and progenitor cell populations, versus the knockout were enriched for signatures that were effector-like and negatively enriched for exhaustion phenotypes. And then I'll show you a couple more examples that were very interesting. For example, this is the CCR9 locus here. And the first line over there shows you the Jensen-Shannon distance. So there's a very high peak telling you there's a difference. Then the middle one is differential mean methylation level. And the negative peak tells you that it is the knockout that is hypomethylated. And then entropy is under that. And CCR9 is a chemokine receptor that drives T cells to the intestine. So us being interested in GVHD and seeing this as one of our top differentially methylated and expressed genes was, very intriguing. And in fact, single nucleotide polymorphisms in the CCR9 gene of donors have been associated with increased GVHD. So the question here is, of course, well, can we target CCR9 to treat or even prevent GVHD? Because if you go back to that cycle of the pathophysiology I showed you, it's not just about, stopping them from tracking there once GVHD starts. It's stopping them from migrating there in the beginning and getting primed during that initial phase of GVHD, and hopefully preventing that whole vicious cascade from snowballing. So we went back to our sequencing data, and indeed CCR9 transcripts were increased in CD4 and CD8 T cells, and then going back to those co-adaptive transfer experiments by flow cytometry, more knockout CCR9 positive cells were migrating out to the lymph nodes and the intestine. And so then, of course, we asked, do these inhibitors exist? And lucky for us, they do. And one such agent, CCX2A2B or Versidon, has been actually in up to phase 3 clinical trials in humans for inflammatory bowel disease, where it did not quite meet the set endpoints for those patients, but it was safe and well tolerated. And so we acquired that agent to start using it in our mouse models that I showed you before, and we treat these mice before we give the cells at day -2 to have the inhibitor present and circulating, and then we treated them up to day +5. And what we saw was that the treated mice there in blue, you can see that white cells accumulate in their spleens and lymph nodes, but they have improved histopathological GVHD scores in the small and large intestine, along with improved or decreased lymphocytic infiltration and decreased evidence of apoptosis. The data is very preliminary and, an ongoing experiment. Now we're doing the survival experiments, and the treated mice at 2 different doses are having less weight loss, which is very exciting to us. Of course, what is most exciting is having any new agent that can spare our patients of steroids or potentially be combined with steroids. And then, there are other pathways that are regulated by DNMT3A, such as T cell exhaustion. So we know that in T cells, DNMT3A mediates T cell exhaustion, and it can inform outcomes of immunotherapy. And in fact, a group at St. Jude has knocked out DNMT3A in CAR T cells to show that they can prevent exhaustion and enhance anti-tumor activity when they do so. And indeed, in our experiments, we had a decreased PD-1 expression by flow cytometry, and then looking at downstream targets of PD-1, such as PI3K, we saw upregulation there, and that we saw the corresponding peaks in the methylation data. DNMT3 also seems to regulate apoptosis in this context. So this is a caspase 3/7 assay, and you can see that these cells are less likely to experience apoptosis in the context of transplant. Now, of course, I get this comment a lot, the mouse data does not perfectly correspond to the human data, and that makes sense, right? We have to remember that in the mice, we knock out this gene and all the T cells, versus in humans, it's always, a smaller T cell clone that is affected. And then in the mice, we have a total deletion of the gene, versus in humans that have these mutations, it usually results in a partial loss of DNMT3A activity. And then in the mice, we transplant these mice in a way to induce lethal GVHD. But in humans, we always give GVHD prophylaxis or even T cell depletion. So even though, it's not a perfect replication of the human phenotype, I think important to remember that these mouse models over the last few decades have resulted in very significant advances in the field, and I think are teaching us a lot here with the field of epigenetics as well. So another question I very frequently get is, what about the myeloid cells? Because of where CHIP exists, if you have these clonal hematopoiesis mutations, they're not going to be just in your T cells, they're going to be in your myeloid cells most likely too. And so we've done those experiments as well. We use donors with a lysozyme CRE, meaning when lysozyme is expressed, and it's expressed in all of the myeloid T cells, the CRE, the little cutting scissor, is expressed as well, and it goes to cut out DNMT3A, which is the FLOX gene, in all the myeloid cells. And indeed, there is a phenotype here, but more modest than what we see in the T cells, and we're doing more work on this as well. So then, one, I think, naturally goes to ask, okay, what about DNA demethylation, right? Active DNA demethylation is catalyzed by mainly by this enzyme called TET, and what it does is it takes the methylcytosine groups, it flips them over, it adds a hydroxyl group, and then it oxidizes them so that they can be removed and replaced by unmethylated cytosine. And so, for example, in a naive T cell, TET CD8 T cell that wants to become an effector CD8 T cell, TET2 will go to the interferon gamma promoter and remove the methyl marks, so that then that promoter is opened up to the transcriptional machinery, and that gene can be accessed, and that effector T cell can go and produce interferon gamma like it wants to. And so, one might think, okay, if you take out DNA methylation in the donor T cells, GVHD is worse. So then if we do the opposite, if we take out DNA demethylation, GVHD is going to get better, right? That sounds simple, except it's not. I wish it was. Okay, so this is a fully mismatched mouse model, a black 6 into a BALB/C, and these donors, like I showed you before, they were DNMT3A knockouts, now they're TET2 knockouts in their T cells, and the knockout recipients here in blue do in fact do better. However, we don't ever, do these experiments once. We do them multiple times to replicate the phenotype, and then we do them across multiple different strain combinations to confirm the phenotype. And when we did these in the black 6 into F1 haploidentical model that I showed you before, the phenotype is the opposite. The mice do worse again, very similar to the DNMT3A phenotype, which sounds counterintuitive, but in fact goes along with published data in hematopoietic progenitors where they've seen that DNMT3A and TET2, even though they have opposing enzymatic functions, they actually at the level of the cell have similar programmatic goals. So disrupting them can result in a similar phenotype. And indeed, if we go to it, this may be partially explained by CD4 versus CD8 effects that TET2 has that are different in one subset versus the other. So if we look at the CD4-driven black 6 into PM12 model, the knockouts do better, but if we look at a CD8 model, the knockouts do worse. And this goes along with differences that we've seen in vitro in mixed lymphocyte co-cultures where we activate these T cells with allogeneic dendritic cells in a dish, and we look at their proliferation, and it kind of goes along with the phenotype in each of those models. I'm going to kind of end here with another new avenue that I think is very exciting, epigenetic modifiers. So, we spoke about DNMT3A, which is what we call an epigenetic writer, and we spoke about TET2, which is an epigenetic eraser, and then there are things like epigenetic modifiers, such as non-coding RNAs. So microRNAs specifically are these short segments of RNA about 22 nucleotides long that are transcribed but not translated. And what they do is that they function at the post-translational level, and they basically tag their target mRNAs and they mark them for degradation. It's like being in the office and marking the things you need to shred. So even though that gene is opened, if the product of it is not allowed to turn into a protein, the gene is effectively silenced. And microRNA 21 specifically is one of the most abundant microRNAs in mammalian tissues. It is the most upregulated miR in solid tumors and hematological malignancies, as sometimes people call these oncomiRs. And it regulates T cell immunity with a central role in setting a balance between Th1 and Th2 responses and T helper 17 differentiation. And when we've knocked out miR21 in the donors, again, we see a very dramatic phenotype. And I won't go into too much behind this, but what is most exciting to me about this is that miR mimetics and inhibitors exist. They are commercially available and currently in clinical trials for different conditions. So I think that this opens up a whole new world of potential novel therapeutic for our patients. So to conclude, the donor immune response is heavily regulated via epigenetic mechanisms as evidenced by human and murine data. And how I view epigenetics is like being in a traffic jam and you can't really see what's going on. You don't know where the roadblock is because all you can see in front of you is cars. But looking at the epigenetic regulation of these conditions and what is turned on and off, it's kind of having like a satellite view of the situation that can help us decipher things. So in future directions, I'm most excited about using epigenetics in transplant as a discovery tool to help us find new therapeutic targets for GVHD, and mainly to see if we can indeed find these pathways that uncouple harmful GVHD from beneficial graft versus tumor effects. We're looking more into the myeloid DNMT3 deletion and the TET2 phenotype and epigenetic modulators such as MERS, and then we're starting to look into the impact of host epigenetics. So I'll end here by thanking the Cowden Foundation for what they do and their efforts to raise awareness for GVHD. Thank you all for listening, and our patients and families for inspiring us to put in the hard work, and everyone who works in the lab to produce the data I showed you today. I'll take any questions if there are.
Here it is.
Use our microphone so our virtual guests can also hear as well. So.
That was a fascinating talk. Have you thought about inoculating your wild-type mice with like hypomethylating agents and seeing if it can reproduce the knockout phenotype? Because I imagine the methylome will look very different, but it has like translational implications with the maintenance, like onuregs and stuff that we're doing now.
Yeah, that's a really great question. And, that work has been done, and, it wasn't very good because I didn't do it. So it has been done. The challenge with using hypomethylating agents to study epigenetics or DNA methylation is that they are nonspecific. And even though we say they're hypomethylating, after, a certain dose, they can actually be cytotoxic, as even in the clinical setting we see it, And so if you want to really study DNA methylation in a very clean way, it becomes very difficult. So that work has been done. I think a lot of it is by the DiPerzio group, and they've seen different mechanisms behind it, that it can affect effector function, maybe can, induce Tregs. We haven't quite seen those same effects using, our approach. We use them in the patients. Like I said, they can be cytotoxic though. And I don't think we've quite been able to replicate the murine data when we've applied these agents in humans. So that's why we haven't, really used them as much in our lab up till now. And to say, when I say nonspecific, they're nonspecific in that, which DNA methyltransferases they may be inhibiting. There's not only DNMT3A, there are other ones, but also they have, other bystander effects to, other enzymes.
Awesome talk. Thank you so much. You mentioned MIR21 as one of the microRNAs you're looking at, but as you mentioned, it's like ubiquitously expressed. Are there any more specific microRNAs that has come up or that you're potentially looking at in terms of GVHD?
We haven't branched out into other, but there are published data. I think, microRNA 137 comes to mind as something that was recently published. And then Dan Peltier and his group work with other non-coding RNAs. He started that work with Pavan Reddy, so I can also direct you to some of his work.
Any other questions? Okay. Great, thank you so much. Thank you, Dr. Katana.
Okay, so we are right on time in here. Which is awesome. So we're going to move forward, and I'm going to introduce Dr. Emily Baumrin. And she is a dermatologist and internal medicine physician who treats patients with dermatologic diseases. Her research aims to improve the lives of patients suffering from dermatologic complications of transplantation and cancer therapies, including GVHD. She leads a research program that focuses on understanding skin GVHD and the best ways to prevent, diagnose, and treat this condition. She serves as Director of Penn Dermatology's GVHD disease, it's graft versus host disease, not GVHD disease, multidisciplinary clinic. And I am delighted to welcome Emily to the stage.
Thank you, Meredith, for that introduction. And it's always exciting to be around so many transplant clinicians and researchers and learn from all of you as a dermatologist in this very rewarding space. So again, my name is Emily Baumer, and I'm here from the University of Pennsylvania. And I'm going to be talking a little bit about measuring therapeutic response in sclerotic skin chronic GVHD in particular. Where we are now, what are some of the challenges and some of the efforts that we've put forth to better our measurement of therapeutic response for this condition. So I would like to start with a patient. This is a woman I take care of in the graft versus host disease subspecialty clinic in the Department of Dermatology. And I met her first 5 years after transplantation, when she developed diffuse swelling of her arms, trunk, and lower extremities. She had had a history of mild ocular chronic graft versus host disease and pulmonary graft versus host disease, which were actually very well controlled on topical and inhaled therapies only. But then she developed this more acute presentation. And over the next months, she progressed to develop sclerosis of about 85% of her body surface area. Her skin was hidebound, difficult to pinch. She had extreme shortness of breath because of the restriction in her chest, and she couldn't eat food because she felt so full from the restriction in her abdomen. She needed help with activities of daily living, like getting dressed, because of her limited joint mobility, and she had liked to play the piano, and she was no longer able to do that because of her wrist restrictions. She also described a lot of discomfort in her skin, so she had a lot of pain, felt like her skin was pulling or tearing, and this actually required pain medication to treat. So we started her, along with in the dermatology group, working closely with transplant clinicians, we started her on prednisone, followed by ruxolitinib, then belumosudil, then photopheresis. We did a trial of imatinib, and then most recently axatilimab. And this is her, the last time I saw her, a couple months ago, after about 2.5 years of therapy. As you can see, she's still quite severely affected by sclerotic chronic GVHD. But when I examine her, her skin feels softer. She's no longer having shortness of breath, and she can participate in exercise like yoga and physical therapy without feeling short of breath. She's able to play the piano, not like she used to, but she's able to do it. And she no longer has any pain in her skin. She hasn't had to take any pain medicine. So when I look at this patient, has this patient had a therapeutic response? And I think it depends on how we define therapeutic response, what measures we look at, and what our ultimate goals are. So I'm going to use this talk today to talk about what our current standard is, and then some of the efforts that we are doing to improve their measurement of therapeutic response. So taking a step back, sclerotic chronic GVHD refers to the process of fibrosis of the skin, subcutaneous tissue, and fascia. And the epidemiology has a big asterisk because what we have reported so far using big cohorts predominantly refers to the era before post-transplant cyclophosphamide prophylaxis, GVHD prophylaxis. So we really do need to understand, as was mentioned in the panel, how, what is the prevalence, incidence, and natural history of sclerosis in this new setting. But what we do know and what has been reported is that the cumulative incidence of sclerotic chronic GVHD is between 10 and 20%, with a median time to onset after transplant of 14 to 19 months. In terms of prognosis, the presence of sclerosis has been associated with prolonged immunosuppression, and the severity of sclerosis as measured by body surface area and the NIH skin score is associated with failure-free survival, which is predominantly driven by change in medication or failure of medication. So therefore, this highly morbid manifestation of chronic GVHD is associated with prolonged treatment courses. In terms of mortality, curiously, the presence of sclerosis and severity of sclerosis, again, by body surface area and then NIH skin score, has not been associated with non-relapse mortality, which is curious because it's a highly morbid manifestation. It's associated with lots of immunosuppressive medications, but we have not seen that association. Our group became interested if there were other measures of sclerotic chronic GVHD severity that might portend a worse prognosis in those that develop disease. This would help with risk stratification, selection of therapies, and when to de-escalate therapies. So we looked at patient-reported outcome measures, and we looked at 2 patient-reported outcome measures in a longitudinal cohort from the Chronic GVHD Consortium. We looked at the FACT BMT, which is a health-related quality of life patient-reported outcome measure specific to patients who've undergone transplantation, and the Lee symptom scale skin subscale, which is a symptom bother patient-reported outcome measure specific to chronic GVHD. And we looked at only the skin-focused questions. And we found that patients that suffered the worst symptom and health-related quality of life impact in patients with sclerosis had higher rates of non-relapse mortality, shown here in the blue line, for both health-related quality of life and symptom bother. So there are indeed patients with sclerotic skin chronic GVHD that have a worse prognosis than others. We just may not be capturing them by our classic clinical measures like body surface area and the NIH skin score. So what is our current standard for measuring sclerotic chronic GVHD therapeutic response in clinical trials? The current primary skin-specific endpoint is the NIH skin score, the 2014 version. And this is a composite endpoint comprised of 2 scales. The first is a body surface area assessment that's categorical, which measures body surface area involvement of both sclerosis, but also non-sclerotic disease, which constitutes maculopapular rash, lichen planus-like lesions, poikiloderma, keratosis pilaris-like lesions. So really that measures response in both sclerosis and non-sclerotic disease. The second is the skin feature score, which measures depth of sclerosis ranging from no involvement to deep sclerosis or hidebound skin. And lastly, there is an exploratory endpoint that is a clinician-perceived skin and joint severity, tightness severity, rated on a scale of 0, not bad at all, to 10, very severe. This is not used as a primary endpoint, skin endpoint in clinical trials. And then let's look at patient-reported outcome measures. So the Lee symptom scale is the current standard patient-reported outcome measure used in clinical trials. And it is a chronic GVHD specific measure that asks patients about symptom bother in multiple different organ systems. So this is not the entire measure. I show here just the skin and the muscle and joint domains, which have questions that relate to sclerosis, particularly thickened skin and limited joint movement. And this is typically collected as a secondary or exploratory endpoint in clinical trials. So now I'd like to take us through kind of the seminal studies of our FDA-approved therapies for steroid refractory chronic GVHD, so we can see how these current clinical trial endpoints perform and highlight maybe some of their shortcomings. I'm going to skip over ibrutinib because that study was performed prior to the 2014 NIH consensus criteria. And so we'll start with the REACH3 study, which was a phase 3 study of ruxolitinib versus best available therapy in steroid refractory chronic GVHD. These tables are from the supplemental section, but these are organ-specific responses of the skin in particular, which was reported by the NIH skin score, which I just showed. So the NIH skin score organ-specific response was 41% in the ruxolitinib group compared to 15.5% in the best available therapy group. Now that's a great response, but what we can't determine from this is which of these responders had sclerosis in particular compared to non-sclerotic or combination disease. The investigators didn't stratify or report the stratification of non-sclerotic and sclerotic subtypes. So that's a major issue in our current response criteria. So let's move on to the ROCKSTAR study, which was the phase 2 study of belumosudil and steroid refractory chronic GVHD who failed 2 or more lines of therapy. So in the optimal belumosudil dosing regimen, here reports the organ-specific responses. And again, the skin response is reported by the NIH skin score as our standard primary endpoint of 37%, with 16% complete responses. In this study, investigators report each scale of the NIH skin score separately. So the body surface area score, the skin feature score, and the clinician perceived sclerosis severity scale of 0 to 10. And again, what's difficult to ascertain is how many patients had sclerosis and what were the responders with sclerosis who had sclerotic disease and non-sclerotic disease as reported. And then lastly, I'll go to the AGAVE trial, most recently of axatilimab, which was a phase 2 study of axatilimab at varying doses for steroid refractory chronic GVHD. Again, the primary skin endpoint, the NIH skin score, was reported as a partial or complete response in 26% of patients. And the investigators took it one step further. They did report each scale separately for the NIH skin score, the skin BSA score, the skin feature score, and the clinician perceives sclerosis severity scale. They also reported the least symptom scale overall, but the question specifically of skin thickening as it relates to sclerosis. The denominators for all of these scales are different because the investigators did report just the group of patients with sclerosis for these sclerosis-specific response measures. And so you can see the responders in the sclerotic population. I'd like to take this data to highlight one fact that we delve deeper into when we're thinking about improving response criteria, and that the clinician-perceived sclerosis severity scale and the Lee symptom scale have much higher response rates than our NIH skin score metrics, the BSA score and the skin feature score. And that demonstrates that even when clinicians and patients think that they are getting better, they may not meet our NIH consensus criteria for response by body surface area assessment or depth of sclerosis. So I go through our current standard and then these seminal trials that support our FDA-approved therapies for steroid refractory chronic GVHD to highlight some of the shortcomings of our current response criteria. First, we have a lack of standardized and sclerosis-specific endpoints for clinical trials. So all of these studies report kind of different metrics and different subpopulations, which make interpretation difficult, but also comparison of therapies difficult for clinicians to interpret for patients. So we need more standardized endpoints to promote comparative effectiveness trials. Second, the NIH skin score does not differentiate response in sclerotic skin from non-sclerotic skin, just because it is that composite endpoint of body surface area response of both subtypes. And lastly, just notice that the NIH skin score response rates are overall really low. In all of those trials, if you look at each organ system, the skin is always on the right at one of the lowest response rates. And that does highlight the need for more effective therapies. As I showed with my patient at the beginning, sclerotic chronic GVHD is a highly morbid manifestation, and we definitely need better therapies for this condition. But it also highlights the need to revise our response measures because maybe they're not capturing therapeutic benefit or clinically meaningful benefit for patients and clinicians. So now that I've reviewed that the clinician-reported outcome measure of the NIH skin score and the patient-reported outcome measure of the Lee symptom scale are kind of our standard, our group became interested in comparing these two to see when they correlate, when they don't, and how they compare to one another in terms of prognosis. And some of this work has been previously done. So a secondary analysis of the Rockstar data, the belumosudil data, by Stephanie Lee et al. Demonstrated that patient-reported outcomes and clinician-reported outcomes are not always correlated. So on the top of this table was investigator-assessed response by NIH consensus criteria, and on the bottom was patient-reported clinically meaningful response by Lee symptom scale, both overall and then in each domain for each organ system. And if you look at the overall line, they're actually pretty similar. So overall response for investigators was 76%, and overall response for patients was 80%. But then if you look by organ system, they can be quite mismatched. And so for the skin in particular, the investigator-assessed response was only 35%, but patients, almost double the patients thought that they had a response in the Lee symptom scale, skin subscale. So we became really interested in who are the patients where these match and who are the patients where these don't match? And this would be incredibly useful interpreting these data. When should we go by more of what the patient says? When can we trust the clinician's response and inform our interpretation and design of clinical trials? So we designed a study to identify the clinical factors associated with discordance in clinician and patient-reported treatment response for skin chronic GVHD in particular. And we evaluated then the association of the clinician-reported treatment response and patient-reported treatment response with survival to see which measure may be more prognostic when assessing treatment response. To do this, we designed a longitudinal cohort study using 2 observational studies from the Chronic GVHD Consortium and a randomized control trial of imatinib versus rituximab for sclerotic chronic GVHD. We included patients who were adults and who had a diagnosis of cutaneous chronic GVHD by NIH consensus criteria. In terms of our outcome measure of interest, in contrast to what I showed you in the belumosudil data, we used a single question asked of clinicians and patients, which asked them to rate their treatment or their GVHD response 3 to 6 months after enrollment in any one of these studies. And so the question asked of clinicians and patients were the same, so direct comparisons are more easily made. And we focused on the skin only. So we looked at 489 patients with skin chronic GVHD, and we found that about 2/3 of patients had a concordant treatment response between patients and clinicians, and about 1/3 of patients had a discordant treatment response. We further stratified discordance into negative clinician discordance. That's when the clinician thinks the patient had a worse treatment response than the patient, and positive clinician discordance when the clinician thinks that they had a better treatment response than the patient. There was no difference in concordance by sex, age of the patient, but notably there were more white patients who had a concordant treatment response compared to other races. We then looked at clinical features of chronic GVHD that might predict this discordance. So how do we find out what patients, are more likely to have a discordant treatment response when we initiate therapy? And we found that the presence of sclerotic chronic GVHD or the presence of sclerosis, regardless of non-sclerotic disease, was a notable risk factor for having discordant treatment responses between clinicians and patients. And this was both positive and negative clinician discordance. So clinicians were both rating that the patients was doing better than they thought they were, and that they were doing worse in both directions. The other variables that made it into the multivariate model are closely related to sclerosis. So that's photographic range of motion, which measures the joint restrictions, the NIH Joint Fascia score, and the Karnofsky Performance Score. They were not significant in the multivariate model when accounting for sclerosis, but are closely related. So we conclude from this that the presence of sclerosis is a risk factor for having a discordant treatment response between patients and clinicians. We then wanted to see, okay, well, which of these measures might be better in determining prognosis? So we evaluated the association of patient-reported treatment response and clinician-reported treatment response with non-relapse mortality, adjusting for confounders associated with mortality in the multivariate models. We looked at the subgroup of 234 patients with sclerosis, and we found that patient-reported treatment response was associated with non-relapse mortality. So patients who said that they were improved on the light blue line had less odds of non-relapse mortality compared to those that said that they were the same or worse. In the clinician-reported treatment response, we did find that the point estimates went in the same direction, but they were no longer statistically significant. So the strength of association between patient-reported treatment response and non-relapse mortality was stronger. So the conclusions from this study is that sclerotic skin chronic GVHD is associated with discordance between clinicians and patient perception of treatment response, and that patient-reported treatment response is associated with survival for these sclerotic patients. Some key takeaways from this study is that to highly emphasize that PROs in general are a really important endpoint for our sclerotic patients. I showed initially that they are associated with mortality in terms of the severity of impairment, but now I show that the patient-reported treatment response is also associated with mortality. And so it may be capturing benefit that we're not capturing with our clinician metrics and assessments. It also highlights the fact that better clinician-reported outcome measures are needed. We lose some of that prognostic association with the clinician-reported treatment response, which is probably highly informed by our clinical assessments like body surface area or depth of sclerosis. So what can we capture that's going to be a better prognostic marker for these patients? And then lastly, there's a whole literature on discordant severity grading and discordant treatment response grading between clinicians and patients. And just the fact that this exists can promote issues with patient-doctor relationship, patient satisfaction, And it highlights just the need to investigate kind of whether there are more non-clinical factors associated with the discordance that we can target with more psychosocial or clinical implementation interventions. All right, so I'm going to move on, shift gears a little bit. I've used kind of some of the work that we've done so far to highlight the importance of patient-reported outcome measures in sclerotic chronic GVHD. And so I worked with Stephanie Lee and other collaborators to develop a novel patient-reported outcome measure to measure sclerotic chronic GVHD, and I'll take you through some of that work. So just to remind you, the Lee Symptom Scale is our current standard endpoint, patient-reported outcome measure collected in clinical trials, and it has the skin and muscle and joint domain that relate to sclerosis. And these two questions in particular, thickened skin and limited joint movement. So we became interested in if the Lee Symptom Scale, as it stands currently, is sufficient to capture outcomes of importance to patients with sclerotic chronic GVHD. To do this, we performed a formal PRO development protocol as recommended by FDA best practices so that a PRO can support labeling claims and be incorporated into clinical trials. So this methodologic framework is proposed by the FDA for PRO development. The first step is to hypothesize the conceptual framework of the outcome you are trying to measure. And this is done by defining the population, literature and expert review, and patient input. The next step would be to draft the instrument based on the conceptual framework developed, and then to test whether the instrument or the patient-reported outcome actually measures what it's intended to measure by content validation testing. And then the next step after that is, once the instrument is formalized, to assess reliability, construct validity, and ability to detect change. Because if the instrument doesn't have these things, then what you're studying in a clinical trial setting or to measure therapeutic benefit won't really be reliable or you won't be able to interpret it. So following this guidance, we performed a concept elicitation study using semi-structured interviews of patients with sclerotic chronic GVHD at Fred Hutchinson Cancer Center to identify concepts of importance to patients with sclerotic chronic GVHD. We then used these interviews along with expert review and literature review to draft a novel patient-reported outcome measure. And then we tested the patient-reported outcome measure with cognitive interviews to test content validity. And cognitive interviews is a method where you administer the patient-reported outcome measure to a patient, you have them take the entire measure, and then you ask them questions about comprehensiveness, readability, clarity. You get their feedback in a semi-qualitative manner, and then you make iterative refinements to the instrument. So we enrolled 36 patients with sclerotic chronic GVHD, and just to highlight, the median duration of sclerosis was 3 years. So these were kind of heavily treated patients with sclerotic chronic GVHD. We included patients who had multiple different anatomic sites involved. You can see here upper extremities, lower extremities, chest, abdomen, and back, because these may have different symptom and functional impairments depending on the anatomic location of involvement. Using thematic analysis of semi-structured interviews, we identified 5 domains of importance to patients living with sclerotic chronic GVHD. These are skin changes, symptoms, emotion social functioning, mobility restrictions, and activity limitations. I'd like to read you a few representative quotes that inform this thematic analysis. Oh, you know what? It didn't capture all of it, but I'll read some that fit. So for symptoms, there was a time when I could feel my body getting tighter and tighter by the day. And then emotional social functioning. I developed heavy social anxiety dealing with this condition. There are instances when I was treated less than human. Some of this got cut off, but I remember some of them. And for skin changes, you can tell that the skin is getting tight. It looks like cellulite, the skin dimpling. So we use these semi-structured interviews as patient input to develop items in a patient-reported outcome measure. This measure, pictured here, is called the Lee Symptom Scale Skin Sclerosis. We then pilot tested this patient-reported outcome measure with patients doing cognitive debriefing interviews. Based on their feedback, we took away items, added items, and made items more clear. The Lee Symptom Scale Skin Sclerosis is a 55-item measure split into skin symptoms and activities. And although there are quite a few items, the average time to completion was 3 minutes, and patients rated the questionnaire as both acceptable and feasible. So just to review, the Lee Symptom Scale Skin Sclerosis measures symptoms and functions related to sclerotic chronic GVHD for adults. The target application would be in therapeutic clinical trials focused on steroid refractory chronic GVHD, in which sclerotic chronic GVHD is often represented, and or for sclerotic skin chronic GVHD specific clinical trials. And its use as an adjunct to the Lee Symptom Scale for those with sclerosis, to be used in addition. We are currently doing reliability, validity, and responsiveness to change testing, and that will be published soon. All right, so now I'd like to switch gears from patient-reported outcome measures to clinician-reported outcome measures. So just to remind you, the 2014 NIH Skin Score is the current primary endpoint to measure skin response in clinical trials and has the 2 scales that I mentioned previously. However, through reviewing some of our data of the seminal trials for our FDA-approved therapies and some of our own data, we've highlighted some shortcomings of the 2014 NIH Skin Score. And the 2 predominant shortcomings are that the response measures both response in sclerotic skin and non-sclerotic skin because of this composite body surface area assessment, and that the overall skin responses are low, even when clinicians and patients may perceive benefit. And so the body surface area response requires quite a bit of response, going from greater than 50% to between 19 and 50% might be difficult to achieve. And the deep sclerosis features, resolving that into superficial or no sclerosis, may be very difficult to achieve even when patients and clinicians think they're benefit. So many patients with sclerosis sit at this NIH Skin Score of 3 and are unable to move, even if they may kind of perceive some benefit in their sclerosis. So to address these limitations, we developed the Skin Chronic GVHD Task Force as part of the NIH Consensus Development Project on criteria for clinical trials in chronic GVHD. We first met at the NIH workshop on immunotherapies and cellular therapies for systemic sclerosis and chronic GVHD over a year ago now. And this is a group of pediatric and adult transplant clinicians and researchers and dermatologists with expertise in chronic GVHD. And this was spearheaded by Steve Pavletic, Ed Cowan, Alina Markova, and other colleagues, and has been a tremendous effort. At this meeting in May 2024, we defined the problem that I just described to you. And then we met again in Vancouver at the Chronic GVHD Symposium to propose changes to the NIH skin response criteria so that, 1, we could determine disease response in non-sclerotic and sclerotic subtypes, and also that we may achieve better response rates. And then lastly, we met again at the Tandem meeting in February 2025, where we review and revise the proposed criteria and examine case studies on how this criteria would perform in different cases of chronic GVHD. The finalization of the response criteria was still underway when I made these slides just a week or 2 ago. It's finally ready for publication. And so I didn't include the final response criteria today, but it will be presented at the Tandem meetings this year and published hopefully in TCT soon. And then I'd like to end by just reviewing some of the more promising objective non-invasive modalities for the measurement of sclerotic skin chronic GVHD. And, if valid, these are really the way forward in terms of overcoming some of the issues that we have with patient-reported outcome measures and clinician-reported outcome measures that I've discussed today. So I'd first like to start with the Myoton. How many in the audience have heard of this device? Okay, we've got a group over here at this table, Deb in the back, but most people know. So I'll go from the beginning. The Myoton is a handheld device. It's shown here. And it uses a single mechanical impulse to measure the soft tissue biomechanics. And it measures 5 parameters: oscillation frequency, dynamic stiffness, logarithmic decrement, mechanical stress relaxation time, and creep. But for sclerotic chronic GVHD, that dynamic stiffness could be really relevant in measuring kind of the stiffness of the skin and its response over time. Much of the work in sclerotic chronic GVHD for the myoton has been done by a friend and collaborator, Eric Tkachuk at Vanderbilt, and you can see him here holding the device. This is on the device's website. But he has shown that there's inter-rater reproducibility of the myoton in measuring sclerotic chronic GVHD, that it can differentiate sclerosis from non-sclerotic skin, and that it is even responsive to change when measured against clinician assessment. So there's been a lot of validation testing of this instrument in sclerotic chronic GVHD in particular. And I think the next step would be to start incorporating it into some therapeutic trials as an exploratory endpoint to see how it performs in that setting. Another thing that people ask me a lot about is, what about MRI? Are you using that? Is that good for detecting sclerotic chronic GVHD? So there have been multiple small, usually single-arm prospective studies on magnetic resonance imaging for sclerotic chronic GVHD. And you can see that MRI imaging, both with and without PET, can detect skin and fascial chronic GVHD. So here on the top row is PET MRI imaging for panel B and C, and you can see enhancement of the fascial and muscular components in a patient with sclerotic and fascial chronic GVHD. On the bottom are MRI images, T1 weighted with and without contrast, and T2 weighted, which show enhancement of the subcutaneous and fascial compartments in patients with chronic sclerotic GVHD. However, follow-up studies which have looked at MRI as a therapeutic response measure, getting serial MRIs over time, have not found that the MRI is responsive to change when compared to clinical assessment. And so the changes observed may not be kind of rapidly reversible or specific enough to detect changes over time. So how do I use this modality in my clinic? I will use it to help diagnose sclerotic chronic GVHD when my clinical examination when clinical findings are subtle or when you're unsure of ruling out other causes, but I will not use it as a response measure. And then I'd like to conclude the talk by just briefly mentioning biomarkers. And I love it because I think Yuli also had a holy grail, right? This would be the holy grail in measuring therapeutic response for sclerotic chronic GVHD. And unfortunately, most of the biomarkers are in the discovery phases, but there's a lot of work being done. So this was a table we put together as part of the Skin Task Force, which reviews some of the soluble biomarker candidates, cellular biomarker candidates, and even skin tissue biomarker candidates that are in discovery and validation stages for general systemic chronic GVHD and skin chronic GVHD in particular. And I'd just like to highlight two kind of key points with this table. One is if you look at the type of biomarker that's mostly in development, these are diagnostic or risk biomarkers. So that's helping to assist in diagnosis of chronic GVHD or to predict risk of developing chronic GVHD. But they're not being designed to study therapeutic response. And then the second that I'll highlight is just that the markers that are in validation phases are more for multi-organ systemic chronic GVHD and again, diagnostic and risk. So therapeutic response biomarkers are a huge unmet need in this field and definitely require more investigation and in that setting. So I'd like to conclude by just summarizing what we talked about today about measuring therapeutic response in sclerotic chronic GVHD. First, I reviewed that the NIH consensus criteria and Lee symptom scale are the current endpoints used to measure therapeutic response, but they have their limitations. Patient-reported outcome measures are important endpoints in sclerotic chronic GVHD because they are often discordant between clinicians and patients and are prognostic. The Lee Symptom Scale Skin Sclerosis is a novel patient-reported outcome measure to measure therapeutic response from the patient perspective in sclerotic chronic GVHD. And new NIH skin response criteria have been developed. Stay tuned. And then lastly, non-invasive modalities and biomarkers are really an unmet need and research priority for this condition. I'd like to thank my research team at University of Pennsylvania, collaborators at Fred Hutch, and my funding sources. Thank you.
Any questions?
This might be in part of your coming soon, but in the 55-item questionnaire, how do you narrow that into, how do you take that questionnaire and turn it into response criteria, or is that going to be reported?
Yeah, so what we have to do is we have to basically evaluate responsiveness to change as a psychometric property, because when you evaluate responsiveness to change, you'll get like the minimal clinically important difference. And what we do is we measure the patient-reported, the Lee symptom scale skin sclerosis, and then we'll measure it against other PROs. And you'll use an anchor-based approach to determine clinically meaningful difference. So we know that the clinically meaningful difference, for example, of the skin subscale and the Lee symptom scale is 11. So what is the score differential in our new PRO instrument that matches that score 11, and then that score will determine clinically meaningful difference. We also compare it against a global patient question anchor, like, you know, how much do you think your GVHD is better on a 7-point scale, from like very much worse to very much better, and that will be an anchor. So we say, okay, it's clinically meaningful if a patient went from about the same to moderately better. That's a 2-point difference. What's the score difference in our new PRO that matches that clinically meaningful difference? So that's basically formal psychometric testing that we're gonna do, and then we would publish a score difference that's clinically meaningful.
Is it possible that different parameters have different weights? Like a change in one matters more than a change
Yeah,
in
that's a
another?
great question. So what we do is we do something called like factor analysis to see which questions kind of group together. And then we will actually test each of those domains separately, and some of the domains might be weighted more than other domains. So let's say skin changes, like the dimpling, or you know, is not as important. It'll have a lower kind of, it'll have a different weighting in the domains that we find. But we have to do factor analysis to see which group together.
Are there any efforts underway to look at any of this in pediatrics?
It's such a good question, and you know, the PRO realm is you know, it takes so much work to develop and validate PROs, and then they have to be done for your developmentally appropriate age. And so my work has all been in the adult population, but Sandy at the NIH has been working to adapt the Lee symptom scale to pediatrics. That's not a sclerosis-specific measure, but definitely a patient-reported outcome measure. She's been basically working to have a pediatric version of the Lee symptom scale.
All right, thank you so much. That was a great talk, and we're excited for what's to come. So now we have a break, I believe, to get lunch, and then come back at noon for our keynote speaker.
Okay, starting effort 3. Great.
All right, we're going to get started in just a few minutes, but just a reminder, if anyone has questions, to write it down on that paper and pass it over, pass it on to the table in the corner, purple sweater. We'll get started in a few. All right, we are going to get started. Do we have his slides? Oh. Well, while we're pulling up the slides, please continue to eat. This is, eat and listen. I'm really thrilled to introduce our keynote speaker. I was really excited about nominating him, and so I get to have the pleasure of introducing him. So Dr. Andy Harris is a pediatric transplant and cell therapy specialist at Memorial Sloan Kettering Cancer Center in New York. He did his med school at Case Western. He's actually from Ohio, for all the Ohioans, from Toledo, Ohio. Did his med school at Case Western, and then residency at Cleveland Clinic, and then fellowship at Michigan, and was there for a few years, then went to Utah, University of Utah, and then now is at MSK. And again, he's a pediatric transplanter. He's an internationally recognized expert in graft versus host disease, is the director of the MSK Kids Multidisciplinary GVHD Clinic, where he leads a team that sees children from around the region to help manage their complicated and treatment refractory GVHD. And I think that's really cool because I don't know of any, other pediatric focused GVHD clinics. So I think that's amazing. He leads international trials working on new testing and treatment strategies for GVHD. Another amazing thing about Dr. Harris is that he's a 27-year leukemia, stem cell transplant, and GVHD survivor, which was his motivation to get into this challenging field of medicine. And so again, we're really excited. I've known Andy now for many years, and he's just an inspiration, on many levels. And we are really excited to have him as a speaker, since he's able to speak about GVHD from the personal point of view and from, as one of the experts from a professional point of view. So Dr. Harris, take it away.
Thanks for the really kind introduction, Amy. We've known each other for, 12 years, give or take now. It's a real honor to be here speaking to you all today and being back in Ohio, getting back to my roots. I've known Meredith for a few years now, and the work that she's doing for her foundation is really, really special and really incredible. So it's really a joy and an honor to be here. I'm going to talk a little bit about my journey to getting where I am today, and then talk a bit about my clinic here. There are a handful of multidisciplinary GVHD clinics around the country. As Annie appropriately mentioned, there's fewer in pediatrics than there are in adults, but there are a lot of them out there, and all of them are a little bit different in how they do things. So I'm going to share a bit about my philosophy and vision for how we do and why we do what we do there. And certainly there will be time for some conversation afterwards. So I'm going to start here. This is my freshman year of college spring break. We are in Florida in front of Margaritaville. This is my older brother to the left of me, and I'm the one with the long hair here. I was in engineering school. I was playing semi-professional soccer and having a relatively fun life. But I wasn't really enjoying engineering and switched to a pre-med major for my following school year and started in the lab. And unfortunately, while I was actively playing soccer, in fact, I was getting encouraged to try out for the Columbus Crew because they were still having open tryouts back in the late 90s with how early the MLS was. I went from, over my winter break for the holidays, going from being a world-class fitness, being able to run miles upon miles without issue, to having to stop to catch my breath on campus while carrying my backpack, which was certainly not expected. And unfortunately with that, we made a diagnosis of acute myeloid leukemia in February. It was Friday the 13th of February, 98, and I'll never forget that day. I was transferred up from Toledo to the University of Michigan because it's the closest large academic center. And this was me the night before I shaved my head. My girlfriend, who is in the back upper right there, always wondered what I would look like with dark brown hair to match my eyebrows, since I always had that blonde hair. And so we did that night, and then the next day we shaved my head. And then I went through my first 2 cycles of chemotherapy. There was absolutely no response to that chemotherapy. It was, for the doctors in the room, escalating dose ida doctor. And this study in the Children's Oncology Group at the time was the CCG. The COG wasn't even founded yet. Was stopped because of toxicity. We were having too many patients die due to toxicity of the therapy, even though it seemed to be very effective. For me, I got through the therapy, but my leukemia was still, roughly 60% blast after induction, so I was a primary induction failure. We got a relatively new salvage therapy that got me into remission at the time. It was mitoxantrone, etoposide, and cyclophosphamide, for those in the room that know these things. And went on to a transplant for my sister, you see in this picture on the right. And Roughly a month after my transplant and discharge, my family had been going to this summer vacation spot every single year that was roughly half an hour from the University of Michigan. So they gave me the permission to go there instead of going straight back to my house. And we had some fun while we were there. Here you see we were in togas. So throughout that summer, I was working on getting back in shape and trying to figure things out, but had very frequent follow-up in the hospital until I started to get very, very jaundiced. And I developed biopsy-proven acute GVHD of the liver that unfortunately did not respond to steroids. And back in 1998, there was not a lot of treatment for graft versus host disease that did not respond to steroids. And so at that point, my parents had told us to get my affairs in order. This is a picture. I had put on a lot of steroid weight, was still quite jaundiced. My brother and sister were brought up to see me to say goodbye. And at that time, I promised that if I made it through, if I survived, I was going to come back and work on making transplants safer and more effective because what I was going through absolutely sucked at the time. And so I'm sure you can figure out, I made it through. And as my lovely and talented wife, who's in the back of the room over there, could tell you, I was stubborn enough to see that promise through. So over the following 10 years, I finally got back to college, completed my undergraduate studies, and that took 3 years since I was through a year of college. During that time, I started training martial arts, taught martial arts, and had the opportunity to go train soldiers and go around the country and teach women self-defense. Went on to medical school. During medical school, I became a husband and a father, and becoming a father was a big surprise to us because we were told that wasn't going to be a possibility. So there was a lot of interesting conversations with family members about the fact that we were expecting children. Then went on to my pediatric residency, as you heard, at the Cleveland Clinic. And then 10 years and 36 days after my bone marrow transplant, I showed up back at the University of Michigan as a pediatric hematology and oncology fellow, which is a doctor in training. So my very first month as that children's cancer doctor in training, I was on the bone marrow transplant service working with Dr. Yannick, who was my primary transplanter. So the two of us, for those 2 weeks together that we went about seeing the patients and everything else, didn't say a single thing about the fact that I was this patient before. And so at the end of it, I said, Greg, I've been working really hard to come back here and do this. I've got to say it's been an absolute joy getting to work with you, and it's been very surreal. He looked at me and said, Andy, think of how weird this is for me. So it's been it was a wonderful journey, and from there, I started my career, focusing on bone marrow transplanting and graft versus host disease. So as a cancer fellow, part of your job during those 3 years is to do a research project. And my research project identified a blood test that helped us with diagnosing and prognosticating for acute graft versus host disease that affects the intestines. And as a follow-up to that, we worked on revising our staging and grading guidelines for acute graft versus host disease. And I had the privilege of being the first author for a paper that now is what is used internationally for acute graft versus host disease data capture on any clinical trial that's capturing clinical data. So my career got off to this huge jump start from being in the right place at the right time and taking advantage of the opportunities that were given to me. And then we had this mass exodus of our bone marrow transplant team at the University of Michigan. I moved across country to the University of Utah, where I had to reinvent myself a bit. So there, on top of working on acute graft versus host disease, I started to work on chronic graft versus host disease and started collaborating with a good friend, Kirk Schultz, who's up in Vancouver, British Columbia, Canada, on working on biomarkers for graft versus host disease, that's chronic graft versus host disease in children. And we're still doing the analysis of this second iteration and starting to figure out the next phases of that. Unfortunately, Utah was not a great fit for our family, even though it's an absolutely beautiful place to live. And we moved across country 4 years ago to Memorial Sloan Kettering Cancer Center. And when I went there, I was tasked with leading a pediatric multidisciplinary GVHD clinic. That's going to be a big part of the rest of this talk, as well as overseeing our portfolio of clinical trials in both acute and chronic graft versus host disease. And over the past several years, I've been fortunate to go around the world and around the country to be able to talk about graft versus host disease and treatment, progress, research, all of the above. So moving on now to chronic graft versus host disease and how we manage this. As you all know, chronic graft versus host disease can affect almost every single organ in the body and system in the body. We often rely on some of our subspecialist counterparts to help us with diagnosis and management of things. And so when we see a patient, We send them out to another subspecialist. They come back to us. We hear back from them. We send them over to see some other people. They come back to us. We hear back from them. We send them to somebody else to get additional help, and they come back to us. And as you can imagine, as a patient, this is a lot of time spent going to and from doctors. This is a lot of time hearing from different people, different perspectives, sometimes hearing mixed messages from different doctors, and having my transplant physician trying to coordinate this all, put it all together, and help me figure out how to move forward with my treatment. There's a lot of barriers and limitations in this model. And first and foremost is that a lot of our subspecialists, first off, have very busy clinics themselves, so there's often long wait times for them to get in to see them as a new patient. But some of them are not part of the same health system, so they may not be sharing health records. And on top of that, a lot of them have a lot of expertise in chronic graft-versus-host disease, so we rely on them to tell us what they're seeing and try to have to put it together ourselves, how this fits into our patient's chronic graft-versus-host disease journey that they're in, and figure out how to go forward. As I mentioned, there's a lot of time spent going to and from clinic. This is days away from work, days away from school for the children and from their parents from work, traveling away from their support structures and their loved ones close to home. And there's some risk with this as well. You can get some repeats of tests, sometimes that are not needed. There can be gaps in communication between the subspecialists. And certainly the rehab doctor and the pulmonologist are probably not talking to each other because they're not aware that they're both seeing the patient. Everybody's going through the bone marrow transplant specialist. Sometimes things will be missed because they're expected to be seen by somebody else, and you can get some conflicting advice, treatment guidance, things like that. So I think that while these colleagues helping us with the management of our patients is really important for trying to do our best we can for our patients with chronic graft-versus-host disease, I certainly think that we can do a lot better. And this is where this multidisciplinary GVHD clinic approach comes about. So instead of sending the patient out to see all these different doctors and all this communication, all this travel, why don't we bring all the specialists, all the doctors together in one space and have the patient come to us as opposed to us sending them to them. And this leads to no delays in assessments and assistance, no fragmentation of care. We're all in the same room. We're all talking to each other. And we are able to identify subspecialists that are committed to really learning about chronic GVHD in their area of focus that can really provide a lot of expertise for our patients' care. And when we bring them all into the same room, everybody's able to share their observations, their concerns. They can ask a question of one of their colleagues about how does, for example, I've got a kid that's got both scleroderma and lung GVHD, and so my dermatologist, my pulmonologist were able to talk about how the thickening of the skin around the chest was impacting their lung function and their test, and trying to get a better feel for how we can work together with both those teams to improve care from both aspects there. We also make sure that something that one of our doctors wants to do for our patient isn't working directly in opposition to the goals of care from one of the other doctors, so we can learn to compromise, work together to find common treatments that are going to make sure that everybody's goals are being met, most importantly the patient's. And we're able to make this comprehensive treatment plan that's harmonized amongst all these doctors to really help move forward through this team medicine. And the last part of this that I'm really excited about is when you bring all these subspecialists together that are at the cutting edge of their own fields, they can bring some of the new treatments, some of the new diagnostics to this clinic, and we can talk about, are these things that may be of benefit for our patients? And if so, let's explore making a clinical trial for our patients using this new thing that's from this other field of medicine to see if we can advance our field and improve our patients' care, improve their outcomes. So in our GVHD clinic, we have a huge team. We have our dermatologists, our pulmonologists, our GI doctors, my rehab doctor. I've got an ophthalmologist who's not in our clinic because they need specialized tools, but is a regular referral, and I've known her since kindergarten, ironically. She was already established with the team by the time I got to New York, but we've known each other since we were young children, so we have a very close working relationship. I also am very fortunate to have a pediatric and adolescent gynecologist who works with our team. This is something that's really a rarity, and I wish that there were more gynecologists that were involved in GVHD care and getting expertise there, because the gynecologic issues that our patients can experience can be frequent and they can be severe. We have dentistry that works with our team that are situated just a floor down and come up and see our patients. We have nurses. We certainly have transplant specialists, which I forgot to put on here. We have a nutritionist that comes. We have our pharmacist that's able to review all the medications with our patients because they're often on many, many medications. We have to worry about interactions, side effects, and they are able to do education with the patients, but also help guiding us when we're putting a new medication on and how that may impact some of our other medications that we're prescribing to our patients. And then because I'm in pediatrics, we also have child life that comes and engages our patients to make this a little bit more of a pleasant experience, because it's a very busy day when you're seeing all these different doctors. So when I'm looking to bring somebody new to this clinic, and this is something that I get a question about from a lot of my colleagues, is how do you get somebody from one of these fields to come to your clinic? And the first thing is that you need to have a lot of passion, and you need to put yourself out there. So the newest member of my team is our gynecologist, and I had reached out to, because I'm at Memorial Sloan Kettering Cancer Center, and we're a pediatric division within a larger adult cancer hospital. Thankfully, right across the street, we have Weill Cornell Medical Center. So I reached out to the head of gynecology there and said, do you have anybody working in the pediatric and adolescent space that'd be willing to work with my team? She said, well, I don't right now, but I've just recruited somebody that's really going to focus on pediatrics that's just finished a pediatric training. And she needs a niche to work in, so why don't you reach out to her and see if she'd be interested in supporting your clinic? And it just so happens that she has a very big interest in supportive care around gynecology and pediatric oncology in general. So this was something that she was very excited about, and we're working together very closely, and we're very excited to have her. But for me, that was a lesson that when you're reaching out and they say, I've got nobody in this space, you can say, do you have a young doctor that's still trying to find their home, their expertise, their niche? I can help them build that reputation, which helps with their promotion and their satisfaction with getting this expertise. And that's really, I think, a nice way of getting people involved in this. So really, it's finding one dedicated individual from each of these places. I can dedicate a day of clinic and preparation once a month for right now. And as things build up, we may have to add an additional day on. But if we're having that much success, it's usually an easy ask to have that incremental increase for them. And so for this multidisciplinary GVHD care model, instead of having the patient going all over the place, we all come together to support that patient and to provide this harmonized global care that we do now. And I think this is a much better model from a quality of life standpoint for our patients, but also from a quality of care that they're receiving as well. So this is our team here. I've got everything from, let's see, the laser's not going to help for all of this, but I've got some of our transplant and oncology fellows will come to learn how to do team medicine in this clinic. And so this gal on the far left, I'll go from left to right, is one of our fellows training in transplant that joined us from Saudi Arabia. And then I have my rehab doctor, Dr. Abanis, next to her, and Binny next to her is our pharmacist that works with us. Dr. Hans was another one of our transplant fellows that came to clinic that day and is now in South Carolina. One of my nurse practitioners, Joanne, is right next to her. Amy is right in front of me there, and she's our pediatric gynecologist. I'm that guy in back with the scruffy beard. We've got a couple nurses in front of Alina Markova, who's our dermatologist, who's excellent and does a lot of work in graft versus host disease from the dermatology standpoint. The tall gentleman next to her is Stanley Joe, who's one of our gastroenterologists who sees our patients. And then Andrea Harris is just in front of him, who's one of our pulmonologists. Not pictured here is our dentist, who comes up and works with our team. And I'm missing our child life specialist and our nutritionist, who are also here every single week. So we've got this nice big team, and everybody enjoys each other's company. We look forward to this clinic every month. And we're working on a lot of papers and research together, which I think is really exciting for trying to push this field forward and being able to share what we do outside of the walls of our clinic to try to help everybody else as well. So how does this work when patients come to clinic? So we actually have to do preparation beforehand. So we look at our schedule. We reach out to any of the outside transplant centers that are sending patients our way that are scheduled to come to clinic and get recent records that we can all review from our different perspectives. And then we have this virtual meeting where we talk about who all is going to see a patient. So if it's a new patient, we make sure that everybody sees them for a global assessment, but for patients that have been seeing us for months or sometimes even years, we have the people that are seeing them for active issues planning to see them, but we always make sure that we're not missing any new things that have shown up when we do our initial interval history with the patient when they come to clinic, and can add people back in that otherwise wouldn't see them because they're doing quite well without any real concerns from that standpoint. And so that's how we get prepared for this clinic typically the week before, and that takes a little bit of time commitment from everybody, but it's a very quick and easy meeting. We catch up with each other a little bit about how our lives are going as well, so we have some fun with it. And then when we're in the clinic day, we have patients fill out a symptom questionnaire just to make sure that we're looking for and they have a chance to volunteer any new concerns that they have, and we can compare this to the previous questionnaires to see if there's any significant changes for them. And then we put patients into 3 or 4 rooms, 3 or 4 patients at a time, and then we have our clinicians go round robin in to see these patients. Typically, I'll send a trainee or my nurse practitioner in to see a new patient first. But for our established patients that we know need to see rehab or know need to see the pulmonologist, they'll go and see these other patients. They're not waiting for somebody to come see them. And as people go into rooms and come back out, they share with the rest of the group what they've heard from the patient, what they've found on their examinations, their assessment. Are things well controlled right now from my perspective with my area of expertise? Or are there things that need to be done as far as further evaluations, or do we need to make changes in treatment based on my perspective? And so we all go through this round robin, and at the end, we all sit down together and make this global plan for each patient. For the patients that are coming from Memorial Sloan Kettering, I enact those plans. But for patients coming from elsewhere, I really have to engage their local doctor because I want them to still have ownership of their patients, be aware of what they're on, because they're going to be seeing them in the interval before I see them back. And many of these patients I'm seeing anywhere from 1 to 4 months apart to give ample time for GVHD to change, because chronic GVHD, as we all know, is a very slowly progressing disease and with waxes and waning. So if I give them enough time to see how things are really going, that gets rid of that weekly variation, I get a better feel for if we're on the right track or if I need to make changes. The outside referring doctors always reserve the right to say, I'm worried that things are heading in the wrong direction. Please see them sooner. I will always see them sooner if they ask that. So here I have what all the different subspecialists do and how they bring their expertise to bear for our patients. Our pulmonologists look through their pulmonary function testing when they're old enough to perform PFTs and really able to look at things that I'm not able to discern without the formal training that they have as far as patient effort and reproducibility. Looking at, do they think that this is more of a chest wall issue versus an airway issue versus a lung issue, and do we need to get follow-up testing? As dermatologists know, we really value their ability to describe the different skin findings that we have because they're highly variable between patients. There's a lot of very fancy and complex words to describe them that are best left to the dermatologists who know these things very well. Our GI doctors of nutrition not only look at diet and gut health, but also worry about the liver and all other things GI related from the mouth all the way out the other end. Dentists also look in the mouth, not only screening for oral cancers, but looking for ulcers and lesions, can provide topical treatments, special toothpaste, things like that our patients can use. Everybody ends up seeing rehab medicine because of the disability that they get as a result of their chronic GVHD, and they're very good at helping us find ways of helping them optimize their ability to do their daily activities and to get back into their things that they enjoy. I've got a 10-year-old with pretty significant scleroderma that's responded to therapy that's playing hockey. And so she kept on working with him on things, mobility, because he wanted to be able to fully wind up to take a slap shot. So she was able to personalize some of his physical therapy with his local physical therapist to some of his goals for his activities that were important to him, which I think is great to have that ability to do that. The gynecologist will see our patients in a separate place due to the privacy of that exam, and then circle back to us, let us know if they're providing any topical therapies, if they have special concerns based on their exam, or if they think that from what they're seeing, we need to change our systemic therapy as well. And then the eye doctors take care of all the specialized lenses, the punctal plugging, and all those things. So these all are getting brought to bear on a daily basis in this clinic when we have this. So again, we have this global discussion afterwards where we determine, are we on good therapy that we need to keep going? Have things been stable and under good control for long enough that we are talking about, is it time to start backing off on our therapy to see if things are going to stay under control with less therapy? Or do we need to bring some new medications on board? And how long should we wait before we see this patient back? And we want to make sure that everybody has a voice in that, because it's very important that everybody has their concerns and addressed as well, all advocating for the patient as well as the patient as well. I kind of see the patients at the end and communicate all of this, do my own assessments, and then our pharmacist will review medications with the patient when we're making changes. Now, a few years ago, we added in a telemedicine option because not everybody can make it into New York City pretty readily, whether it's because of time, resources, or because of their own mobility and the impact chronic GVHD has on their life. So this really eliminates these barriers for getting this subspecialty multidisciplinary assessment of their chronic graft versus host disease. So how we do this for these patients is, instead of having them sitting in the room, we have a computer set up in the room that they log into from home, and we all rotate through that room and see them virtually like they were sitting in that room, and the same workflow applies from that standpoint. So this is great for these patients that are coming from far away. We've had a lot of positive feedback about this and have actually published our experience with this in journals earlier this year. When we're doing telemedicine, it's hard to really assess the skin. There's often poor lighting. So we have patients take photographs of all the different areas of their body so we can get a good feel for what's going on. And we can keep the log of those photographs that we can compare from one visit to the next, so we can look for changes in the skin from time to time. So we have them photograph these areas. We give them these pictures to help guide them. And for my younger patients, they don't look the same, so we have to talk about how to take these pictures in our patients as well. So we have both adult-sized and shaped people and toddler and baby-shaped people that we give this guidance for. And we make sure that we get a good look in the mouth as well, because we have a lot of concerns around the mouth for our patients, not only ulcers, but also the concern for oral cancers that can happen in our patients. We also look at mobility, so we have them take pictures and we'll have them reproduce this for us as well, because mobility is a big part of our assessments and a big thing that can hinder quality of life and the ability to do activities for our patients. And so we go through and do that whole telehealth visit the same way as if they were right there in front of us. After clinic, we do a full debrief to make sure that nothing was lost in sometimes a little bit of chaos that can happen as we're all going in and out of rooms, to make sure that we've got everything properly documented, we're all on the same page, and the recommendations are very complete. We make sure we schedule that follow-up for the next time they come. And then for those patients that come from outside, I set up a virtual meeting with the referring doctor where we have a chance to talk about the patient, what our findings are, what my recommendations are. Let's hold the course where we are right now. Or, I'm worried that we've lost control of our graft versus host disease, or that this is still progressive despite the last time I saw this patient. And these are our treatment options that we have. Based on what I'm seeing with the patient, I'm going to recommend this out of the treatment options. And they can certainly fill in some of the things that patients don't always come forward with, like, well, actually we found out that they haven't been taking their medicine for the past 2 months, and that might be why we're seeing this progression. And I'm confident they didn't tell you. We only found out because we checked with the pharmacist and then filled a prescription and God knows how long. So these things can be filled in when I'm talking to the doctor. That helps me figure out and get a better understanding of why the patient's GVHD has changed the way that it has. It's also an opportunity for me to educate them about some of the newer treatments and how we do monitoring around those treatments, how to give those treatments safely, and then some of the anticipated side effects that they can be watching for with the patients. So I can educate them and empower them to continue to provide good care locally in between these visits to our clinic, which is also nice because it builds up a community amongst our transplant physicians around providing care for these patients. And it gets them comfortable with using me as a resource when they have concerns or questions, the fact that we're having these regular conversations as well. So the vision for this clinic was really to be a consultative clinic for the region and beyond. So I've seen patients from Rochester, I've seen patients from out of state in Pennsylvania. Again, I've established this relationship with the doctors where they'll reach out to me if they've got a patient they're concerned about. I give them instant consultation on the phone for the short term, but if they want them to be seen in this clinic, then I get them with my team to get them scheduled. It also gives access to all these other doctors, to subspecialists that have an interest in chronic GVHD that they may not have close to home, and therefore being able to provide the services for these patients as well. And a big part of this for me is making sure that they still have clear ownership of their patients, that they understand everything that is happening with their patients, because they're the ones that are seeing them day in and day out, so they need to be aware of what's going on. This is not me taking over all of their care. This is me helping them provide care for their patients. And with this improved relationship that happens with these conversations, again, this leads to good education for them and then their local care getting better. There's still a lot of gaps, though, in GVHD care for our patients, and I think one of the biggest ones is early detection of chronic graft versus host disease. These patients typically don't get sent to my clinic until they've already identified that there's a problem, and the problem's not responding to their usual bag of tricks that they have for treating it. And one of the big problems is that the fibrosis or scarring that we see as chronic GVHD can be very difficult to reverse, if it's going to reverse at all, and it often takes a very long time. And when patients first present with chronic graft versus host disease, if you're not looking very close, you may miss some of these early subtle signs that can lead to early treatment to prevent this progression to where we now have restrictions in movement and activities and significant impairment on quality of life. We also do not yet have really good testing that's going to predict who's going to get chronic graft versus host disease, or to help us with diagnosing chronic graft versus host disease when the findings are subtle, or that they may be related to infection versus chronic GVHD or something else that can help us point us in the direction to make sure that we're giving good treatment for them, instead of giving time for this to really present and clarify what it is that we're seeing in front of us. And again, the lack of access to specialists for a lot of people is a challenge. Now, one of the things that I see as being a real big challenge for me is I'm in a tri-state area, and a lot of children are on state-supported insurance. A lot of them have Medicaid to help support their cancer therapy. And when you're on a state insurance, there's a lot of restrictions going across state lines. And so I can't do telehealth for these patients when they're at home because I don't have a license in their state to practice medicine, and then their insurance doesn't allow them to come to me because they want to keep their care inside the state. So this is really an artificial border that's more political than anything. So I think that this is a great place for some advocacy, saying for some of these rare and orphan diseases like chronic graft versus host disease, that we need to tear down these artificial barriers and allow patients to have access to specialty care that's not available close to home for them. So this is something that I think that we can all as a community be vocal about in trying to help get better access for patients to good chronic graft versus host disease care. We also, and when I was in Utah, we had patients come down from Idaho. There was not a single pediatric bone marrow transplant program in the state, so we had all the patients come down to us. For them to have to come down any more frequently than they already had to for additional care is challenging. So because a lot of these kids were on Medicaid, I could not again do telehealth for them. They'd have to come down. So again, if we can address this, I think this would help patients in a lot of different areas, including those that are living in remote areas as well. Another big problem in pediatrics is that when new drugs, new treatments are being identified and tried in clinical trials, we're not being inclusive of our young children. This is something that the FDA said that they want to address, but they've said it, but they've not followed through with action, and really saying we really need to have inclusion of young children after a safety run-in for these agents in adult patients. They allow us to take 12 to 18-year-olds, but those 3 and 4-year-olds aren't allowed to go on that study yet, and they think they're being protective. What they're really doing is inhibiting our ability to learn how to properly give these drugs to these children. And we ultimately end up using a lot of these drugs off-label, not knowing how to really, truly, properly give these drugs to these kids because we don't have any other agents that we know are effective in this area. In pediatrics, the only drug approved to treat graft versus host disease is ibrutinib, which is one that almost nobody uses on a regular basis, so we're using a lot of things off-label. The pediatric studies for ruxolitinib have been finishing up, and the results are getting reported, so it's helping us with knowing how to dose that. But the studies for belumosudil, which is Rezurock, and for exatilimab are still in the planning phases and getting ready to just start enrollment now. So we're way behind the ball in getting access to the agents for these young patients. And these are patients that we want to have long, full, productive lives, and we're talking 60, 70, 80 years of life, that we are really restricting our ability to effectively treat them. We may be setting them behind the ball by giving these impairments in their growth and their development and in socialization as well, because of the stigma that comes for some of these children that have an inability to interact with their classmates in a normal way. Another big challenge that we have in our young children is that they are not able to perform the pulmonary function testing that we use to diagnose chronic GVHD that involves the lungs. There's a lot of efforts going into looking at different testing modalities for this, but when it comes to clinical trials, those things aren't ready for utilization in clinical trials, so we have to wait for them to become symptomatic from a lung standpoint. And we know that by the time that patients have symptoms in their lungs, their lung GVHD is already fairly advanced, so that's waiting too long. So we have to come up with better ways to screen these young children so that we can catch them before they have symptoms, so we can start treatment early for them as well. So how do we close these gaps? Again, education, outreach, support, remote support and consultation, putting out white articles and opinion articles and reviews that can be used by from in the different subspecialty fields. How do we teach other dermatologists to take care of chronic GVHD if they're not close to a transplant program? We can give them treatment. We can give them education through medical journals and papers. Same with all the other subspecialists. What about the local oncologist that sends a patient 150 miles away to the closest transplant center, and then the patient comes back to them? How do we empower them to look for chronic GVHD detected early? Education and outreach, I think, are really key to help with that for our patients. We can't expect the patient to keep on coming all that distance to us or stay close to us when all their support, their work, their schools are back home. We want them to get back to their lives, but we need to make sure that we catch any bumps along the way that are a result of their transplant early so that we can keep those from being an ongoing problem for them. And again, this lobbying to break down these state border walls for orphan diseases, I think, will really improve access for a lot of patients as well. So as I mentioned, we have some lung testing modalities that are being investigated underway. I think we're probably going to hear from those in the next session here on this side, but we have some CT-based imaging. There's an MRI-based imaging, and then there's another pulmonary function maneuver called multiple breath washout testing. They're all being investigated, including in young patients that get over this barrier of being able to get testing and screening in these young patients. Again, the FDA is recommending that we include children and teenagers, but they're not following through and giving us that access. We need to keep on pushing them to follow through on these words. And then we have to acknowledge that clinical trials in children are challenging because we do a lot fewer transplants for children than we do in adults. So this takes very large efforts involving all of the large pediatric transplant centers to get enough patients to be able to do meaningful clinical trials. So this takes a huge effort, and it's a very expensive investment for people when they're doing these studies. So, but we feel that not only is this, warrant the support, this absolutely is an obligation that we have to learn how to give these agents to these children. So with that, I'd like to thank you guys for your attention. Again, a lot of this is my experience. My position on things are other multidisciplinary GVHD clinics in other areas that are very successful, that do things a little bit differently. And I think that most of us are all talking to each other and sharing with each other what we do to try to improve care for our patients, because really that's what it comes down to, is we want to make sure that our patients have the best possible lives after transplant. So thank you.
We do have some questions online. While people are thinking of their questions, why don't we take those? So the question is, great presentation, fabulous program. How long do you book for each patient with each provider, and how many patients are seen per clinic? How often do you have this clinic? Does Dr. Schultz have a very similar clinic in Vancouver, and are there many similar all-inclusive clinics for adults?
Yes.
Go.
So I wish I had more information about where these other programs are that do these. I know there's a handful of adult programs around the country. I know Dr. Schultz sees a lot of children with chronic GVHD. How many subspecialists he has working and seeing those patients with him, I'm not sure about. As far as our clinic, we schedule patients in 2-hour blocks to be seen by the multiple subspecialists, and then they all bill for their time individually, and which makes this financially salient for them. They're all able to individually bill for their time with the patients and their medical decision-making. We have this clinic right now for pediatrics once a month, but as our volume picks up and more, we have to decide, do we want to add an additional day or extend our day even later, as we have more and more patients that are seeking our assistance, and their transplant doctors are seeking consultation assistance with their management. I'm certainly open to that. My team is open to that because we do enjoy each other's company. And so for us, it's a little bit of a break in the usual routine to come together and get to do what we think is very fun and exciting team science and team medicine. So that's how it works for us. We, again, give patients a 2-hour block. Everybody's got time slotted in there, but then however much time they take, and then the medical decision-making also fills into the billing, and that's just, how it ends up working. How many patients do I see today? So I had my most recent GVHD clinic this past Tuesday, so earlier this week, and I had 8 patients, pediatric patients, come to that clinic. Of them, 3 were new patients from the surrounding area, and the remaining ones were patients that were well established with us.
I'm looking for Steve. I mean, the NIH does something very similar when it's like everybody comes to the patient and there's the team discussion, but that's I've always thought that was really amazing, but like not feasible in like outside of the NIH and the government, kind of setting or the research setting, but you're doing it in, in sort of like the
it's a clinical setting, but
normal
also it's
insurance.
a platform for research as well, absolutely. So,
yeah,
like
right,
I said,
right. But meaning it sounds like people are able to bill for time, but so I guess I had a question, you have, say, the GI doctor there. Are they able to but not everybody may need a GI specialist, right? So they may only bill for one patient, but somehow they're able to pull this off where they can spend a day with you. How do you convince people to, not like the doctors, but like their bosses, right?
Right, sure. So I did mention my stubbornness before, which certainly helps, as well as my passion. And the fact of the matter is a lot of our patients have weight issues. A lot of them are either underweight because of wasting and inability to get good nutrition because of oral and GI issues. And then we do a lot of screening still as well. So he ends up seeing a fair number of our patients. The other benefit for me from my GI doctor is he's one of 4 subspecialists that are not oncologists that is employed in pediatrics at Memorial Sloan Kettering. So he's kind of been, his role is to really support all the different teams. And so this actually helps meet some of his clinical needs and expectations as well. For the other ones, they understand the scope of the problem that we have, and they're very supportive of the efforts that we have, and they think that having me as a resource right next to them when they're seeing these patients to help contextualize things is a good resource. So the division leaders, many of them will actually come and spend a day in clinic with us just to see exactly what we do, and then they see the value added for our patients in this type of model. So I get a lot of support from that standpoint, but one of the things I hear from a lot of my colleagues that would love to get a model like this is that it's been really hard to try to identify people that can commit to doing this with all the other increased expectations that are made of clinicians in our current state of affairs in medicine and academic medicine in particular.
So, I mean, as you know, I'm so fascinated by this and how you've been able to pull it off together. It's such a fantastic thing that I think, we're all envious about it. And, just to follow that up with another logistics question, I think the barrier to other institutions doing this is not the doctors. We would all love to be able to do this, but from an insurance standpoint, if I...
You don't have dessert, do you? Okay, let me give you Mike.
I did have dessert, thank you.
Save some for me.
So from, an insurance standpoint, many times if I ask, my dermatologist, hey, can you, I have this kid in clinic, I'm worried, can you send someone to see them? And they will, but then they can't bill for their time because the patient is not physically in their clinic. Have you found a way to bypass that at your institution?
We have, because everybody does bill separately. And so additionally, a couple of the subspecialists that see my patients physically in our clinic are primarily appointed at Cornell and then have an adjunct appointment at our center because they'll come over new consults inpatient for other complications as well. So when we officially have them on the schedule and we have this as a GVHD clinic and them as a member of the GVHD clinic, they're able to bill, is my understanding for how that works. So instead of we're actually all in the dermatology clinic, which is a much nicer space. Dermatologists get much more support than us pediatricians do. So we have a beautiful scenery and views in a brand new building. And she also has this wonderful 3D camera that we can do these photographs of our patients in 3 dimensions and be able to zoom in all the way to poor level resolution. We can take these and compare them longitudinally to make sure that we're getting a really good feel for how our patients are doing. But everybody's been able to bill because they have a dedicated slot in the schedule that is seen, that the patient is seen by them in the GVHD clinic. And we get approval for all the different subspecialists before patients come to this clinic. So we get, our transplant coordinators and schedulers make sure that we get the approval from insurance for them to see all these people. There have been a couple times where that's been a barrier to a patient coming, and if a patient's not able to come, and their insurance, despite all the communication with them, won't let them come and see everybody, I'll at least see them myself over in our standard clinic. And then sometimes after I've seen them myself, I'm able to put together a letter that also takes in my note the need for multidisciplinary care for this patient that has multi-organ involvement, graft versus host disease. And sometimes that's enough to overcome the resistance from the insurance company, is having somebody that's recognized as a GVHD expert saying there's really added benefit for this patient to have multidisciplinary care given all the different organs that with which they're having issues as a manifestation of their chronic graft versus host disease.
It's amazing. Thank you.
Thank you.
I think I'm loud.
So the people online can hear you.
If I may ask, what kind of transplant did you get? You don't have to answer it if you don't want to.
Yeah.
But and how do you see the evolution of the transplant and the transplant source and what is available at this point now, and the GVHD management as well?
Yeah. So my transplant was in 1998. I had an HLA-matched bone marrow, peripheral blood stem cell transplant from my sister. My conditioning regimen, this was way back in the day, we were still giving oral busulfan, so I was taking the busulfan. We had the 5 little tablets that could get put in a gel cap, and you had to keep it down at least half an hour, because if you threw it up within a half an hour of taking it, you had to count the number of pills and repeat that. So there was a lot of meditation done by me to wait that 30 minutes. And the prophylaxis was, tacrolimus was still FK506 back then, but Michigan was using that with methotrexate, so I got that. When my GVHD failed to respond to steroids, we tried a couple different things. I tried mycophenolate. They were talking about trying Plaquenil, which is an older agent for lupus, is my understanding. But what we ultimately used that got me back into control of my acute GVHD, and I thankfully never got chronic GVHD, was ATGAM, which is horse ATG, which is something that really we don't use much outside of aplastic anemia now, and everybody uses rabbit ATG now because it seems to be better tolerated and more effective. So that was what I had gotten at the time. And obviously there's a lot of follow-up because those that have steroid refractory acute graft versus disease are often the patients at highest risk for chronic, and I just happen to be very fortunate that I did not suffer from chronic graft versus host disease as well. Did that answer what you were asking? Yeah. Oh gosh, so transplant has come so far since then. So back in 1998, at least in pediatrics, the thought was that if a patient went to the ICU that had a bone marrow transplant, they were destined to die. So we're not even going to take these patients to the ICU. And I remember being awake one night when I was spiking high fevers with low blood pressure, hearing my mom pleading with the doctors not to send me to the ICU because the ICU docs told them that if I had to go to the ICU, I was going to die. So just even that mentality has changed drastically. We've gotten way better with our HLA matching. Instead of just matching on HLAs A, B, and D, DRB, we now are matching at 12 points, so we have better matching. It's much more high resolution because we're now doing sequencing to do it as opposed to mixing studies and a lot of dirtier testing. As far as GVHD prophylaxis, we're a lot savvier with our combinations. We've learned that we can reduce our doses of methotrexate and minimize toxicity without compromising our GVHD prevention. On the adult side now, everybody's getting post-transplant cyclophosphamide. We've not gone that way in pediatrics because of the concern of extra alkylator agents and effects on fertility and growth, things like that, although we still end up going that way. We use it for our higher risk patients. There's things like abatacept that are out there. We're now doing things like alpha-beta T-cell and B-cell depleted grafts. For patients with non-malignant conditions, there's now the promise of gene therapy for a lot of these diseases where we get rid of all the risks of alloimmune effects like graft versus host disease as well. So we've come a long ways in a lot of different areas. Our prevention and monitoring for viral reactivations like CMV is now something that is a regular thing, and now we have a very safe and well-tolerated long-standing agent that we put almost all patients on to help prevent CMV reactivation. So there's all these different things that have become huge advances, and that's not even talking about all the advances, ruxolitinib, belumosudil, axatilimab, ibrutinib, all approved for chronic graft versus host disease, at least in adult-sized patients and adult patients. We're still working on those in pediatrics. As I mentioned, this is something that I've been a very vocal advocate for earlier inclusion of younger children in these studies to give us access and learn how to properly give them. So we've made all sorts of progress across the board. We have better antifungal management and better fungal screenings that we can do now as well. So there's a lot that's happened over the past 27 years. This is a very rapidly evolving field. It's an exciting field to be in, but it really takes a village not only to get any single individual patient through a transplant, but also to learn how to incrementally improve the safety and efficacy of transplant as well. So this is really one of the great places to work if you like working as part of a team and being part of a large group of people that are working towards a common goal. Yes?
Thank you so much. And this is so great. And I saw the white paper up there, so I have to ask, how are you planning to share this more? Representing the GVHD Alliance friends over here, how can we help advocate for patients for this model? Because it seems so awesome.
So we looked for a medical journal home for that white paper. Unfortunately, we're not successful. So it's up on the STCT website and on the GVHD Alliance website as a way of getting it out for people. I've been asked to go all over the place to kind of share this model and how we are able to successfully and sustainably do this multidisciplinary GVHD clinic. I was just in Argentina in early September talking about multidisciplinary GVHD care there. I'm trying. It's like I'm putting myself out there. I'm screaming anywhere I can that this is really a model that I feel strongly in as being best for our patients and a great resource to all the other transplant programs as well. So it's not just about the clinic, it's about all the surrounding programs that can also tap into that as a resource for their patients too.
All right. Thank you so much, Dr. Harris, for that very inspiring talk. And stay up there because next we're going to have our expert panel discussion with our speakers, whoever is still here. We probably need more chairs. That means you guys. Actually, you do. Yeah. Where's everyone available? Oh. And for those who submitted your questions, Dr. Lou's going to ask them. Oh no, Dr. Colascio is going to answer them. Ask them.
Thank you, Dr. M. Hello, everybody. My name is Matt Colascio. I work at the Cleveland Clinic, and I haven't done this in a few years, but this is an opportunity for those who are here to get your questions answered. So if you have questions that you would like to answer but don't feel comfortable with the microphone, there's forms in the middle of the desk. Fill them out, raise them up, and we'll pick them up, and we'll try to get to as many of these as we can. So I also want to acknowledge that this is one of the few symposia nationally that involves both doctors and patients. And for us in chronic graft versus host disease, you've seen the complexity of the disease. So even though we're a small group, the amount of questions that are generated is massive. And this is your opportunity as patients to interact with those of us who do this for a living, understanding that none of us can answer all of your questions. As Dr. Harris has hopefully convinced you, it requires a multitude of specialists to get the best care. And you have a mini graft versus host disease clinic right here, right now, and please take advantage of that. That's what this session is for. So I've got some questions, and I've got to read Dr. Lou's writing, so I'll do the best I can. All right, I'll try to call these out to folks so that everyone gets to participate. Okay, let's try with actually, I'm going to go off panel for the first one. Sorry about this. And ask Dr. DeLima. You might know the answer to this, but sorry I caught you with your mouth full of food. I'll give you a moment to swallow, and then I'm going to ask you this question. So it should be relatively easy. Is there a national list of doctors that are specialists in GVHD?
So I know some of our community partners like NBMT Link have lists of doctors that focus on GVHD that are available through their websites. So there's a lot of these patient advocacy and support groups that will put lists of doctors that have self-identified as having a commitment to GVHD-focused care that are available for patients. So Peggy over there, I know, has a really nice list on her website. If you want to raise your hand, wave. There we go.
There's the... Here, you want to... Here you go. Wait.
Hi, I'm Peggy from the Link. I just want to correct you. Unfortunately, it's BMT InfoNet that has that incredible directory. I wish I could take credit for it, but that's the truth. Thank you.
I'm so sorry, Peggy. Thank you. But there are groups out there that have these lists, is I think the long and the short.
So the next question is, and Dr. M, maybe you know the answer to this one. Is there some group that tracks survivors? Or Dr. Pavletic? Is there some group that tracks survivors? Because there are some people who are long-term survivors and they're looking for information about that kind of thing. Oh, Dr. Hamilton, is there a group that tracks GVHD survivors?
Not that I'm aware of.
Sort of CIBMTR. Yeah, CIBMTR. Yeah.
For patient, like.
Yes. Yes.
No, I mean even CIBMTR is an anonymized registry.
Okay.
I don't have additional questions for you.
I'm going to juggle all of these. All right.
And I will add to that, I think at least, at Hopkins, every time we bring a patient to transplant, we do encourage patients to enroll on, studies that track outcomes such as CABMTR. So I think that's, for our patients to know that is, an anonymized registry so that if a researcher has a question that pertains to transplant, they can submit a proposal as to what they're trying to study, and then the CIBMTR will approve of that study or not, and they'll provide the data, and they'll provide biostatistician support to help answer these questions that, can relate either to GVHD or other transplant-related questions.
Thank you. There was another question about what percentage of the U.S. population has chronic graft versus host disease. And without knowing the answer off the top of my head, it's got to be less than 1%. It's got to be less than 0.5%. It's got to be less than 0.1% of the population of the United States. It's tiny and getting smaller, most likely. Okay, here's a question for, this has to go to Dr. Harris because it's about multidisciplinary teams. How do we educate the multidisciplinary team to best care for these patients when you're trying to shuffle PT, OT, nurses, social workers, and everything else? How do they get those supportive care referrals?
So like the PT and OT, my rehab medicine doctor, so I've got a physical medicine and rehabilitation doctor that's part of my clinic. And so she really focuses on the coordination of physical therapy, occupational therapy, giving home stretching and exercise regimens for those that seek those out. So some of this is delegation of some of these things to people where things are in their wheelhouse. I have a nutritionist that's right there, so they are able to help them as far as diet plan, meal planning and things like that, getting around some of the limitations they may have if they have issues with oral sensitivities or pancreatic issues, things like that as well. So I think that when somebody commits to this clinic, they're also committing to the follow-up that happens after this clinic. So people take those things from their area of expertise and they follow up on those. Pulmonary rehab is something that's kind of divided between our lung doctors and our rehab doctors. So they work together on things, looking at how do we optimize airway clearance for people that are having problems with airway clearance and mucus, things like that, while the other person is working on how do we improve their strength of their respiratory muscles because they've got weakness that's also contributing to this. So really it's a lot of identifying the issues, identifying the proper resources, and then delegating to the person that's the right person for that to follow up and make sure that those needs are being addressed and being engaged for the patient.
Thank you. This one's for Dr. Shah.
Can I actually add for a minute? I'm so sorry. So at the James, we also have a multidisciplinary clinic for our graft versus host disease, and we have almost every single person that you have in your clinic, but we also include our rehab professionals as well, which is nice because then they can get treatment on the spot. And then we also have like a network of therapists that we try to refer out to if it's closer to home, but then also kind of keeping them. So I think it really is just dependent on the resources that your institution has, and it can look creative, kind of like theirs is, or it could be the professionals themselves.
And some of that limitation for me is that identifying people that are comfortable working with young children.
Yeah.
And so that's why my rehab doctor knows who those people are in the area, and if we have a patient coming from a place we don't know, she actually reaches out, figures out who she wants to work with the patient, then works very close with them to put together that plan.
Yeah, I think like from someone who works in a multidisciplinary clinic, one of our biggest struggles is finding the people more regionally. So I think that is an area of growth for us as a holistic community, is trying to build that network for us as clinicians to be able to refer out, because we understand the barrier of trying to come to us like in the city.
Okay, great. This is for Dr. Shah. So we have a question from online about whether or not probiotics are advised for those with chronic graft versus host disease.
I don't know of data directly for chronic graft versus host disease, but I think there's some provocative data around immune checkpoint inhibitors and melanoma. And in this study from MD Anderson, where they looked at progression-free survival on immune therapy, this was not an interventional study, but they just looked at dietary fiber intake and probiotic intake, and they've divided people into 4 groups. So the group with sufficient fiber intake without probiotics did better than the group with sufficient fiber intake with probiotics. So the probiotic group did worse, even though they got enough fiber. And that may be, and then they have good mouse modeling in that discussing mechanisms, but it could be because probiotics have few bacterial strains, and so it's going to reduce diversity instead of enhance diversity possibly. And so I think that probiotics may have a role in short term where like potentially after diarrhea or something where somebody needs it for stabilization or things with antibiotics, but I don't think long-term probiotics are necessary and should be done unless there's a clear indication for what it's being done. And the other, one more point is like probiotic strains are often strains that can survive a lot of things. So the question is, could they lead to more antibiotic resistance than not to, which I don't think we know enough about, but that is another theoretical concern.
Dr. Lee, care to expand?
Sorry, I didn't hear.
Would Dr. Lee like to comment at all?
Oh, do you want to explain?
No, I agree with what Dr. Shah said. And also, when looking, not in graft versus host disease, but there are some studies that's been done in looking at like specific lactobacillus strains, probiotic strains in patients that are undergoing transplant. And it's always that question of, right, like sometimes are these, the host is severely immunocompromised. So sure, in a healthy subject, it could be beneficial, but at what point, that balance could be ticked off and then actually become harmful in the long run. So yes, there are studies ongoing, but I think long-term studies are still necessary.
Yeah, I think that's a great point about infection risk, right? Like immunocompromised patients on probiotics, there are cases of like a systemic circulation and infections too. And I think the bug also matters. So there are studies in like metastatic renal cell where a probiotic, which was basically Clostridium butyricum, was associated with better response. So I think, but the study from MD Anderson was off-the-shelf probiotics. So I think, we have to, the strain matters and what context as well.
Oh, yeah. Yeah, I will add one thing from an infection standpoint is that these are living bacteria. So in certain circumstances, it can cause infection if used in someone who has an active leaky gut. And we have seen cases of probiotic-associated bacteremia and fungemia. So use it with caution.
So Dr. Shah, first of all, just so you know, I had extra salad because of you. But, I wanted to ask, and maybe I can ask our ID specialist here as well, what are your thoughts? Probiotics is live bacteria, so I think many transplanters, try to discourage that in the very immune-compromised patients for the reasons you mentioned. What are your thoughts on prebiotics, which is kind of the substrate for that healthy bacteria as one way to think about it? Because I was intrigued by what you mentioned, that it is perhaps that the microbiome needs something to feed on, and we can provide, healthy substrate in the form of fiber rather than allowing them to, attack the mucosa. So do you have any thoughts on prebiotics?
Yeah, so prebiotics are basically dietary fiber in a supplement form, and it's just isolated fiber. Two things. One is that when we think about a prebiotic supplement, often they are just one type of fiber. And so when it's just one fiber compared to food, which has soluble fiber, insoluble fiber, cellulose, inulin, resistant starches, there are many types of fiber. Each fiber feeds different bacteria in some ways. So when we do eat only one type of fiber through a supplement, often we might be just having one type of good bacteria or bacteria grow, and the diversity is not enhanced from that aspect. So I do think that fiber supplements can be a shortcut if somebody refuses to eat dietary fiber, but I don't think it is the same thing as changing dietary habits to increase the fiber intake. So I think that, and I did see that the salad was finished, so I think everybody ate a lot of it.
Okay, the next question, there's a question from the audience.
I'm receiving UVA1 light therapy for scleroderma. I didn't hear much about that today. Can anybody talk about that or how effective it is or not?
I can take this one on? Okay. Thank you so much for your question. Yeah, so I didn't touch upon phototherapy, which is separate from extracorporeal photophoresis. And light-based therapies, I would say globally, have just less evidence than we have for some of the larger trials that we have for our medication-based therapies. And so you always have to think about determining efficacy when talking to patients, taking a little bit with a grain of salt, because a lot of the studies we have for narrowband UVB therapy, which is a different wavelength of light compared to UVA1 therapy, which we use more in the sclerotic forms of disease because we think it goes deeper into the skin than the narrowband UVB therapy, which the light rays are more superficial. So we might use those for like lichen planus-like disease or some of the non-sclerotic forms. But our studies about efficacy are usually retrospective studies. The length of follow-up varies, and also patients are often on other therapies in these studies. So we have some efficacy data in these kind of retrospective studies, but they're not as clean or interpretable in applying it to you as a patient than some of the kind of randomized control trials that we have for the medication-based therapies. And it's unfortunate because they're safe and, patients who want to avoid medications love light-based therapies. But some of it has to do with like funding sources to study these therapies, which, don't have industry backing. So it is something as dermatologists, we have looked at and probably needs to be reinvigorated. UVA1, I'm curious where you're getting it, because UVA1 therapy is actually pretty rare to be offered. Narrowband UVB therapy is very common. So I use that for my rash-like patients, my non-sclerotic patients who may not need systemic therapy. But UVA1, we don't even offer at University of Pennsylvania. But yes, there is some data that can help with sclerotic disease, but the studies are, limited. Yeah, phototherapy can be really tricky. It requires, it takes into account the skin type or skin tone of the patient, how much you can tolerate without burning, and then you also have to take into account your skin cancer history, medications you're on that might increase your risk of skin cancer. So there's so many patient factors, but it is one of those things that a lot of people try to optimize the dose in the office before you get the home unit. But what you're going through is really common, and so it is one of those therapies, and the time it takes to administer it is one of the reasons it's lower on the list compared to some of the others.
Next question. This one is for Dr. Shang. What is the recommended frequency of PFT monitoring beyond the first year post-transplant?
Okay, so thanks for that question. I actually have a slide on that in my talk, but the recommended frequency is, well, first of all, you have to have a baseline PFT before you get your transplant, and then one at day 100, and where we are recommending now one at 6 months and a year, and ideally one at 9 months. And so the full PFT, which includes spirometry, lung volume, and DLCO, the diffusing capacity, should be done at least at the 3-month and 1 year mark. If you get graft versus host disease of any other manifestation, the clock kind of starts. You should get a PFT at that time, because sometimes, lung dysfunction occurs at the same time you get skin or other manifestations that's just silent. You don't feel it. And if you do have active graft versus host, chronic graft versus host disease that requires any sort of therapy, then every 3 months.
Great, thank you. I don't know how much time we have left. We have more? More? Okay, good. Because this question, I don't know who to ask this to, so I'll ask it to all the experts in the room and we'll see who can come up with the answer. Are there definitions for primary and secondary resistance to ruxolitinib?
I don't think there are formal definitions that are out there, but we all kind of know it when we see it. So if you're progressing straight through your first your first course of ruxolitinib, then I think we would all agree that that's a primary refractory case there. If you have somebody that's been on ruxolitinib, has seen a response, ideally improvement, but sometimes just stabilization of disease in and of itself is a response. And at some point you lose that, I think we would all agree that that would be a secondary failure. Or if you've come off it and then you see recurrence or progression of chronic GVHD after stopping the drug, you go back on it and you see ongoing progression, I think we'd all agree that that would be a secondary refractory as well. But I don't think anybody's put forth official approved definitions as primary and secondary.
The Zeiser publication for ruxolitinib refractory definition that came out a couple of years ago is not definitively accepted by any one institution, but it was a publication, and it similarly follows steroid refractoriness in terms of a rough timeline, in terms of usually a week or two, depending on if you have acute or chronic graft versus host disease, and then whether or not upon weaning you have flares. So similar to that, but ultimately it comes down to, as we're exploring how quickly we start ruxolitinib after steroid refractoriness and or start combination therapies. It's very case dependent, and I think every GVHD specialist would agree with this, is that every patient that has GVHD has a different presentation of it, different manifestations, and so people respond differently and at different time points, and so durations can vary, but it's all about following very closely with your GVHD specialist. And while I have the microphone, I just wanted to answer that first question that you had, Matt, which was, how do you find a GVHD specialist nearby? And I agree, you can look online, but go back to your transplant center. Ask your transplant physician. You should always feel free to contact your initial transplant center, whether or not you still follow with them, and ask them, who can I see for GVHD? At this point, they should be able to refer you to someone that is at least regionally available. And while we don't know what's happening with telemedicine at this point, there are resources that you can be pointed to. And if you're willing to travel, find someone close by.
And don't go anywhere, Dr. Cho. We might have another one for you. So there's a question that I ask too. Separate from ruxolitinib refractoriness, it often works. And for those patients for whom it works, when do you know how to stop it? And if you stop it, do you taper it? Anyone want to take a chance at that?
So that's a very timely question, especially because we just submitted an abstract to Tandem for this, and obviously I hope it's accepted for first presentation. But we actually looked at our patients who received ruxolitinib because in our OSU graft versus host disease clinic, we saw many patients who were flaring after they had been tapered or taken off their ruxolitinib entirely. And this was mostly in the chronic GVHD setting, because the acute GVHD setting is a much shorter timeline. And so what hopefully we'll be presenting at Tandem is that we saw 44% of our patients who were tapered or discontinued flare with progression of their GVHD. And so it's a very difficult question. We tried to see, are people who have been on it for longer the ones that are less likely to flare versus not? And in fact, no. So we have to dig into the data a little bit deeper to see, this is all retrospective analysis, but it really depends on those that respond or don't respond and how good their response was. But if you have a good response, we actually in our clinic say, if you're doing well on it, you're tolerating well, you stay on it. Don't try to take it off if it's working for you, because there's the almost 50% chance that your GVHD is going to get worse just even on decreasing the dose of it.
Yeah, this is one of those major unmet problems that we have. Is what we really need is some type of biomarker or test that we can use to predict whose chronic GVHD is really quiescent, burnout, under complete control, and there's no evidence of activity, that we think it's going to be safe to try to taper their agents. This is an ongoing effort that's being done by a lot of different groups to try to find these new tests that we can then validate to make sure they become not only accurate and reliable, but are widely accessible. So that way it can help guide some of this when and how to stop our agents, because this is something that we all struggle with, is when is the right time, and then when we do start to taper it, we're all watching our patients like hawks, because we're so afraid that things are going to show back up, get worse, and then we may not get the same responses we had from the get-go. So this is something that we all worry about, we all think a lot about, and there's a lot of people working on trying to find ways of helping us figure out when's the right time and how.
There's an online question about extracorporeal photophoresis, also known as ECP, often used for chronic graft versus host disease. And the question is, are there any harms associated with the therapy other than its inconvenience? Dr. Liu.
I'll take that one. Hi, everyone. My name is Heen Liu. I'm one of the organizers, but also transplant physician, and I oversee ECP and apheresis for many years now. ECP it can be very effective for GVHD. The question is specifically about, is there any harm apart from cost, travel, risk of infection to continuing ECP forever? I think the forever was part of the question. ECP is effective, but it does require a time commitment. The issue is about continued treatments twice a week, every week, for months, for years, and we have patients who do continue on for years. There hasn't been shown to be an impact in terms of your overall immune system recovery from the ECP. The challenge is that the risk of infection and the reasons why people need to stop it. You need access, IV access. Many patients will have ports or lines, and those get infected, and those have to be removed. So largely the reasons for ECP discontinuation have to do with convenience and travel, and infections and access removal, but I wouldn't say that there is a particular harm for continuing on with it. Anyone also would you like to comment as well? Erica? No? Okay.
Oh, I have a question or a comment.
Fibrosing disorders. I just wanted to add a little bit to the question about UVA1 because I used to treat patients with UVA1. As you know, I was surprised when you said you had a home unit because it takes a lot of energy to deliver UVA1, and I would joke that it takes, it's like cooling down a nuclear power plant when you have UVA1 in your phototherapy unit, into your phototherapy center. I did move away from UVA1 just because it was, for my very sick patients, it was hard for them to stand up in that booth, and it's completely enclosed and it's very noisy. I've also been very worried about melanoma because for UVA1, it hits exactly where your melanocytes would sit, and I've been very happy with UVB. An interesting question that came up, not about UVA, but photophoresis, was that if you have a patient with a history of multiple melanomas, and if you theoretically believe in the idea of circulating stem cancer cells, would photophoresis be safe for that patient? And I asked a lot of intelligent people, a lot of people who worked in that area, and everybody sort of fell in different places. But that was one theoretical question that came up, at least at the ECP. And we ended up not giving that patient ECP. So I apologize for interjecting, but I figured you wouldn't mind some additional comments.
Not at all.
Are also generally on other treatments, other immunosuppressants. And I would say that being on the other immunosuppressants is actually a much bigger risk for developing other malignancies than the ECP or circulating tumor.
Okay, we're out of time for this session. I'd like to thank our panelists for engaging with the audience. And this is where we begin the afternoon session, so those who wish to proceed to the patient discussions across the hall may make their way there now. And the scientific sessions will start on this side in about 5 minutes.
Oh, no, not at all. We actually have dermatology. I don't know if you've ever. So our ECP units in dermatology. You love it. I actually talked to Sarah.
I think we're doing introductions for this person.
Thanks. But she's asking for now.
But not now.
Right, you did her.
Yeah.
Wait, where is she?
Yes.
What is it?
More, well, she's doing a scientific one here after luncheon.
Sure.
Do you mind? Because you could just do the same thing.
When is that?
Right after Gongqing.
Oh, really?
Yeah.
Oh, Jesus, I'm a
Mind?
demand. No, how would I?
How are you?
Good, yeah. Yeah,
Let's
it's,
catch up. We haven't caught up.
yeah, I don't
Time.
know. It was so.
But it also always depends on the patient. Right, but let's say you're on board, you started early, and then you basically take the oral agent, whatever first, and then try to do 100. Yeah, I think we need to do that, because the patients are obviously very friendly, especially for super sick or walking. And, but I'm getting more on, the typical cases are on drugs, and they're not getting so let's add ECT, we want to add another thing. And then at that point, it's a hard one to response.
Because the thing too is that like yeah, so we think that
and they're doing a study, I think, great. Just is it up front or is it one of those? Yeah, no, I think it's good. And do you guys do 2 days a week, any 2 days? Yeah.
no, we don't do back to back. And we have like, I really think that was more.
Sorry to interrupt you. I wanted to meet you in a top spot. I trained in the PhD model.
We are looking at
And I never overlapped. Yeah. I was athletic before.
Oh, nice. So, your face is going to be up on the
wall. No. I mean, that's scary. No, just be Resident Oil, yes. Be named after. Yes.
That has changed a little bit. You can't see that necessarily from your studies too.
Well, no, when I was there, it was would be huge. I mean, right now we just if they come from far away and stay in a hotel, then we'll do 2 days. And then we get back to back. I go right to the energy and basically. But I should bring back some transplant thinking of yeah, I feel like it's a little bit of an afterthought, but basically it's a fraction. Usually.
I feel like if patients are willing to
No, I just had nothing to add, so.
Yeah, I love that. I was going to, I think at the end, I did want to ask, and I know we ran out of time, I wanted to ask, especially for you, how do you coordinate with your PhD? Do they see you at the same time, or they see
For me, yeah, because I don't have an Mandy Harris model, but
yeah,
what I
know,
what
the model is like amazing. I'm like, who the fuck is
But the only thing I didn't want to, what's hard is a lot of specialists do need special action. So like from my colleagues who do this multidisciplinary model, this is something I wanted to do. Skin cancer, shave biopsies, like, they want to inject a little steroid into like a bothersome lesion or whatever. So what I do is I actually love, is I have my clinic and then I have like 2 reserved spots for late long atoms. So like if they're upstairs and if they're a known patient, then they're scheduled to me and the same day. If they're like, they came in, shoot, they have this big rash, GVHD, what is it? Then I have these like hidden spots that I add in on.
we need someone like you.
And usually they don't mind like waiting a little bit, so I do it as like last spots and putting in the afternoons, but like they don't get but it's like then they're open and available, so they just like message down my schedule and add them in on our project. So that's like the access point, and then for the same day, what I tend to do is that DMs here only have clinic on Sundays, and it might not be what I do, but their nurse practitioners usually 3K facility because they share them. And so when they can alternate. So if they want to see me, I usually am like Wednesday, and then they'll book me like the nurse practitioner on Wednesday, and me when like they're not going to be seeing. So we kind of have like a workaround, but it's not all. Yeah, but we're like, because I don't have clinic every day, and then certain translations I have my days. Yeah.
And last, like, I'm going to ask at the end of this, did I wonder, so you don't have to answer now. One of the questions I wanted to ask is just to give, especially with the patients here, I wanted to ask our panelists just to comment on how to keep people encouraged or listed, working effectively, especially thinking about
I'll have to turn off the. You want me to turn that off? Yeah. So it doesn't show. Yeah, okay, so. Huh? Not till next week. Didn't show there either. Oh, yeah. Oh, yeah, last week.
Okay, well, I think we'll start with the next session. Please take your seats. So it's my distinct honor and pleasure to introduce next speaker. It's Dr. Guangxing Cheng of the Fred Hutchinson Cancer.
Oh, your microphone.
A pulmonary consult. Is it off? Okay, so once again, good afternoon. My distinct pleasure to introduce Dr. Guangxing Cheng. Dr. Cheng is the head of the pulmonary critical care consult service at the Fred Hutchinson Cancer Research Center, University of Washington. And her particular area of focus is complication after hematopoietic stem cell transplantation, bronchiolitis obliterans, and related diseases. Dr. Cheng as well pioneered and spearheaded the recent momentum, the multidisciplinary effort where pulmonologists and transplanters are working together in readdressing the difficult problem of lung graft versus host disease, specifically bronchiolitis obliterans. And she's the first author of the recent ATS research statement paper that just came out earlier this year. And she's as well the leader of the consensus effort that's going to be taking place over next year very intensively, taking another look in the team effort at the diagnostic criteria of lung GVHD, early detection, better approaches to understanding pathophysiology and therapy. And we look forward to hearing some of this today at her presentation. So thank you for being with us.
Thank you, Steve, so much for that kind invitation. It's wonderful to be here at this conference. Really lovely to be invited. What Meredith and her parents have done is really fantastic. And it's also cogent and interesting to come after the wonderful panel of speakers that you've already heard. And I'm hoping to hopefully address some of the issues that came up in the opening case discussion. But really my goal today is to, there's not enough time to review every aspect of the clinical science of early detection and treatment, but to present some of the work that I've been doing with my group and to see how we can actually leverage that into a treatment approach and possibly clinical trial approach. And then just also by way of, the theme of multidisciplinary care, I'm pulmonary critical care trained, and I actually didn't come to GVHD until about 13 years ago when I joined the Fred Hutch and the University of Washington. It was, I actually came from the University of Pennsylvania for my fellowship, and it was the one position that was actually open. It wasn't my intended specialty, but I fell into it. And I have learned so much, and it really does help being embedded in the cancer center and being side by side with the transplanters and other subspecialists. And, really coming to a conference like this is really important for me as a subspecialist to learn about GVHD. I view my role as, part of the support team to get patients into a good period of survivorship, but it is also the problems that we face are relevant for pulmonary medicine and for medicine at large. So just by way of introduction, late onset non-infectious pulmonary complications occur in a significant number of allotransplant patients, about 20%. And so this was a study that was done in Europe by my colleague Anne Bergeron when she was in Paris at that time, and it encompasses BOS, which is right now the only formally recognized manifestation of lung GVHD, but there are also other forms of late lung disease, such as organizing pneumonia, other ILDs, and issues that affect the chest wall and pleural spaces that are due to GVHD, such as the truncal sclerosis that we have heard about. Now, what is this like in the PT-Psi era? Probably much less, but we have to continue tracking this. And anecdotally, I will say that I have seen some bizarre manifestations of lung disease that come up maybe unexpectedly and not necessarily a usual context. Like I've seen lung disease parenchymal as well as airways disease without any other GVHD manifestations, which is generally fairly unusual. So just to anchor this on a patient perspective, okay, these are patients with lung disease who I have treated. These are quotes from their mouths. I need to breathe to live, but I also need to live to breathe. I'm still alive, but I've had so much loss. If I had known I would get lung disease like this, I would rather have died of my AML. So this is the kind of thing that, hematologists may never hear from their patients, especially if they, go off into the community. But I think it's devastating to hear that, in particular, that they would have rather have died of their cancer than than to suffer from lung disease, because it is the one thing that really, really is so morbid, so difficult to treat, and what causes a lot of suffering. So my group, we did a patient survey to understand, across 3 institutions, to understand what patients really wanted us to focus on as transplant and pulmonary researchers. And it was interesting that early diagnosis and prevention came out on top in 54 respondents. And so in response to that, I convened my group, as Steve mentioned, to bring together a critical mass of pulmonologists who are seeing these problems, and transplant docs like Greg Yannick, for example, at the University of Michigan, who's a good colleague, to really review the literature and to come up with a roadmap on how to tackle this, because I think we all agree in this room that early detection is probably a major key to preventing long-term morbidity. So just briefly, as a way of review, what interests me really, and what we need to understand in order to implement early detection, is to understand natural history or disease evolution. And that means understanding what the trajectory of disease is. And it really is heterogeneous. So you have people who will decline quickly, but once they get diagnosed and get on treatment, they will improve. People who will plateau, and people who will continue to decline. For the most part, the pattern is one of relatively rapid decline over 3 to 6 months. And this is assuming, this is an approximation because we have limited data, because a lot of people don't get their 3-month PFTs. And there is generally this observation that there is stability, but there's long-term kind of low-level decline. But there are definitely these phenotypes. And our window of opportunity for early detection really is in that period that we're actually not measuring, which is the several months before that, where you have a steeper rate of decline. So, and as other speakers have mentioned, we want to preempt that irreversible fibrotic phase. So this is the current NIH recommendation for PFT screening after HCT, like I mentioned. And for high-risk patients, you want to definitely do it a little bit more frequently. The question is, and the challenge, the clinical challenge is, how do you identify who's at high risk? Is there, other than GVHD, which is sort of a loose category? Okay, is the frequency actually adequate, every 3 months, or is it too much? This is a challenging thing, might be challenging for people to implement if they have to do this so frequently. Is there actually access to a PFT lab? A PFT lab is slightly resource intensive because it requires a technician, a specially trained respiratory technician who can coach a patient through a measurement. And do the transplant doctors actually order the PFT? And I will tell you that it is shocking it is shocking that less than the fact that we did this survey, that less than 50% of transplant centers actually follow these recommendations in any form. So getting back to this notion of who is at high risk. Okay, so we know that patients with GVHD get BOS, so 14%. At least that's the pre-PT-Sci epidemiology. And it is usually recognized within 6 months of the initial onset or recognition of extrapulmonary GVHD. Spirometric decline at day 100 is associated with future development of BOS, and that gets at the notion is, okay, first of all, is the pathologic process actually starting there, or is this indicative? It's probably indicative of the risk that is accrued during the early period that puts you at risk for further development of GVHD when you get chronic GVHD or other insults. And then this history of respiratory viral infection, this has been shown retrospectively in lung transplant, okay, where BOS also occurs. And we have shown it retrospectively in 2 studies. And very recently, this is almost very hot off the presses, we finally just published our study conducted at the Fred Hutch from 2009 to 2014, an observational study of respiratory viral surveillance in allotransplant patients, and did find a significant association of early infection with respiratory syncytial virus and the development of BOS. And this was very, very clear, as you can see in this hazard plot. And then PIV, parainfluenza virus, is associated with late pulmonary impairment that doesn't meet the definition of BOS. So as I mentioned before, there's lots of other things that can cause lung disease other than BOS that also cause significant morbidity. So hot off the presses that it's not just respiratory viruses, there are specific respiratory viruses that confer risk. And with what we know about RSV and airways diseases in other contexts, like in children and asthma, not super surprising, but now we have the evidence that demonstrates this. And then I did conduct a pilot study where we did do this, we were monitoring at-risk patients with patients with GVHD with home spirometry and symptomatic RVI testing. This is my medical resident, Mike Vo, who worked on this. And we had patients send in self-collected viral PCR for viral testing, and this was actually conducted, the majority of this was conducted during the COVID era. Other than rhinovirus, the most common respiratory virus detected from the nares in a symptomatic episode was actually SARS-CoV-2. And in our preliminary analysis, we are showing that this is the hazard ratio of actually going on to develop BOS is over 3, though there are wide confidence intervals, and this is a limited population. But there is increasing evidence that there are specific viruses that confer increased risk. Okay, back to the idea of how do you actually make an early diagnosis? Again, right now with the tools that we have, this requires routine interval PFT. And it's not just doing the test, it's also the interpretation of the test and being able to look at the longitudinal trends. So rather than go by a cross-sectional time point or a cross-sectional value of FEV1, such as what is proposed in the current NIH definition of an FEV1 of less than 75%, what you really want to look at are trends, okay? Trends in the decline rather than the specific threshold. And as a pulmonologist, for me, a 10% decline is a good rule of thumb where you might want to pay more attention or consider the diagnosis. So when in doubt, repeat the PFT. And I don't wait 3 months, repeat it like next month, okay? And also I want to mention, just apropos of the case that was presented this morning, in addition to the RV, the residual volume, you do want to look at the total lung capacity, the TLC. I think we home in on the RV because that's what's written in the NIH guidance. But the TLC, the total lung capacity, is really important to contextualize the RV elevation and the spirometric declines, because the other lung diseases that we see, such as interstitial lung disease or pleural effusions, can present more in a restrictive fashion, and that's where you need the TLC. Okay, what are the types of spirometry? So this is, I know a lot of patients don't enjoy PFTs. You go from supervised, where you're going to a lab and you have a technician coach you through the measurement, blow, 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 to unsupervised, where you have a handheld device and you could do it in the privacy of your own home. And what I've been exploring is whether wireless home spirometry can be a screening modality. Can we bring more frequent PFTs into the home, make it more comfortable for patients? We now have this cloud-based technology where the devices are Bluetoothed, and they can be recorded and actually reviewed in real time. So we did do a little pilot study where we enrolled patients with chronic GVHD to do weekly home spirometry, and we were able to find that antecedent decline can be indeed detected, and those are indicated by the little red triangles of different PFT trajectories. So I just wanted to also show you the modality that the little platform that I'm using right now. And I want you to focus in on the flow volume loop, that little curve. Okay, and this is what is available now. So this is like me looking at my smartphone with the app and my coordinator, who's gonna coach me.
Okay, starting effort 3.
Okay, so look at the loop. And so it only takes a couple of seconds. And it's easy. It goes off to the cloud. You do it 3 or 4 times, and the team looks at it, or we get sent an alert if something goes wrong. The patient is sort of coached through it electronically if they don't do a good measurement. So that's how it works. And so I use this technology in a prospective study involving 3 centers, including Michigan and Stanford, to examine whether or not what exactly are the spirometric changes that predict the development of BOS. So what we did was we enrolled patients with chronic GVHD, before, without a lung diagnosis, and we asked them to do weekly spirometry for a year, as well as their routine 3-month PFTs and symptom questionnaires. And if there was a consecutive decline in their home spirometry of greater than 10%, then there was a letter that was sent to them and a letter that was sent to their provider without any, the provider, it was up to them to decide what to do. We did enroll a cohort of patients who were newly diagnosed with BOS to actually follow them as well to see what their post-BOS trajectory was. But the endpoint for the first cohort was a clinical diagnosis of BOS, which included the NIH definition, other complications, the respiratory viral infection, which I just showed you, and also to acquire a biorepository. So right now, this is being prepared for publication at the moment, that we completed our enrollment period and our last follow-up in April of 2024. We got 133 patients, 113 in the at-risk cohort. There were a lot of early withdrawals and a number of people who passed away. I mean, this was a fairly sick population. But at the end of the follow-up period, there were 20 individuals who were diagnosed with BOS. And interestingly, there were quite a handful of other diagnoses, including organizing pneumonia, infection, sclerosis. These are people who had restrictive impairments and infections. How does the home spirometry operate, and will patients do it? What's the adherence? Incredibly, the adherence was pretty darn high, even for participants in cohort 1 who don't yet have lung disease. 77, the median was 77% of the expected weekly measurements were performed. Of course, there was a range. Cohort 2, these are patients with BOS. They know they have lung disease, do slightly better. So overall adherence was really very high, almost 80%, which is quite incredible. But this is also facilitated by the fact that the app gives you like automated text reminders every week. Like we get patients to make it a habit. It's like kind of like brushing your teeth. It's like the thing you do, Sunday afternoon. Okay. A good proportion, a good number of patients provided over 90% of their measurements. And then, there were certainly participants who didn't want to submit any, and those are patients who just, if they, and actually within the first 3 months who's going to be what. If they are not going to do it within the first 12 weeks, they are simply not going to do it, and we take them off study. And then also there are many reasons for non-adherence. People get sick, they get hospitalized, they lose their spirometer, the dog ate it, things like that. So we also wanted to look, it's really important to understand if it's like accurate with your lab PFT, okay? The Pearson correlation for the FEV1 is really very high. And these are patients who are coached in the beginning, okay? They're not new to PFT. There is sort of a training period. People get better with it over time. There is a bias, at least in this study, I used a different spirometer, a bias, which means, it's like off the mark by a certain amount, acceptable within ATS standards, but really what we're looking at is the so-called intra-class correlation. Very, very high, greater than 0.9, and what that means is, is it consistent longitudinally across time? Like, can you trust the trends in what a patient is doing over time? And with a correlation that high, that is, so it's reliable. It's the trends are reliable reflection of what's actually happening in that patient. So Maddie Peha, who was a medical student at the time, now a pediatric pulmonary fellow at Seattle Children's, she looked at this data and this really clever thing of visually mapping out the longitudinal clinical course of someone by their home spirometry PFT, their lab PFT, their symptoms, as well as their respiratory viral testing. And so you can see this is an example of somebody where the blue line with the little dots, that's your home spirometry. They were pretty good with their home spirometry. The green is the laboratory PFT every couple of months. The X on the top dotted line, those are each time the patient submitted a viral PCR. On the bottom X-axis are the symptom scores. And then the dotted red line is the 10% threshold for concern. Okay, and so you can see that this individual did get, their home spirometry did dip. It correlated with their lab PFT. They had a viral infection, okay? A red X is a positive test. And then the vertical dotted line is actually when the BOS diagnosis actually occurred. So this is someone, they had all this stuff going on, but were not actually formally diagnosed with BOS until quite a bit later. So this is a very busy slide, but just to show you that the BOS in this cohort it was pretty mild to moderate in severity at diagnosis. So in the subgroup, in the group that had detected home spirometry detected antecedent decline, the median FEV1 was, hovering around 70%, not super severe, but, that meets the definition, the NIH definition. There was a group where they were diagnosed with BOS, but there was never this 10% decline that was detected. And it's interesting to note that this group, at diagnosis, at clinical recognition, had, almost normal FEV1. Like their FEV1 impairment wasn't particularly severe. So I think this reflects that in the 3 centers that we conducted this in, that people are doing their PFTs and their doctors who are looking at the measurements and being like, okay, I'm not waiting until the NIH diagnosis. I think this is BOS, okay, based on other criteria. So anyway, that's just something to note about the particular cohort. But when we looked at the subgroup that did have antecedent decline, it occurred like 5 or 6 months prior to the formal diagnosis of BOS. So there's this massive lag time, okay, even after you've detected FEV1 decline. And then if you are only doing PFTs, if you ignore the home spirometry, then the lag time is about actually 3 months between first decline by lab PFT to BOS diagnosis. So this brings up a number of different points. So actually I want to just show this is some examples of the BOS with antecedent decline that was that we found antecedent decline by home spirometry, that sometimes the decline was detected and then BOS occurred. And then in this, the upper left is the one very, very severe and classic case of BOS that, yes, we recognized him early and he just continued to decline in spite of everything. And then for those who did not have an antecedent decline recognized by home spirometry, it's interesting that in many instances, the decline happened after BOS was clinically recognized. And so it's interesting that, these people generally got on some degree of therapy, or that the BOS was mild. It probably had happened months before, and now somebody's looking at the PFTs and being like, oh, this person probably had BOS and it probably happened, 3 to 6 months ago and nothing's changed. And so whatever they got on for their GVHD stopped it, or the process was just not going to progress, okay? So lots of caveats. Non-BOS lung disease also show similar home spirometry trajectories, and this is a case of organizing pneumonia where you can see the trajectory is quite similar to that classic trajectory, and then the organizing pneumonia got treated, the lung function did not recover, and this is a case, and actually we see this with some, not infrequently, got converted to BOS. This gives you, supports the argument that there are probably cases of organizing pneumonia that represent lung GVHD. And then truncal sclerosis with restriction on the PFT can also look very, 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 very similar. Okay, so then we looked at whether consecutive decline could be used as an early biomarker for BOS. So we looked at this greater than 10% on 2 consecutive measurements. And what we found, we were looking at the restriction of declines within a specific time window prior to clinical diagnosis. And what we found is that if you it got a little bit, that if you increase the number of declines, it was less sensitive but more specific, okay? And that probably accounts for the fact that there's weekly variation in your PFT. And then does a lesser degree of FEV1 decline, is that actually more sensitive? Yes, but much less specific. And then, when we looked at the positive predictor value, it's actually not very high. It's actually quite low for NIH diagnosis of BOS for FEV1 decline. So what do we do with this information? I mean, we think it should work, but my conclusions from this are that weekly home spirometry are feasible. It is accurate in somebody who is willing to do it on a weekly basis. FEV1 decline occurs months prior to formal BOS diagnosis, that the declines are sensitive but not specific. We have shown also that less severe or indolent BOS is increasingly recognized. Non-BOS lung diagnoses are common, and really that we probably need to refine how we define the biomarker rather than it being consecutive. We have to account for the variability. And that at this moment that you can use home spirometry, I think you can use it for screening and somebody who's willing to do it and do it on a regular basis. So we're trying to build on these findings with RV-BOS study, which is longitudinal monitoring and lung function with the colleagues that I mentioned. And then just briefly mention the other modalities that have been mentioned in other talks, parametric response mapping, these quantitative CT methodologies that can look at, these are better for cross-sectional assessments, look at air trapping indices that would be otherwise hard with the naked eye, and other toolbox techniques, hyperpolarized xenon MRI, forced oscillometry, nitrogen breath washout that are being investigated by the pediatric group, the Transpire group, and other adult groups. So very briefly, since we're running low on time, that a couple of words about treatment. Okay, so we know that the lung response is almost always worse than other organs, therefore a different approach is needed. And I want to posit that the goals of therapy, that we have to move beyond nihilism. I think we can move beyond nihilism, that the goals of therapy really should be to restore lung function as much as possible, okay? And not be satisfied with it just being stable, okay? We do want to prevent further lung function decline, and we want to preserve quality of life, okay? And that is a patient-centered goal, and every patient, needs to have this discussion with their provider about do they actually, what the pluses and minuses are. So yes, we want to target the chronic GVHD pathways, including fibrosis. Not a lot of good evidence, but I want to point out that there is one RCT that actually shows an improvement. That is the use of inhaled corticosteroid and long-acting beta agonist only. Okay, the FAM trial did not show that. The FAM trial just showed stability. Okay, so, but what I do in my clinic is I usually use FAM with the bronchodilator plus minus prednisone, and now there is a choice of the other FDA-approved agents. There's been a smattering of clinical trials that have come out. So, as was mentioned before, in a previous discussion, the risks of systemic immunosuppression we know from prednisone, and I also want to remind people that azithromycin was associated with a risk of hematologic relapse and malignancy in a randomized clinical trial. So, and does this question of does upfront immunosuppression change FEV1 trajectory? And we have been looking at this in our prospective cohort, and with almost 100 patients prospectively followed where they got FAM or FAM plus immunosuppression of any combination, prednisone, bel, ruxolitinib. It seems like IST maybe does a little bit better, but not by too much. And that the people who tended to be started on immunosuppression were those patients who had a lower FEV1 to begin with, probably more symptomatic. But if you looked at both groups, FAM or FAM plus IST, at the end, at 12 months, a third have improved a little bit by 5%, a third have declined by greater than 5%, and a third are right in the middle. So really, it's this is where we are at with our therapy, and it's impossible without a randomized clinical trial to actually know whether your systemic therapy is efficacious in the long run or not. Okay, so I'm going to propose in my last minute a stepwise approach for early BOS that leverages this home spirometry data, that we should have, an adaptive approach where, particularly for early disease, where it's really mild, the patient's not symptomatic at all, they're like, I feel totally fine, give them a home spirometer, start them on ICS-LABA, have them do their home spirometry. If they progress, and you will know this within the first 4 to 6 weeks, if they progress, bring them back in immediately, start them on prednisone, FAM, and whatever new agent that you have in trial, or the next line therapy, okay? If they are stable or improved, so a third, you should expect some to actually improve. They continue on with their ICS-LABA. If they get a complication or they decline by their home spirometry, put them back, get them back into your systemic therapy arm. And then just want to mention the pulmonary antifibrotics, pirfenidone. This was just published for long-term use, and there was a new agent out that was just FDA approved, nerandomist, a PDE4 inhibitor that is much more potent than this, that I think we should be considering for our patients with BOS and other fibrotic GVHD. So the take-home message is early detection is improving, much more needs to be done. It should be coupled with evidence-based treatment, and we've outlined some research objectives in this statement. And I want to make a plug for this multidisciplinary approach. I think this is just a theme from today. We have organized a consortium around this topic, and would be very happy to hear from anybody who wants to learn more about GVHD or come to our research conferences. So acknowledge all the people that I work with and the patients, my funding sources. Thank you. Okay, lung transplantation. Yeah, we chatted about this last. Okay, so end-stage lung disease from BOS, yes. What are the indications for lung transplant? They are going to die within 2 years, but it's their only organ system. They have to be on less than 20 milligrams of prednisone a day or the equivalent. Like, not a lot of other stuff going on. Have good social support and have the potential to rehab. You have to have a BMI of greater than 18. Like, you can't be losing weight, which is tough because the sickest patients cannot get there. Yeah. And each lung transplant program has its own kind of aggressive, threshold for jumping on a patient. I actually have a patient who probably went to lung transplant today because he's young, he's 24 and has no other organ problems from, other GVHD.
I have a question. First of all, of course, fantastic presentation because give us hope, that we can really have path forward. One comment, 2 questions. One comment, just this budesonide beta agonist studies enrolled much better patients than FAM.
Yes, it did. That's right, because in France, they do their PFTs every 3 months religiously. Patients don't complain, they all do it. So the median FEV1 into entry of that trial was 65, whereas in FAM it was 48.
Right.
Yeah.
So it's hard to...
Right.
But, and then two quick other questions. One, half of your patients with BOS didn't meet NIH criteria for BOS. I'm just curious, how did you make diagnosis of BOS for those? And the other one is that your diagnosed patients with BOS were fairly early, mild or maybe moderate. Did you have any indication that they did do better on treatment than you would expect for BOS?
Okay, so the first question, how did we make the diagnosis of BOS if they didn't meet NIH criteria? So it was basically, it was done at 3 centers. For me, it's if they actually have a more than 10% decline from their immediate prior or their baseline. There's evidence of obstruction. There's some subtle things on the PFT beyond the scope of this lecture that I look at, okay, that having to do with like the lung volumes and the mid-flow rates, a compatible clinical scenario, and any CT findings of air trapping. So if you see air trapping, which often is like an early sign, it's very subtle. Then it's like, well, okay, you don't have anything else. And sometimes you bronch these people and they don't have any parenchymal stuff. My colleagues at Stanford, they are using PRM. They are actually using PRM to diagnose BOS now, if they don't meet NIH criteria.
Okay.
Yeah, and also, I mean, Greg Yannick, he's the PI of the PRM study at Michigan. They're also, sort of on top of that. So, and also there's atypical criteria where you have symmetric decline in your spirometry, the FEV1 NFC, without a change in your total lung capacity. And that is actually a known phenotype for airways obstruction that is well described in COPD. Okay, then your second question was...
Or just those who were diagnosed, they were pretty early, so did you have any indication that they're doing better?
Okay, so I haven't done the deep dive into those particular 20 patients, but when we looked at the entire cohort of patients also that were enrolled into the BOS cohort in that ATS analysis, there really wasn't a correlation between, sort of a little counterintuitive, your level of FEV1 and your overall trajectory at 12 months. It was equivalent. I mean, it didn't actually change. So, we're waiting on more patients, and we got to do a sort of deep dive on, what did that have to do with? But I will say that there is a response, there is an early response that is often ignored at 1 month. Okay, this is why all the clinical trials where they say, okay, don't monitor until 3 months. I disagree with that. I think you should actually, I always have my patients come back within 4 weeks. And they do feel better. Some of them actually feel a lot better just on the inhaled steroid and beta agonist.
Okay, thanks.
Dr. Chang, there's a question online for you. The question is, could you discuss your criteria for adding an antifibrolytic?
Oh, for adding an antifibrotic. So the antifibrotic we have at hand right now, pirfenidone and nintedanib, I would add it, number one, if people cannot tolerate the prednisone, ruxolitinib, or belimositil. And if there's sort of evidence of decline, or if they're in this chronic phase where they're like, I don't want to take those immunosuppressive medicines and I want to just feel better, then I do start them. I have some long-term patients with FEV1 of 30, 40%, pretty impaired, who have started on it and do actually feel better, which is what we showed that the Stop BOS trial showed. It's not for everybody because you have to take a lot of pills and then there's GI side effects, but it still needs to be monitored. Yeah, I think the new one that is just FDA approved, that is promising. That is probably more promising than the pirfenidone, but it's not gonna work overnight, unfortunately. It's just, those agents definitely people have to be patient with.
Wonderful talk. Any concern regarding conditioning regimens with subsequent risk of BOS?
Really good question. We've never really been able to parse that out, though historically busulfan has been identified as a risk factor. The Hutch data, not able to replicate that, but that has been shown at least a couple of historical studies. TBI is a risk factor for early acute lung injury, but we've never really been able to show that in the BOS cohort. And in fact, early acute lung injury is not really a robust risk factor for BOS because those patients often don't survive long enough. But if there is some indication of lung dysfunction, it's probably reflective of something that happened or the toxicities of the conditioning regimen. Yeah.
Just for pirfenidone, since you had mentioned it as an alternative to some of the immunosuppressive options, do you see them as exclusive? Could they ever be used together? I know there's no data, but just
yes.
do you see it as only being a one or the other?
Well, actually, I mean, pirfenidone in combination with something like ruxolitinib would actually be, sort of make sense biologically. And what I didn't show is that in the STOP-BOS study that my colleague at Stanford did, there were actually responses in the skin. There were good responses in the skin long term. To Emily's presentation, there wasn't a gradation, there wasn't like a distinction between the fresh skin GVHD and sclerosis. I suspect that it probably helps some sclerosis.
Thank you so much, Dr. Zhang.
So it's our next presenter is Dr. Kyulim Lee. Second time today. Dr. Lee is an assistant professor in the Division of Pediatric Dentistry at the Ohio State University College of Dentistry. She is a pediatric dentist at Nationwide Children's Hospital. She is a board-certified pediatric dentist and an NIH-funded researcher. Her current research examines bacterial genetics, genomics, and microbial ecology as they relate to oral and systemic health, with a particular focus on the oral microbiome in pediatric patients undergoing transplant. And the title of her presentation is Oral Care. No, it was earlier, right? It's a different one. It's the oral microbiome. Sorry, I was reading your title from the patient's room. The oral microbiome in pediatric hematopoietic cell transplant recipients. And thank you, Dr. Lee. Come on.
All right, thank you guys for waiting for the best talk of the day. Just kidding, it's the last one, so I'm sure you guys are ready to go to cocktail. Let's see. I think it looks different. Oh. Oh, the green button. Oh. Sorry.
The famous green button.
Yes, I stayed away from the green. I went to the red directly. Anyways, thank you guys for the opportunity to be here. As you guys know, it was actually Dr. Jacqueline Mays from the NIH that was supposed to be here today. But of course, with the federal restrictions with traveling, she couldn't be here. And I took the opportunity on behalf of her to take this spot. And so it's a true privilege to sort of stand here, have a chance to connect with you all, and give you this presentation. So I'm going to share just a story about my work and how I got involved in working with a very special population that's very dear to me and I'm sure to all of you guys, and that's also very central to my clinical practice. So at Nationwide Children's Hospital, we have a division of dentistry that is very integrated within the hospital. And I know this is pretty unique. And the level of involvement, at least, we are very active across across the hospital and helping manage some of these patients that are admitted for their medical condition. This graph sort of shows, it's a little difficult to see, I'll admit, but sort of shows all of the services that requests consultations of our specialty. And one of the divisions that consult us at the highest level is the hematology, oncology, and bone marrow transplant team, and we receive about 135 consults per year. And as my introduction, I'm an oral microbiologist by training, so caring for these patients and sort of looking and witnessing firsthand their oral complications that's related to their systemic health, that really got me thinking, what the role of the microbial communities could be in these patients that affect their oral health and how that might impact their systemic health. And in particular, I got particularly drawn to working with patients with hematopoietic cells transplant. And as we know, hematopoietic cell transplant process, it's a great curative treatment for various pediatric cancers, but it's also associated with various complications. So these patients are severely immunocompromised for long term, during their chemotherapeutic regimen and their grafting and engraftment process, and even post-transplant period. They're at high risk of infections, but they're also susceptible for treatment-related toxicities like oral mucositis. And we know oral mucositis is one of the most debilitating side effects in patients that undergo cancer therapy. These patients usually need additional days of opioid usages when they're admitted. They are on total parenteral nutrition, altogether increasing their hospitalization days. Additionally, these patients are at high risk of infections, specifically systemic infections like bloodstream infections. So working with as I mentioned, our hospital, our division gets consulted on the heaviest by the hematology, oncology, and bone marrow transplant team. And this is one of the little patients that I saw pre-transplant to help provide dental clearance. And I actually ended up enrolling her in my clinical study. But, just being on the floor and seeing how just their basic quality of life is affected. They can't even eat, drink, swallow their own saliva. And naturally, I started wondering about how the oral microbial communities could be contributing to the progression and the severity of oral mucositis, and if there was anything that we could do there. So as we know, oral mucositis begins with that direct chemo and radiation therapy causing that direct injury to the basal epithelial cells. This initial phase, there is that surge of oxidative stress that activates that innate immune response. Then we have the activation of some inflammasome pathways and activation of pro-inflammatory transcription factors like NF-kappa beta. That leads to the production of pro-inflammatory cytokines that we see here, like IL-1 beta, IL-6, TNF-alpha, that leads to that local tissue damage. Then there's the self-perpetuating feedback loop that causes this to progress and leads to that mucosal tissue damage and that ulcerative lesions that you see clinically. And where I want for you to kind of focus on is this area right here, where this point of barrier breakdown, where that mucosal integrity is now compromised, and these sites become susceptible for bacterial translocation to the bloodstream. Dr. Shaw earlier did a great introduction on the importance of microbiome in human health. And human oral microbiota is no exception. It's a highly diverse ecological, complex ecological system, and we have identified over 700 bacterial species to date. And just to put things into perspective even more, 1 cubic millimeter of dental plaque contains about 100 million bacteria. Just like the gut microbiome, this balance of health, this balance of these oral microbiome and health really helps maintain that, overall health. And when you start seeing that disruption, which is like oral dysbiosis, that could be linked to various systemic diseases. This illustration is perfect in that it shows potentially the role of specific members of microbial species that have shown to kind of impact human health in general, such as cardiovascular disease, diabetes, rheumatoid arthritis. And they can do, some of these oral microbiota species could do this by, one, directly translocating to that distant site and causing issues, or secondly, indirectly modulating host immune responses and the immune system. So, to highlight here is that the oral microbiota can play an important role at the systemic scale. It could either maintain health or, be the drivers of some disease. So what does the literature say about the oral microbiome in the pathophysiology of oral mucositis and bloodstream infections? Now, several studies have reported the disruptions of the oral microbiome in patients undergoing hematopoietic cell transplant, and this to be associated with affecting the prevalence and severity of oral mucositis. But the majority of this research is, of course, done in the adult population, and despite the high prevalence of oral mucositis in a pediatric transplant population. And even more importantly, several of these oral microbial species grouped into virulence group Strep have been implicated in bloodstream infections in this population. But current ways that they assess this is culture-based at the hospital, which we know that these aren't really high resolution enough to distinguish between different oral microbial species. So, to date, no study has really investigated the role of the oral microbial communities as oral mucositis develops, and in the pediatric transplant population, to ask that key question: can the oral bacterial species that have translocated to the bloodstream through that compromised mucosal barrier be the cause of the bloodstream infection? So to answer this questions, I launched a longitudinal clinical study involving pediatric transplant patients at Nationwide Children's Hospital to characterize their oral microbiome as they develop oral mucositis and bloodstream infections. And this is a study that is still actively going, and I'm actively recruiting right now. But all patients that are undergoing transplant at our hospital were enrolled, and I evaluated them and saw them at 4 different visits, at minimum. First visit being before transplant, so preconditioning time period. Visit 2 was around post-conditioning, so around when they received their transplant. And visit 3 was around the time period when oral mucositis is reported to be the worst. And visit 4 was post-engraftment, right before discharge. And at every visit, I did a clinical exam. I also sampled different sites of the mouth as well as the blood, and also collected these samples and then took them to my lab to do some 16S sequencing to look at the oral microbial communities. And at every visit, like I mentioned, I did oral sampling that involved different surfaces of the mouth. So a lot of the literature that's been reported, if there are with children, typically they just use saliva. They ask them to spit into the tube and then they sequence that. And for convenience, but I'm a pediatric dentist, so I can work with my patients to get these samples. And typically after that I did their mouth care, and so it was sort of a fun experience for them too. But basically, I sampled supragingival plaque samples. I sampled also along the buccal tissues as well as the tongue. And every time I visited the patients, I also collected blood. And when the patients were suspected of bloodstream infections, I repeated their oral sampling. With my clinical exam, I looked at the level of plaque covering their teeth surfaces and looked at their gingival presence or absence of gingival tissue inflammation, and looked at the level of coating that we see in the tongue. And of course, I graded their oral mucositis as well as scored their pains. And I'm going to start showing you some preliminary data that I have on 31 subjects so far on this part, clinical data as well as the microbiome data. So what we observed were, higher grades of oral mucositis was seen compared to baseline, of course, as they underwent transplant process. And consistently during those time period, we saw an increased report of pain. And we know there's literature evidence that, good mouth care decreases the severity and prevalence and severity of oral mucositis. So evaluated whether they were able to practice any oral care while they're admitted in during their process. And you could see that by visit 3, but majority of our patients were just unable to do any mouth practice. And a small number of patients were able to do, using toothbrushes without toothpaste because the taste was irritating, or toothets. And of course, I looked at the way that they intake nutrition, and you could see that by visit 3, majority of our patients were unable to tolerate any feeds by mouth, and a majority of them were on total parenteral nutrition. In our patients, I saw increased levels of plaque covering their teeth surfaces compared to visit 1, as well as their tongue surfaces. And I saw somewhat of an increase in gingivitis in these patients. And when we start looking at the oral microbial communities in our patient population, this is that representation showing the communities we found in the oral cavity as well as the blood of all of our subjects. We saw that different sites of the mouth harbored different oral microbial communities. But what's interesting here is the blood microbial profile showed considerable overlap with the oral microbial communities we found in the different sites, suggesting a possible oral origin. I also wanted to see if there were changes in the microbial communities over time across the oral sites. You can see that in the 3 oral sites, the buccal mucosa, tongue, and the plaque, the ellipses do not overlap substantially, indicating that each visit had a distinct microbial profile and that the oral microbiome underwent substantial restructuring that didn't really go back to baseline if you look at visit 4 and visit 1. And while all sites showed pretty significant changes, we see bigger changes with minimal overlap between visit 1 and 3, which shows that microbial community composition changed significantly between those time points. As mucositis develops, we also saw clear changes in the microbial communities across all the 3 different oral sites. What's interesting here is the wider disbursement of these data points, especially if you look at like buccal mucosa and the tongue, which tells me that we're starting to see some of these communities that we normally don't see in these patients as the mucositis progresses, and we see a more drastic change in the community profile in buccal mucosa and the tongue, which kind of makes sense compared to the plaque, as those are the tissues where you'll start seeing more of that inflammation and that immune responses. Whereas the plaque, was a smaller scale difference. So what's actually driving these shifts? What kind of microbes are emerging and disappearing or being reduced as the mucositis progresses? And when we compare mucositis grade 0 versus 3, you can see that the health-associated genera that belongs to like Streptococcus or Veillonella, these become depleted as oral mucositis progresses. And when you look at specifically what we see in mucositis grade 3, more of that gram-negative genera like Prevotella, Fusobacterium, Capnophagium, those organisms were more present as mucositis progressed. I'm starting to analyze the data now. This was actually something I received this week, which this is a prelim sort of analysis that we did. But now I'm starting to look at the species level. What is driving this mucositis development, and what does that look like in the different sites that I sampled? And just take big picture here is that there's definitely bigger differences. There's more depletions of the oral organisms that are present in the mouth as mucositis progresses. So there is definitely that restructuring, that disturbance, that dysbiosis that we see. And then when you, in terms of looking at what species are present at higher levels, that number is much smaller, but potentially, these might be the ones that I should be looking at that might be really contributing to the progression of oral mucositis. And one of the things I wanted to mention that it was really interesting is this Burkholderia capaceae that's in the, that's one of the species that was not upregulated, but present at higher levels at mucositis grade 3. One of the patients actually had that in the blood culture, in their blood culture. They had a bloodstream infection, and that's what they cultured out. And what I found in my data was that this was actually recoverable in the oral cavity of these patients. And that is not a normal oral organism. This is an opportunistic organism that's normally causes hospital, infections in the hospital setting in immunocompromised patients. And that is not a normal resident in the oral cavity, but it was interesting to see because I do think, things are changed so much in the oral cavity, it's disturbed, and these kind of opportunistic pathogens sort of, maybe that's the site where it started, with the contamination and then went to translocated to the bloodstream. We don't know yet, but I'm hoping, the more patients I enroll, I'm able to ask that question. So let's talk a little about bloodstream infection in general, and I also looked at the bloodstream infection occurrences in my patient population. So currently there are 2 types of BSIs that the hospital tracks. As you guys know, it's CLABSI rates, and then and the mucosal injury, so lab confirmed bloodstream infection, which results from the mucosal barrier injury. We know, though, that all of the hospital efforts or advancements have been focused on decreasing that CLABSI rates, which all involves line maintenance protocols, on nursing education, et cetera. But this really doesn't alleviate the bloodstream infections that are caused by that breakage in that mucosal barrier. So there's a lot that we can look at in that aspect, and there's a need. So this is actually even more of a preliminary data from our 10 subjects, but I evaluated the bloodstream infection occurrences in my cohort, and by looking at the hospital culture reports. And in our 10 subjects, I saw 6 events of bloodstream infections with one patient experiencing 2 episodes. And again, very preliminary, but when I look at the timeline of oral mucositis development with bloodstream infections, I see that, at least in this case, the majority of our patients were experiencing oral mucositis prior to their bloodstream infections. Now, this leads to a very important question, and one that I'm very interested in, is whether the oral cavity can be a source of bacteria that causes bloodstream infections. And I'm hoping, my study is able to answer this with more certainty. But current standard for diagnosing bloodstream infection is culture-based, but that naturally just selects for those organisms that are able to grow in a lab setting. And oral organisms especially are too fastidious to grow in those settings. And so but even then, the blood culture still identifies oral bacterial species, but the level of sequencing they do at the hospital is not really high resolution enough to be able to distinguish between these oral species. So we did 16S sequencing in my samples of blood samples and their corresponding oral samples to look at the microbial profile and to see if there is any overlap. And what we saw, it was when the blood culture reports identified only one single organism, I did identify additional DNA in my blood sample. So for example, in patient 1, we recovered not only strep mitis, but also another common oral organism from the Vionella genus. So it was polymicrobial. And of course, after this, I want to be able to know for sure that the organisms that we are seeing in the blood matches the exact one that's in the from the oral cavity. And to do this, we used a high-resolution amplicon sequence ASV analyzing pipeline that's able to distinguish between like single nucleotides to be able to, and they use this tool often to be able to track strain level and do strain level analysis. And what I saw was that, at least in the preliminary data that I have, that some of these do share that same ASV sequences, suggesting, high probability that the oral organisms that in the blood that were recovered did originate from the mouth. So a couple conclusions. In my patient cohort, I'm seeing oral health changes as the patients undergo transplant. We see higher rates of mucositis, overall decrease in the effectiveness of oral hygiene, frequency as well as the effectiveness. The oral microbial communities changed as oral mucositis developed. I'm doing species level analysis now to hopefully be able to see if I could find predictor or those risk organisms in this patient population. And with some of the analysis I've done, I'm finding that bacteria is identified that are in the blood. I'm able to match it to those that I find in the oral cavity. I'm still recruiting my patients, so this is a study that actually just got funded last year, so I'm still going, and I have a long way, but I'm hoping in the future that I'm able to isolate some of these oral organisms from the blood and actually look at their genomes. I'm a microbial geneticist by training, my background, so I'm interested whether, these strains that ended up translocating to the blood, are there specific species and more strains that are better at doing this, or is it just a lump of bacteria? But if it is a specific species or a strain, and this is like hypothesis, you just start thinking and imagining, but basically these organisms might already have a lot of antimicrobial resistance genes. These patients are heavily treated, right? So I'm just interested in seeing how much of their genome might have changed in comparison to like a reference strain. And I see, consistent to the literature, oral mucositis is a risk factor for bloodstream infections. And bloodstream infection prevention strategies should not only target line maintenance protocols, but also one that targets oral mucositis prevention. And I did not include a slide, but red light therapy, so photobiomodulation therapy has been part of the supportive oral care guidelines for the adult population, got added to or is endorsed by the COG, I think a year or two ago. More of the pediatric hospitals are adopting this. I sold the idea to my BMT team. And when you talk about it enough, they listen to you, right? So they ended up buying the equipment, and now we're in like the implementation process. But one of the things, just clinically impactful could be, some questions I could ask is, with this red light, when you don't have the mucositis, then, can we see a downstream decrease in the bloodstream infections? So that is some of the thoughts I have. And so I have my acknowledgement slide, which I think is one of the most important slides in a research presentation. And number one, that I want to thank is the patients, the little kiddos that allow me to come in, and those parents that are just so willing to participate in a clinical study when they have so much going on. And that little boy on the upper, right side on your end, as soon as I walk in, he would always open his mouth for me. He's so cute. And I always check if he had mucositis, ulcerations, and these they're there for like 30, average of like 20, 25, and then if there's complication, obviously they stay longer. But they're isolated in that room, and they really appreciate when you guys visit. And sometimes I'm there just to do my exams, and I'm just in the room talking to the parents. And some of them, still text me, and I follow up with them actually in my dental clinic because some of them do experience GVHD, so I'm keeping an eye on some of them. And of course, my funding sources, and then all of my collaborators at Nationwide, Dr. Bajwa, Raj, he's been great bone marrow transplant physician that's been a great partner in this work, and then the coordinators, and obviously all my science team, and you guys for sticking through and just being here and sharing, the passion. Thank you.
Okay.
We'll start with your question.
would
Thank you
like-
so much for an excellent talk, Dr. Lee.
I have two questions for you. Did you ever stumble upon like a time where you cultured something in the blood? Because you do a more advanced sequencing, I guess, right? The way you're detecting organisms in the bloodstream. Did you ever have an incident where it wasn't detected by the lab, but by you?
Yes. So, so meaning like by the lab blood cultures, and then that I done. Yeah, there are. So one of the ones, there's two problems here. One is sometimes it is cultured, and then I get the blood after they get the antibiotics. So I don't. It's not in my blood, whatever that they had detected in the lab. So I had to go through some optimization process. But secondly, to answer your question, more specifically, So that one example where they identified a species from like strep viridans group, they call it, and then but my sample showed additional oral bacterial species that were present. So
oh no, I mean like when I tell patients like every time you brush your teeth, you become bacteremic transiently, and if you're immunocompromised,
yes,
right? Like, do you ever detect it at subclinical? Like they're not sick from it, but it's bacteria in the bloodstream.
Yes. So I'm looking at my routine, the blood that I collected routinely, and we do have bacterial DNA there, and it is the question of yes, there's going to be transient bacteremia all the time, and what's interesting is some kids do get bloodstream infection and some don't, and they're all neutropenic. So that's another question that that I could.
About the T cells.
Yeah. But yes, I do. There are, especially my routine sampling of the blood, I do see quite a bit of, at least right now, that I'm detecting bacterial DNA, either from the oral or the gut.
And
but more from the oral, which is interesting.
Is it the same one over time in the same patient? Like, I guess you do 4 samples.
Yes, it's not clear right now. At least the analysis that I'm doing, I think we have to expand my, I have to look at more patient samples. But yes, it is not a clear pattern where I see like one at a lower level and then it starts increasing, and then, this patient has like fever, for example, and then has a blood sugar. Yeah, it's not that clear yet.
And then did you need to sample all the 3 areas, or did you find consistently, like when you were doing the swabs in the different regions of the mouth? Did you see them on, like, if you detected a bacterium, for example, like, did you detect it on all 3 regions the same, or do you still need to continue obtaining it at every site?
So if I detect it in the blood, did I see it in all 3 different sites of that patient's mouth? Yeah. I will say for the Burkholderia capacia that we recovered, it is everywhere in the kid's mouth, but with other subclinical, bacterial DNA that I find in the blood, if I see where it originated from the mouth, it's not in all of the sites. It's sometimes in the buccal mucosa, sometimes in the tongue, sometimes in the teeth. So,
and there's no one bad area, like the worst one out of the 3. There's no like.
No, I know, and that's why I did different sampling, because it could be from the mucositis, or it could be just from the gingival crevice. It could be from the tongue. So there's a lot of sources, and I wanted to get very granular in finding that where it could have originated. If it is the oral cavity, then where. So, but at this time, not too clear. Yes, but I've just started analyzing my data, so.
There was one question online asking about gum transplants, either from autologous or cadaver for GVHD patients.
So gum transplant is a little bit tricky. I have I think gingiva, right? Gum transplant. Gingival transplant, like in recession, patients that have recessions.
Yes.
Yeah.
Yeah.
So it's a little tricky. I don't know what the success rate looks like in the adult population, but especially when you're in your immunosuppressed state, you need those immune cells to accept for healing, So I don't know how it would look like if patients that are still on steroids and then they're immunosuppressed and they get that. I don't think it's most likely going to be rejected, even if it's your own tissue, because usually for gingival recessions, they take like the palatal tissue and then they graft it. But you need to have those immune cells to be able to heal, right? So I don't know how it looks like in the adult population. Not something that I would want to try in our pediatric patients. They don't really need it. But secondly, it really depends on the immune system. So I would be very cautious unless you're very much out of your transplant and you have obviously no GVHD symptoms. That's only one I would consider. Yes.
That's amazing work. Did you have a chance to compare the kids' oral microbiomes with their parents' oral microbiomes? And then another question would be, when they go home, how does that change, and would they acquire any more of their household members' microbiome in their mouth?
That's a great question. So the collaborator I'm working with, Anne Griffin, she is actually the pioneer in one of the oral microbiome studies that looked at that acquisition. So getting that, how much of that relates to the kid's oral microbiome with the parents. And she also like compared with like genetics, so siblings that were, or like twins that were adopted separately, to look at if there's that genetic factor, or is it the household factor, right? Mom to child or child to child, that is much stronger. So it is, they say, they say don't kiss your kid when they're younger, like don't share whatever, but it happens. And there's a huge resemblance between household microbiome. And so the kids that I see here, diet is a big driver of the oral microbiome. We're going back to talking about nutrition, but especially the oral microbiome, and what you eat, drink, that really affects it. Dental caries, number one reason is sugar. You could brush all day, every day, but if you're sipping on pop all day, you are going to get decay. So unless you have the health associated and that's established. But anyways, so these kids, I'm very interested, because right now it's longitudinal, but I'm not looking at them like a year out, 2 years out. And as I'm seeing these GVHD patients come to my clinic, that was a question I've been having. Like, I have their samples from early on, and I'm seeing them a year or two out. Are they actually, how does that microbiome look like now that their immune system is flared up again, or even just going home and their health and they don't have any symptoms? Now they're exposed to all these other factors. So yeah, that's a very interesting question, and something I'm also wondering how that might affect it, because it will. So.
Any other questions for Dr. Lee? Wonderful. Thank you so much, Dr. Lee.
Thank you.
We're going to have some closing comments. I think that on the patient side, they're just finishing up with their sound bath, and then they'll be joining us shortly. So we'll wait for that.
Now he's septic. Yeah. He's his own septic.